Hello guys, can you see me and hear me? Am I audible and visible? A very good morning, Joycey Mohan. I hope I'm audible and visible. If so, say me a hi and a hello and a very good morning. Let's start the marathon for pathology. I'm going to keep it short and sweet. Very few information which I want you to remember before the D-Day. And I want you to keep on answering as well so that it becomes a much more of an interactive session and not a didactic session. So if you look at NEET PG anywhere, you know that these are three classification. Hematology is something which is important, especially few classical scenarios, few important points to remember, few keywords to search for in a long answer. Like if I say massive splenomegaly, in case of a leukemia or a lymphoma, I want you to only remember two things, CML, hairy cell leukemia, that's all. Because these are two things which will present with massive splenomegaly, right? Like that keywords will go with hemat. Systemic path, very important few topics which is required from an exam point of view, we'll cover that. Most of them think that general path is something which is totally separate. It's not. It's very much linked with systemic pathology, right? Let's say that I'm having a patient with a chronic inflammation. TB can happen anywhere in the body. Donor granulomas, liver, it can come from hepatology question. It can be interlinked with medicine. I am sure that Dr. Santosh has taken your class for your medicine, and there's lots of integration which can happen, right? So general pathology is a little bit related to systemic pathology. Quite a few of systemic you will definitely read over the period of time when you go to your other subjects. And obviously there'll be pinpoints there relating to pathology as well. Hemat, like I said, we're going to go with keywords, right? If you're ready, put say you comment ready and let's start the show, right? Good morning, everyone. I hope you're doing good. Fine. So very simple things. I'll be asking questions, leading questions. I want you guys to answer. If you answer, it'll be much more of interactive. It won't be boring. I'll take 2 hours, give a 5-10 minutes break, and then let's go for 2 more hours, right? Just 4 hours before ophthalmology sets in. We'll definitely wind up with pathology, right? Only Sudhir is ready. Not everyone is ready, right? I want everyone to be ready. Okay, let's start. Okay, let's go. You'll have the annotated PDF immediately, not like yesterday. I'll send immediately after the class to the content team and they'll upload it there, right? Let's go. Great, amazing, fine, perfect. So first thing, necrosis. We're going to start with a very simple concept of necrosis, right? So when you look at necrosis, I'm going to obviously look at solid target infarct, maintained architecture. It's going to be coagulated necrosis, right? What is the most common cause of coagulated necrosis? What do you think is the most common cause of coagulated necrosis? It is undoubtedly ischemia and infarct, right? So the maintained architecture, which means if it's a myocardium being destroyed, I will not be able to identify it's a myocardium. I'll be able to identify it's a myocardium even after it's dead. That's the important thing for myocardial necrosis or a coagulated necrosis, right? So in microscopy, what I'll see is I'll see only pink cells because there'll be blue color, everything will be gone. I'll be seeing only pink color there. That's the first thing. I won't be seeing any nucleus. What happens to nucleus in case of coagulated necrosis? Again, you guys know, any necrosis, we have 3 changes. Can anyone tell me the nuclear change in necrosis? This might also come as in one liner. We have, perfect, we have pycnosis, we have karyorhexis. Rhexis means breaking. And finally, we have karyolysis. Lysis means everything is gone. Everything is gone. So there'll be no blue color in case of any necrotic area. I won't have any blue color. It'll be predominantly pink only, right? The maintained architecture, which means I can see that it's destroyed. I can see a heart, it's a dead heart. I can see a liver, it's a dead liver. I can see a kidney, it's a dead kidney. That came once in a PYQ in the NEET. We call them ghost cells. Ghost cells will be present, which means I know it's a dead tissue. If ghost cells are present, I'm going to think of coagulated necrosis. As simple as that, right? Let's go to the next one. Liquefactor necrosis. What comes to your mind first? Whenever you think of liquefactor necrosis, obviously it comes to your mind, it's going to be infarct of the brain, right? By default, I'm going to think of brain infarct or the CNS infarct, right? Anything involving the CNS, if it's infarcted, it's going to be liquefactor necrosis. There's one main difference which I want you to remember between coagulated and liquefactor necrosis, mechanism of action, because that will help us to remember the next 2 causes. The mechanism of action for liquefactor necrosis, enzyme activity or enzyme activation, like a lipase. Once lipase activated, it will destroy the brain. Brain is full of lipid. It's very soft, made of fat, right? So that's the reason when I have abscess, there's lots and lots of WBCs. Lots of enzyme activation. When you have gangrene is nothing but gangrene plus infarction or suppuration. That's when wet gangrene. Again, I'll have lots and lots of WBCs. And one more thing, it's lipase. So what's one more disease which you can have liquefactor necrosis? I'm sure you know that. As a classical surgical history, patient who's an alcoholic comes in the middle of the night with abdominal pain, severe abdominal pain, and perfect, that's your pancreatitis. So whenever you have a case of pancreatitis, I want you to be a little bit careful, because pancreatitis will have liquefactor necrosis in pancreas, because pancreas does not have fat, right? So one more condition which will also have liquefactor which will also be there in pancreatitis, omental tissue. What will happen to omental tissue in pancreatitis? Everyone, come on guys, comment. Only Cat and Sudhir is commenting. More. It's just simple things. So just listen to me. You need not write down anything. The entire PDF will be with you at the end of the session. Just go through. Interact more, so you make more mistakes, you learn more, right? Perfect. You will have in same pancreatitis, if it's an omentum, you will have fat necrosis. Fat necrosis in omentum and liquefactor necrosis in case of an pancreas. Perfect. Amazing. So since liquefactor necrosis destroys everything, if it's a heart, I cannot identify it's a heart. If it's a GI, I cannot identify it's a GI. So which means ghost cells will be absent. When ghost cells are absent, I think of a liquefactor necrosis, right? Perfect, great, right? So that's one. Caseous. Caseous is only one guy. Caseous, anywhere, wherever you see in your life, caseous necrosis is equivalent to tuberculosis. That's all. Unless proven otherwise, it's TB, fine. Caseous necrosis, if there's any old examiner who comes into the exam scenario, this was a subtype of coagulative necrosis. Okay, this was a subtype. It's not anymore. We have put them as differently. The only difference in microscopy is caseous necrosis will be a granular necrosis compared to a coagulative necrosis, right? Can anyone give me just one more finding or one more disease where you can see caseous necrosis apart from TB? Let's interact. Come on. RRR, reset, restart, refocus. Amazing name, right? Perfect. You have few more infectious disorder where you can see caseous necrosis. Perfect. Histoplasma you can see. And if at all it comes coccidiomycosis, you can see them, right? So histoplasmosis and coccidiomycosis, you can see the classical history. You must have read in microbiology the desert fever and everything, right? You'll have the history along with that, or an immunocompromised person. Even an immunocompromised person, I would first still think of tuberculosis only. TB, then others, right? Simple thing, correlating with microbiology. What's the stain for tuberculosis? This at least you have to answer. The stain for tuberculosis. The simplest stain what you've been doing for lifelong. That's your acid-fast bacilli. Oramin, rhodamin is also there. But acid-fast bacilli is the commonest stain which has been done, right? Perfect. Zn stain or an acid-fast bacilli? Yes. Okay, Zn stain. Great. I think I'll ask simpler questions so that more of you will interact, more of you will react, so it will be useful for us in the long run. Fine? Perfect. Fibrinoid. Remember, never forget, oid is equal to like. It's an fibrin-like necrosis. I will see fibrin in a vessel wall damage. So anything related to vessel, I will see fibrinoid necrosis. I want an yes or no answer. Can I call heart as the biggest vessel? Yes or no? Yes, Sudhir, you are absolutely right. Pan, not just pan. I want you to remember little bit bigger. Pan was a PYQ, right? Perfect. Vaginus also will have that. Kawasaki will also have that, right? Anything will have it. Any vasculitis will have it, right? Amazing. Yes, it is. So it's not just vessel, and if it's somewhere related to heart, that's where your rheumatic heart disease and Ashoff body comes in, because it's cardiac involvement, right? SLE, perfect, Shanavas, right? SLE, I'm going to have in vasculitis again, right? Type 3 hypersensitivity, any vasculitis, and rheumatic heart disease in case of an Ashoff body. And also, some of you answered that malignant hypertension. Again, it's related to blood vessel, right? The hyperplastic arteriolosclerosis and the onion skinning appearance, this also might come in an exam. Plus fibrinoid necrosis, you'll have them. Fibrinoid is fibrin-like necrosis. One important extra point, it might come as a new question. Fibrinoid necrosis in microscopy, they are PAS positive, periodic acid shift positive, because fibrin is also periodic acid shift positive. Like that, fibrinoid necrosis is periodic acid shift positive, right? Perfect, great. I want interaction like this so that we can make the entire 4 hours just go in a mind, right? Last but not least, fat necrosis. Fat necrosis, we divide them into two types of fat necrosis. One is traumatic. Guys, give me one example for traumatic fat necrosis. Other guy is enzymatic. One example for traumatic fat necrosis. Trauma-induced. Breast, FNAC, biopsy, gluteal region, injection, FNAC, biopsy. That's all. Any structure rich in fat which has trauma in breast parenchyma, after FNAC or in the gluteal region after an injection, you can have traumatic fat necrosis. Anywhere you can have, right? Simple example, correlating with pharmacology. Yesterday you read about pharmacology. Multiple insulin injection in this place causes lipodystrophy. Fat necrosis, that's all, fine. Enzymatic, we read in the pancreatitis and it's related to momentum, fine. Again, I want everyone to comment for this question. What is the normal color of microscopic color of fat? In a normal tissue, what will be the color of fat in microscopy? Fat will be pink, blue or clear. Fat will be perfect. Fat will be clear. But when this becomes necrotic, every necrotic tissue will become pink in color. Even a fat necrosis will become pink in color, right? Fat normally is clear, colorless. It becomes pink in color because of the necrotic change which happens, right? Triglycerides is there in normal fat, which becomes fatty acid. Fatty acid will be pink in color, right? Perfect, right? Those are the 5 things, right? So just one more correlation here. Why fat is clear? This was asked in the INACT exam because fat has been washed away. One more leading question to that. If fat is washed away and if it's clear, if I want to demonstrate fat, what section do I need? To demonstrate fat, to demonstrate a normal fat, what section do we need? What fixative is required? Can I do it in normal or others? Sindhu, definitely, you will get this PDF in the Telegram channel of PW, you will have it. We need frozen section, right? You need not write things. If you're good, if you're fast enough, write it. But I would say more interaction will help you than writing because the entire PDF will come to you, right? Amazing, guys, right? Perfect. Let's go to the next session, apoptosis. Just few points regarding necrosis. You can correlate and apply to this in anywhere where systemic pathology comes. Myocardial infarction, same necrosis. Pancreatitis, same necrosis. It will not change at all, right? Perfect. Okay. Apoptosis. So apoptosis is a programmed cell death which can be both physiological and pathological. You must have definitely seen some PYQs on pro-apoptotic, anti-apoptotic, right? A simpler way for me to remember is anti-apoptotic. It's not going to cause cell death, so longer life. So anything which has L, right? BCL2, MCL, BCL-XL is anti-apoptotic. It's an exception. See, exceptions are always problem for me. BCL-XS, that also has S. Maybe remember S for small. Okay, that's pro-apoptotic. Anti-apoptotic, longer life, so it stays for a longer time. And pro-apoptotic, shorter life, so maybe BCL-XS, right? Simpler way to remember this. Both of these proteins, where are they located? Are they located in the mitochondria, Golgi apparatus, lysosomes? All these are going to be located in the mitochondria. The inner mitochondrial membrane, to be very, very specific, this also came in a very old PYQ around 2016-17, which might be required, might not be required. They are located in the inner mitochondrial membrane. So that's what triggers, and we call all these as intrinsic pathway of cell death, right? Perfect. Just few words to remember regarding that. That's all fine. So extrinsic pathway of cell death or the extrinsic pathway of apoptosis is triggered by FAS ligand interaction. There was a question which was asked once. What is the CD marker number for FAS? There's FAS ligand, which is a TNF group of family. We have CD95, right? So CD95 is involved in the extrinsic pathway of apoptosis, and these guys are involved in the intrinsic pathway of apoptosis. Just remember them, both of them. Perfect. Both of them will go and destroy and finally cause cell death, right? So can I call this guy caspase dependent cell death? Yes, no, maybe. I can. It is, right? So these are caspase dependent cell death. There are possibilities you might have questions based on caspase. Even as INACT, we had questions based on caspase, right? Caspase 1, 2, 3, 4, lots of numbers are there. What is the caspase involved in the intrinsic pathway of apoptosis? Let's look at that one by one. All the caspases involved in the intrinsic pathway of apoptosis. Tell me the number. The number. Intrinsic pathway of apoptosis, we look for caspase 9. I'm writing CAS for caspase 9. Perfect. Great. Extrinsic pathway. Extrinsic pathways. Karthik, 3 and 6 are execution, right? Extrinsic pathways 8 and 10. Of this, you must have definitely read that human caspase if there's a question. 10 is in human caspase, right? Perfect. Then I have execution caspase. Execution caspase is 3 and 6. Just a way to remember, when you start working, it's very difficult. So bigger number. When I execute, I come to the top. Smaller number, less work done. 9, 8, 9, 10 are the initiator caspase. 3 and 6 are the execution caspase, right? There's one more cell death which involves caspase. What is that? Necrosis, necroptosis, pyroptosis, ferroptosis, which is the other cell death which also involves caspases. Other cell death which also can involve caspase. That's your perfect pyroptosis. Can anyone remember at least one caspase is involved in pyroptosis? This was the reason, kind of reason PYQ which came in the INACT, right? Perfect. It is your 1, 4, and 5. To be specific, if you remember 1, that's more than enough. But 1, 4, 5, all of them will be involved in case of an pyroptosis, right? Amazing. Great. Now let's go to stains. Like I said, general pathology is like a portal to understand systemic pathology. Fine. So there are few things here. I would first write what will be the color in microscopy, few things about the stain, and where it can be used. In a scenario where it can be used, right? What will be the color of microscopic color of melanin? Melanin will be brown. Melanin will not be black. Hair is black because of density of melanin. Melanin normally is going to be brown in color. We have Masson Fontana, we have Schmoller stain. This is a normal skin biopsy where in the basal layer you can see melanin. Basal layer is the normal location of melanocytes. This INACT had a twist from this. Masson Fontana is also positive for pigmented fungi. Obviously, when you have pigmented fungi, they are going to have Masson Fontana, right? Pigments, same. It's ultimately it's a pigment stain. So pigmented fungi also will be positive here, right? That's a thing. So can I use this in any disease? Will this be positive in melanoma? It will be positive in melanoma. It will be positive in most of the hyperpigmented lesion. In a hypopigmented lesion like vitiligo, it will be negative. Or an albinism, it will be negative, right? So if it's negative on a skin biopsy, I think of an vitiligo or an albinism. Fine. I'm just going to ask you one more simple question so that you can differentiate between vitiligo and albinism. Fine. I'm saying a person who's a 35-year-old woman has hypopigmented patch. Biopsy shows negative for Masson Fontana. Vitiligo or albinism? What's the answer? 35-year-old women, biopsy of an hypopigmented patch, negative for Masson Fontana, vitiligo or albinism? Simple. That's why your clinical scenario comes into place. Vitiligo is an acquired autoimmune disorder. Albinism is most of them a congenital problem. The same question comes like saying 2-year-old kid, hypopigmented lesion. You think of albinism, right? Albinism is most likely inherited, most likely autosomal recessive. So they present very early in life. Vitiligo is acquired. Later presentation, more common in women, not always in women. That's how you will be able to differentiate it, right? Perfect, right? Let's go to the next guy. Hemosiderin. Hemosiderin, again, microscopy will be brown in color. And the stain is Pearl's Prussian blue. Pearl's Prussian blue, logically, if you have to choose between hemosiderin and ferritin, it stains hemosiderin, it might not stain ferritin. Remember this, it's an hemosiderin stain primarily, right? So there's an image where you can see that these are the positivity, right? I'll give you clues. I want you to tell the diagnosis. 45-year-old person having jaundice, icterus, elevated AST, ALT, everything. Liver biopsy shows Pearl's positive structure. Diagnosis. Perfect, Sindhu. It's hemochromatosis. This was an old PYQ, right? So 2018 PYQ which came in pathology, along with the scenario which also said that brown color skin, bronze diabetes is classical for hemochromatosis, right? Perfect. Let's say, I'll give you one more example. Let's see if you can pick it up, which is not a PYQ. A person, 50-year-old person having breathlessness dyspnea and lots of problems with walking, orthopnea and everything. Patient is on digoxin. Lung biopsy shows hemosiderin positive cells. What are the name of these cells? In the lung biopsy, in a patient who is having symptoms of orthopnea dyspnea has Pearl's positive cells, we call them an heart failure cells. Perfect. So this is how I can apply them. It's a simple thing. I can apply them easily, calling it an heart failure cell, right? So this is how stains will be asked. You might not have straightforward PYQs or straightforward MCQs or one-liner in the NEET PG exam. We hope so. I can apply it and ask easily, right? It's very, very simple. Perfect. Then lipid. Lipid, oil redo, Sudan black. I don't think you need to differentiate which is oil redo and Sudan black. Obviously red in color, this is oil redo. And black in color, this is Sudan black. I can call it an SBB, Sudan black B, Sudan black 4. There are multiple Sudan blacks. All of them have the basic thing, right? So here, lipid stain, we already know that you need a frozen section for it. Fluorescence section is mandatory to demonstrate lipid stain because in a normal processing, whenever you use gradations of alcohol, lipid will be washed away. That's why lipid is clear. It will be washed away. It will be clear on microscopy. This is a very old PYQ, which I'm sure you will not miss it if it's asked again, right? So that's simple thing about fat. Utility of fat stain is very, very, very limited because I know it's fat when it's look fatty liver. I'm not going to do a lipid stain that, but it's very, very limited for now. Fine. Okay. Glycogen. Glycogen has two colors in light microscopy. Glycogen can be light pinkish. Glycogen can be clear as well. Okay, I'll give you a simple example. Can I say glycogen as sugar? Yes, no, maybe. Pathology is about relating to real life. The only problem is we are taking it away. That's why I'm not able to understand pathology. Glycogen is sugar, that's all right. Can I say a normal sugar is not clear? At the same time, have you seen sugars? I don't know what's the Hindi name or English name of it. Have you seen sugars which is there in the given in marriage halls, which are like condensed crystallized sugar? In Tamil, we call it kalkand. You must have seen that, right? I hope you can relate it. It'll be very sweet, tiny cubes of sugar. That will be clear. So when glycogen is very much deposited, yeah, mystery, right? When glycogen is very much deposited, it becomes clear. When glycogen is less deposited, it becomes pink. That's all. It's based on the deposition. It's not always a glycogen storage disorder will have a plant cell-like appearance. That's a problem with reading MCQs. It can have a plant cell-like appearance when it's loaded with glycogen, clear like a plant cell, right? Not always glycogen storage disorder will have plant cell-like appearance. Yes, glycogen storage disorder can have a plant cell-like appearance when it is loaded with glycogen. It becomes clear like your mystery, right? That's when it happens. Otherwise, it will be light pink. So when it's light pink, I have a problem to differentiate. We use a stain PAS. It has to be PAS positive, and the most important thing is diastase sensitive. Because glycogen is a sugar, diastase destroys sugar. So it becomes sensitive to diastase digestion. Very, very simple. Simple scenario. A patient who's like 5-year-old having pains in the leg after walking or doing very much of fatigue of muscle. Muscle biopsy shows PAS positive, diastase sensitive structure being accumulated. What is your diagnosis? Microbiology, pathology, biochemistry, pediatrics, McArdle's. Perfect. Again, the location is important. If the same question had been 2-year-old, conductive cardiac failure, died, heart biopsy shows PAS positive diastase sensitive structure. SSGST is amazingly right, but to be more specific, McArdle will be a better answer, right? If it's in a cardiac tissue, I'll think of Pompey's. So whatever you read in the tables of glycogen storage disorder in biochemistry, I can create MCQs. It's not a new MCQ, it's the same thing in a different format, that's all. All of them are acting, right? It's very simple, just apply that. You just need a clear mind for it, that's all. Protein is PAS positive and diastase resistant, okay? It's diastase resistant as protein because protein cannot be digested by a sugar digesting enzyme. Where all I can apply this? For an undergraduate, for NEET PG, 2 places I want you to remember. One, in liver biopsy. Liver biopsy, PAS positive diastase resistant. It's a PYQ. Come on, answer. This patient also will have lung problem of pan-acinar emphysema. What's the disease? Come on. It's very, very simple. Alpha-1 antitrypsin deficiency. Okay, also will have pan-acinar emphysema, right? Perfect. Second thing, this can definitely come in an exam because it's very much integrated. A patient who is having a history of diarrhea also has conductive heart defects and also has arthritis, problems in the eye. An intestinal biopsy shows PAS positive diastase resistant macrophages in lamina propria, right? In the intestine or in the colon biopsy, I'm having PAS positive. What's the diagnosis? Come on, diastase resistant macrophages in the lamina propria. Perfect, Whipples. Again, 2 PYQs which are related to one fact of PAS positive diastase resistant. Here, the macrophage has the organisms which are PAS positive diastase resistant. In alpha-1 antitrypsin, I have protein which are PAS positive diastase resistant, right? Trifroma Whippli, right? Okay, perfect, right? Calcium. It's an age-old mnemonic. I'm sure you must have remembered this. KAL. K for one-cosa, A for alizarin. One-cosa is the most commonly done one. Alizarin is a very, very, very specific stain. Alizarin is definitely superior. One cosa is commonly done because it's cheaper, that's all, right? Look at that. This is alizarin red, for red in color. One cosa is an silver based stain. One cosa will highlight calcium, brownish black in color, right? It's there in the wall. Let's relate to an scenario based question or an image based question. If you see vessel wall like this, positive for calcium in the tunica media, what's the diagnosis? Vessel wall, no symptom, positive for calcium in the tunica media. Starts with the M, that's a clue. If you see in vessel wall, in the tunica media, that also is an important MCQ where you see this classification, this condition, we call them great. 𝐌𝐞𝐝𝐄𝐝 arteriosclerosis, which is an age-related change. You, me, everyone in the world will have 𝐌𝐞𝐝𝐄𝐝 arteriosclerosis. I can create a scenario based. Just one more twist. A person with a swollen thyroid, midline swelling, biopsy shows one cause of positive structures in that biopsy. What do you think is the most common diagnosis? Though it's an indirect link, but what do you think is the most common diagnosis? Can I put some more bodies and papillary carcinoma thyroid? I can. So it's not just restricted to this. Not medullary Toldenbu. Why medullary? Medullary will not have some more bodies, right? Did I say something else? Why most of them are talking about medullary? One cosa will be positive for calcium, and calcium will be positive for some more bodies. Did I miss say anything? And that has to be papillary carcinoma thyroid. Amyloid in medullary, right? Perfect. Amyloid, yes, for medullary. Congruent medullary, not this. Again, please don't get stuck to the PYQs. I'm talking about calcium. I'm talking about one cosa. So some more bodies, so that, fine. Okay, fine. Got it. Okay, guys, fine. Copper, rhodamine, rubionic acid, or zinc. There are multiple saints, right? So we'll keep it as rhodamine, not rhodamine. Rhodamine is also fine. It's completely fine. But you get confused with auramine, rhodamine stain used in tuberculosis. That's different rhodamine. This is different, right? It's rhodamine, rubionic acid, and orcine. All of them are copper stain. Copper has only one utility, which is Wilson's disease. Wilson has to be going for copper, right? Perfect. Great. Okay. And this is a stain, how copper looks in orcine. Orcine is a better stain compared to rhodamine or rubionic acid because it's more crisper in microscopy. Fine. Okay. Mucin. Mucin has multiple mucin. PS, Alchin blue, musicarmine. Previous, I think one of the AIMS exam had the question of acid mucin being positive for Alchin blue. Just a way to remember A for A. Right. Musicarmine is especially positive for salivary gland related mucin. Salivary gland also produces mucus, right? Salivary gland mucin is more positive for musicarmine. PS is positive for neutral mucin. Okay, neutral mucin, acidic mucin, and musicarmine for salivary gland, right? Okay, so that's how we can apply. Mucin can be applied in multiple places. Esophageal biopsy, lower end, mucin positive for PA Alchin blue. Diagnosis. Cryptococcus as well. If you want to relate it to your microbiology, Cryptococcus is also positive for that. Yes, to it is. It's a mucin stain where it's also positive for Cryptococcus. Perfect. If I'm going to have Barrett's esophagus, will be positive. Let's say if it is a CNS infection with musicarmine positivity, you can think of an cryptococcal meningitis. I can relate that as well, right? Musicarmine is primarily a mucin stain. Carmine is red in color. So if you remember the cryptococcal images, it will be red in color. You must have seen carmine dyes. It's a food coloring agent, right? Carmine is red in color. So musicarmine will be red in color on a biopsy. After doing it, Alchin blue will be blue in color, and PS as usual the magenta color, right? Perfect. Last but not least, amyloid. Amyloid, the stain is congruent. What's the color of amyloid in light microscopy, everyone? Apple green birefringence is in polarized light, right? Here you will have the classical apple green birefringence, but in a light microscopy, it will be salmon pink or an orangish pink in color, right? Orange pink color in light microscopy. Whenever you have a question on congruent amyloid, don't jump to apple green. Please see what they are asking for. Light microscopy, different color. Polarized microscopy, different color for amyloid, right? Okay, perfect. Now, just a spin from this. Where else can I use polarized light in diagnosis? One is obviously amyloid. I can use for amyloid. Amyloid apple green birefringence. Anywhere else I can use polarized light? Brain is always wired to the exotic questions, right? Anywhere else you use apple, right? Perfect. Gouty arthritis. In gout, it is needle-shaped crystals and it is negative birefringence. That's gout. Fine. Perfect. Great. It's into pseudo gout, right? We'll include pseudo gout as well. Great. In pseudo gout, we have rhomboid shaped crystals, CPPD crystals, and they are positively birefringent. If you have to differentiate only based on birefringence, needle, way to remember, needle is like a negative sign, so negative birefringence, and here positive birefringence, right? One more place. I'll give you a clue, you tell me. A patient who's working in a very simple clue, glass manufacturing industry, has histories of cough for a long duration, biopsy taken, shows fibrotic nodules in the lung along with birefringent particles. That is silicosis. Silicosis again, it'll be positively birefringent crystals. Fine. The way to remember gout will have needle-like crystals. It looks like a minus symbol. So think it is an negatively birefringent, right? Silicosis also birefringent. Remember that. It's simple. It can reflect light. Sand can reflect light. As simple as that, right? So these are the, at least from an undergraduate perspective, these are the places where we use polarized microscopy or a polarized light, right? Okay. Let's try to solve a few questions. This might not be simple. I want to make the scenarios a bit difficult so that you can apply that, and I know it might be easy for you guys as well, right? Read it for 20 seconds. Give me the answer. I'll keep quiet for 20 seconds. Just comment A, B, C, or D. I want everyone online here to comment. It's fine if you make a mistake. It's not an issue. Then let's go and highlight the important words here. At least one of you comment, then I'll go to the answer. Okay, Sudhir has gone with C. It's okay. These are not very simple and straightforward, but please let's try to learn. Preserved cell outlines, deeply eosinophilic cytoplasm, and absent nuclei. Can I say it is coagulative necrosis? It is, right? It's coagulative necrosis. It's a very simple question. If I speak of coagulative necrosis, what do we think of the answer? Do I think of this? This is for apoptosis, right? This is for apoptosis. It's not for necrosis. Loss of plasma membrane integrity and calcium influx. Can I think of this? Obviously, I can think of this, right? ATP dependent endonuclease activation, again for apoptosis. Caspase mediated cytoplasmic cleavage, again for apoptosis, right? It's a simple case of myocardial infarction. See, as simple as a myocardial infarction is making you think the question is difficult because it's in 4 lines. Clear mind, look at the keywords. History of MI, it cannot be apoptosis. Deeply eosinophilic cytoplasm, preserved cell outlines, that's a ghost cells, absent nuclei, it's only necrosis, right? It's a simple case of an coagulative necrosis, so option C is the answer, fine. Cryptic commenter, it's simple, no? It's a case of MI. Leave everything else. Anterior wall reveals pallor, which in case of MI. Can I say it's necrosis? Yes, cryptic commenter. MI is equivalent to necrosis. MI is ischemia related, which is equivalent to coagulative necrosis. The most common cause of coagulative necrosis is ischemia, right? Fine. Apoptosis is endonuclease. Endonuclease is where apoptosis, because of the endonuclease activation, my nuclear membrane DNA is like this. Endonuclease, it cuts them into fragments. Because of them, it's cutting to fragments. You have the stepladder pattern. The stepladder pattern of apoptosis is due to endonuclease activation. Okay. Outline preserved hard worker is the clue for coagulative necrosis, right? That's it. Amazing. Fine. Let's try. Simple concepts only. I'm just twisting it so that you can apply it. If at all even the toughest question comes in the exam, you should be able to answer. Go ahead. 20 seconds again. Want more people to answer, make more mistakes so that in real exam you don't make a mistake. Okay, 12 in blue started. SS for C. Let's see. 40-year-old chronic hepatitis B infection, scattered hepatocytes with condensed chromatin, shell shrinkage, intact plasma membrane, adjacent phagocytic Kupffer cell. All of these points to one guy, apoptosis. If this is a new information, remember, tunnel assay is also positive in case of apoptosis. That's an assay used to identify apoptosis. The only thing which can be for apoptosis is this, right? Caspase related, option B, what type of cell death? Everyone. Necrosis, apoptosis, pyroptosis, necroptosis. Caspase 1 activation, interleukin 1 beta release, that is your pyroptosis, right? Diffuse cell swelling, membrane lysis. What type of necrosis? That's your, so this is your necrosis. What type of cell death? This is your necrosis, right? Perfect. Just one more information. There's one more hidden PYQ in this question. Can anyone name the cell? In a hepatitis B infection, can anyone name the cell? Sindhu, membrane lysis, I won't think of a reversible injury. Cryptic commenter, it's an irreversible injury. Great. The Councilman bodies, right? Again, everything is there. It will not go beyond this. Councilman bodies was first discovered in case of an yellow fever. In yellow fever, Councilman saw Councilman bodies, but we use it for almost every hepatitis. I will see apoptotic bodies which are named as Councilman bodies. Kind of an not a right way to use, but we use them. Fine, perfect. Okay, let's see one more question. Let's go to inflammation chapter. It's a simple one. This is a PYQ actually. I know that most of you will write the correct answer. Bronze, diabetes, ferritin transferrin saturation elevated, liver biopsy golden brown, stains blue with Prussian blue. It can be nothing else than this, right? Simple, amazing. This type of confidence I want in a new question also. It is simple to solve, just take some time, right? Where do you see this? Mallory Denk, copper accumulation. Option B, Mallory Denk. Think of alcohol as a primary one, but you know that it's a very non-specific finding. You can see them in quite a few hepatitis. Alcohol is something which I'll think of first, fine. Copper, Wilson. Lipofuscin can be due to cell aging as it's mentioned there, fine. Okay. Lipofuscin is also brown in color. One of the clue to say it's lipofuscin is it is perinuclear in location. It's not diffuse. It'll be seen on either sides of the nucleus, right? Amazing. Okay. Let's go to the next one. Next is inflammation chapter. The same way, let's go to one by one thing so that we can sort it, and I am 100% sure you'll be able to do well. Acute versus chronic inflammation. Put your pens down just for us to listen. Whenever any inflammation happens for acute minutes to hours, we call it acute. There are two things for cell of acute inflammation. Please don't think only neutrophil, eosinophil, allergic rhinitis, asthma, which are also acute manifestation, will also have your eosinophils. It's not only neutrophil. If it's allergy, parasitic, I think of eosinophils. Your hallmark is vasodilatation, increased vascular permeability. The simplest way to explain or remember this hallmark is mosquito bite. If mosquito bites, there'll be a tiny bump in your skin. Vasodilatation, more permeability. This is what causes edema, bump in your skin during any acute inflammation. Chronic, days 2 months. Chronic, this is the cell of chronic inflammation, not lymphocytes. But yes, I will also see lymphocytes if it's an autoimmune disorder or if it's a viral infection. Please remember that once I know it's autoimmune, you can diagnose almost every autoimmune condition biopsy. I need to just identify lymphocyte, that's all. And this is my most favorite of entire pathology. Every chronic inflammation will have tissue destruction. It will heal by fibrosis. Best example is TB. Fibrocavity lesion and X-ray. Cavity is tissue destruction. Fibrocavity, healing by fibrosis. That is by default for any chronic inflammation, the outcome, right? So now, when I know acute and chronic, the goal is not to remember the selectin integrin, that I'm sure you will do. The goal is for me to remember few more things apart from this, right? One line for this margination, rolling and addition, but I have to also remember few more things which we'll definitely see in future, fine? Okay. In acute inflammation, we have the rolling, margination and everything, right? Margination, which helps. There are two things you have to remember in margination. Margination is primarily a vascular process. Okay. And selectin helps in margination. Selectin is not the only one which does the margination. Selectin helps. Do you guys know any CD marker number for selectin? Anyone? I'm sure you know for PCAM, which was been previously asked. CD31 for PCAM, right? CD, the double of it. 62 is for selectin. That's a marker for selectins, which is CD62. Fine. Rolling is the next step. After marginating, it rolls on the endothelium, right? For rolling, there are two things there. One guy in the WBC, one guy in the endothelium. Who is in the WBC? Who is there in the WBC which helps in rolling? Which is your Ciala-Lewis X receptor. Who is in the endothelium? The same guy, selectin. Selectins are primarily in the endothelium. There's a selectin called as P-selectin. Again, one more PYQ for you guys. Where are they stored in endothelium? They are stored in a tiny one. What is that? They are stored in a tiny body called as Weibel palade bodies. They are stored in the Weibel palade bodies along with the von Willebrand factor that's in the endothelium, right? So that's released during inflammation and which helps in the rolling, right? Perfect. Okay. Addition, again I have a guy in WBC, I have a guy in endothelium. In WBC we have integrins. In endothelium we have CAMs or the cell adhesion molecules. We have two types of CAM, ICAM and VCAM, right? Those are the cell adhesion molecules, fine. Diapedesis is moving outside. So diapedesis, there are two steps in diapedesis. One is to escape. Second, there'll be collagenase activation. Most of the time this step is missed because this collagenase activation is going to help to kind of loosen the basement membrane, because every endothelium sits on the basement membrane. I have to lose it, only then goes. To escape from the cell, we have the PCAM1. Everyone, what's the other CD marker number for this? It's your CD31. CD31 is the other name for your PCAM. PCAM1, right? CD31, do remember this. Chemotactic event, C5 is the best or the superb chemotactic factor. This is for chemotaxis. Generally, people confuse this with C3b. C3b is in perfect opsonin. This also was a PYQ. Chemotactic factor, I'll prefer C5. And there's one more leukotriene, leukotriene B4, is also a very good chemotactic factor. These are endogenous chemotactic factor, right? Exogenous, any bacteria's polysaccharide or the flagella protein, everything will take into place, fine? Okay. Then it goes outside to the site of inflammation. This is an information. What is important for an undergraduate or a doctor is, if it's lost, what happens, right? So let's go to the diseases, and one where it's a error, one characteristic feature, so that we can apply that to a scenario based question. Okay. LAD stands for leukocyte adhesion deficiency. Autosomal recessive inheritance. LAD1, what is the problem? LAD1, what's the defect? Is it selectin or is it integrin? Come on, these are very, very simple ones, right? Let's start with the comment board again. LAD1 is a problem in, integrin, or to be specific, like Subrat said, beta-2 integrin. Okay, it's an integrin defect. Fine. Remember, I looks like one integrin. This is Ciala-Lewis defect. It's not a selectin defect because selectin is on the endothelium. These are leukocytes problem, right? Both will have common thing, which is infectious disorder. More amount of infection will be there, right? But both has one more important common thing, neutrophilia. You might miss this. Remember this forever. Put a star mark, put a hyphen, highlight it if required. Because these are immunodeficiency disorders. Generally, I'll think of neutropenia, but I'll have neutrophilia. Like Karthik said, the other finding here is Bombay blood group. What's the name of Bombay group? H group. That will be seen there in Ciala-Lewis defect. Some other person commented, I think you remove the comment. What is one more classical finding of integrin defect? Integrin is not just involved in inflammation, integrin is also involved in wound healing. So I'll have, remember this, delayed wound healing. I want you to remember this, not just delayed separation of umbilical cord. That is there. But if umbilical cord history is missed, if the person is like 10-year-old, healing will be delayed, right? So yes, obviously because of this, umbilical cord separation will be delayed, but the primary problem is healing delay. Umbilical cord is a scar, right? that also is related to the healing problem only, right? That is LAD1 and is LAD2, right? Chronic granulomatous disease. I have two inheritance here. I have both autosomal recessive and X-linked recessive inheritance. What's the defect? Anyone? The defect in chronic granulomatous disease? It is NADPH oxidase defect. Okay. Because of NADPH oxidase, I will not be able to produce the free radical, right? One classical clinical history. This came in a PYQ along with the scenario. Which infection will these people be more prone to? Which infection do you think these people be more prone to? Catalase positive, catalase negative. Perfect. That's a very, very important clue. When you have lots and lots of catalase positive infection, there's a clue. This came in a PYQ. Look for that. You know the organisms which are catalase positive, relate to that. Catalase positive organisms, NADPH oxidase defect, and what's a test? Any one investigation of choice. Tell me one which has been commonly used. There's multiple roaming around, you must have read. One thing which has been commonly used as an investigation of choice. We can do an enzyme analysis. Perfect. NBT test, I want you to remember, there is many tests like Lord says, DHR is also fine, but NBT is something which I don't want you to forget. Nitroblue test, that is important. DHR also, if you can remember. Enzyme analysis also can be done, right? Perfect. Kshedia-Khayashi syndrome, autosomal recessive. The way to identify Kshedia-Khayashi syndrome along with recurrent infections. Do you know any other symptom classical for Kshedia-Khayashi? Infection will be gone because there will be defect in the gene LYST gene. The gene says everything. LYST, lysosomal transporter. So phagolysosome will not be transported and formed properly. Because of that, there's a defect in phagolysosome. So it's transporter defect. Because of the transporter defect, my body cannot transport a melanocyte from the neural crest into my skin, because melanocyte is neural crest origin. Because of that, people might have albinism. It's again a transport defect. My body cannot transport a Schwann cell, a neural crest origin, to my tip of the peripheral nerve. Less myelination, neuropathy. These are classical symptomatology in a scenario-based question, right? Perfect. Okay. One more thing. A very, very, very specific finding. Since phagolysosome formation is a problem, I'll have big granules loaded with bacteria inside the WBC, right? You'll have very large granules in WBC. That is very, very classical, a very, very specific finding for Kshedia-Khayashi syndrome, right? That's what happens in case of a Kshedia-Khayashi syndrome, right? Perfect. Last but not least, just to complete, autosomal recessive, it has both catalase positive as well as catalase negative organism infection. Not very common. Let's ignore that for now, right? But these are few things which I want you to remember. Everyone in this table has been asked in an exam sometimes, be it an FMG, NEET PG or INSET in the last 5 years. At least 1 point comes. Maybe we can expect something in this NEET PG exam as well. Fine. Okay. Let's go to the next guy. Let's go to chronic inflammation, right? Microscopy, you'll have granuloma. The center thing will have all your epithelioid cells. What does oid mean? We just read that in your fibrinoid necrosis. Comment, what does oid mean? You guys know that. Oid is perfect. Epithelioid cell is epithelium-like cell. So the cell looks a little bit elongated with a pink cytoplasm and a long nucleus, looking like a columnar epithelium. So I call it an epithelioid cell. That's all. Fine. A granuloma will always be surrounded by lymphocytes. Lymphocytes is a hallmark of granuloma. Surrounding granuloma, I have lymphocytes, right? It's a modified macrophage. Can I call this as a principal cell of granuloma? Yes, it's the most important cell of the granuloma. Giant cell is not the principal cell. Epithelioid cells are the principal cell of granuloma. That's how a granuloma looks like. We divide granuloma into two things: caseating, non-caseating. Tables are important but difficult to memorize. Tables are very easy if you know the funda behind the table. The funda behind this classification is, what does necrosis mean? Can I call necrosis cell death? Yes. Can you kill a suture material? Can you kill or destroy a suture material in foreign body? Yes, no, maybe. I cannot destroy a suture material, right? Or a foreign body. Can I kill a sarcoid? There's nothing to kill a sarcoid, right? Can I kill a Crohn's disease? There's nothing to kill in Crohn's disease. Can I kill leprosy? Can I kill histoplasma? Can I kill TB? Yes. If you can kill TB, histoplasma, coccidioidomycosis, especially neuritic leprosy. In neuritic leprosy, in other places, I will not be able to, so it is. If I can kill, necrosis will be there, necrotizing granuloma. I cannot kill. Again, first is TB. Never, ever, ever forget that. If my immunity is bad, you and me cannot kill TB. That time I'll have non-necrotizing. Granuloma is equal to TB, unless otherwise proved. Apart from that, yes, I can have a foreign body. I can't kill a foreign body. Any foreign body granuloma, suture granuloma, that's one of the commonest example. Crohn's disease, nothing much to kill. Hodgkin's lymphoma, nothing much to kill. And last but not the least is your sarcoid. Okay, if you can't kill, think of that, right? But always non-necrotizing granuloma or non-casing granuloma is TB by default. First is TB, rule that out and then go for rest out, everything, fine? Okay, since we are in sarcoid, sarcoid is a multi-system diagnosis, fine? Sure, cryptic comment that is said only neuritic leprosy will come under this. We have different types of leprosy where you might not even see a granuloma, you'll see only macrophages. You must have read them as globi, right? Tolled in blue. Fine. Okay. We'll come to cat scratch granuloma soon, tolled in blue. Fine. So whenever you see sarcoid, there are few more things I want you to remember. What will be the level of AZ enzyme? High, low. It will be very, very, very high. It's not just lung problem. Yes, I have a lung problem. I have bilateral hilar lymphadenopathy. Then I'll have other findings as well. I need granuloma. Granuloma in sarcoid is called a naked granuloma. The reason is there'll be no lymphocyte cuffing. The lymphocytes, what we saw in a classical granuloma, will not be there. And yes, it's non-necrotizing, non-catiating by default. You cannot diagnose sarcoid only based on a chest X-ray and a biopsy. It's a multi-system diagnosis. It's always a diagnosis of exclusion. Unless until the question says AFB or Zeal-Nielsen test negative or a PCR negative for TB, don't think of sarcoid, not just in MCQ, even in real life. First TB, then yes, if rest everything is available. If the question says AC is elevated, think of sarcoid by default, right? All these are required for me to identify sarcoid. CD4, CD8 increase also required for me to identify sarcoid, right? Okay. This is for granulomas. Few outliers and few unique findings like Jane cells. There are multiple types of Jane cell, right? What about Jane cell is this? Fastest finger first. Just come in the first letter also is okay. Schumann body, asteroid body can also be seen in Sharka. You are absolutely right here. This is Langhans type of Jane cell. And horseshoe or an U-shaped nuclei arrangement, we think of TB. We think of TB. It's not always TB. We think of a TB, right? A circular arrangement or a wreath-like arrangement. Whatever helps you, right? We call it a two-tone type of Jane cell. It is seen in xanthoma. So how I can create a clinical scenario based out of this? A 40-year-old person having a tiny elevated lesion close to the eyelid, biopsy taken, showed a granuloma with Jane cells surrounded in the form of circle, two-tone Jane cell xanthoma. It's very simple to create history. It's not a dermatology question. The base is coming from here only. That's how integrated questions are created, right? What is this? This is a PYQ. I'm sure you'll identify that. This is a Warthin-Finkelday Jane cell. Warthin-Finkelday is a Jane cell with an intranuclear and intracytoplasmic pink or eosinophilic inclusion. Warthin-Finkelday Jane cell is seen in measles. Measles pneumonia is where we see them often, but any part measles, I can see Warthin-Finkelday Jane cell, right? Perfect. Both intranuclear, both intracytoplasmic, pink. The same guy here, both intranuclear and intracytoplasmic inclusion, blue. What is this guy? I would say is not the concern for me. I want intranuclear and intracytoplasmic basophilic inclusion. Then yes, CMV is fine. Obviously, I would say makes to the top of the list. It can be owl's eye, it need not be owl's eye. But same, I'm having an owl's eye with pink inclusions, pink nucleoli. What is the diagnosis? That's your RSL, a classical RSL seen in Hodgkin's lymphoma. If it's a blue inclusion, I think of a CMV. The pink nucleoli, it's not an inclusion here, pink nucleoli, I think of an RS cell, right? So can I say this to be a tumor gene cell? Yes, no, maybe. Let's have a eureka moment. Even the final exam read, we need an eureka moment by default. Yes, I can call it a gene cell, right? RS cell is a tumor gene cell. Gene cells are seen in inflammation, which means RS cell is a chronic inflammation. RS cell also, Hodgkin's also has granuloma. If you look at RS cell, it releases interleukin to attract more and more WBC. Diagnosis of Hodgkin's lymphoma is RS cell plus background inflammation. RS cell Hodgkin's lymphoma has a very decent prognosis. The only reason I kept as a cancer is it's metastasizing. Maybe in future we'll change into inflammation. Life is much simpler. Start thinking. It's not just MCQs. We're imparting knowledge that should at some point of time help you in future. Fine. Let's go back to our MCQ learning. So this can be seen in Zank's smear or it can be seen in Pap smear. We have the 3M. Right? We have the 3M. Molding, multinucleation, margination. Diagnosis. That's a classical and a simple diagnosis, right? Molding, multinucleation, margination. Perfect. It is seen in HSV, herpes simplex virus. I can see them in Zank, which can be an oral smear for HSV1. Genital Pap smear, I can see HSV2. It's herpes simplex virus, right? Cryptic commenter, won't think of a cervical carcinoma. Okay, since cryptic commenter has asked this question, I'm going to ask this question to everyone here. If it is a cervical carcinoma case, what will be the microscopic finding of a Pap smear? Thinking of HPV infection. There's one classical finding since we have here. Let's include that as well. HPV, I see a clear intracytoplasmic inclusion, which we call them an 𝐒𝐂𝐈𝐀. Cyte is cell. 𝐒𝐂 means hollow. 𝐒𝐂ocyte, 𝐒𝐂𝐈𝐀, hollow nail, right? 𝐒𝐂ocyte, right? Clue cell again. Cat is taking us to one more question. Where do you guys see clue cell? Clue cell is not seen in HPV. Clue cell is seen in Gardnerella vaginalis infection, which is in bacterial vaginosis, right? It's in bacterial vaginosis. That's a different finding. That also is a finding seen in case of an Pap smear. Fine, perfect. Racinoid nuclei. Instead of perinuclear halo, I use the term intranuclear inclusion because virus and inclusions are hand in hand, right? Perfect, amazing. Okay, your favorite things, which are not seen at all, but you guys like these things, right? Hardly you will see in real life. A donut-shaped granuloma, if you want to write the real name Duffnet or you want to call it donut, it's fine. Donut-shaped granuloma is seen in liver and bone marrow. The reason for the donut is the central fat. That's why liver and bone marrow is required. In liver also fat is very common. Bone marrow also fat is very common, right? The donut-shaped granuloma, you see them in great Q fever. Which organism? Anyone? Which organism? Anyone? Coxiella bruneti, right? Coxiella bruneti is the organism where you see the donut granulomas. Perfect. Okay, this is your Druck's granuloma. Again, something which should not happen in this era because I have beautiful ways to treat the simplest malaria, cerebral malaria. Yes, I can see them in cerebral malaria. Druck's granuloma, not seen these days. Fine. You're right, Q fever and also your allopurinol toxicity, which will have history by default, right? Someone asked about cat scratch disease, stellate granuloma. The thing about stellate granuloma is not the star shape. That's not what should excite us. It is definitely an irregular granuloma. Is it looking like a star? Need not. It's an irregular granuloma. The thing is, this is also will have in microscopy. If you go to higher power, you will see neutrophils. When you see neutrophils plus granuloma, can I say it's an acute on chronic inflammation? Yes, no, maybe. I am saying neutrophil and granuloma. Whenever you see acute on chronic inflammation, I want you to think of this T cell, which is TH17, along with TH1. TH1 is the regular T cell which helps for granuloma formation. But here, along with TH1, I also have TH17. That's why it is unique, right? You see them in cat scratch disease, Bartonella-Hensley, and someone also told that lymphogranuloma venereum. In both of them, I have chronic inflammation plus an acute problem. That's why it's very, very important for us to understand that, right? Last but not least, microgranuloma. When I have less than 25 epithelioid cell, I call it a microgranuloma. Okay, microgranuloma is a diagnostic of toxoplasma infection. Toxoplasma lymphadenitis, I won't have a giant cell, just cluster of epithelioid macrophages. We call it a microgranuloma. Might come in an exam, not used in real life. Most of the thing which comes in the exam might not help us in real life, right? Okay, let's go to a few MCQs. Let's solve a few. Hopefully, we'll be able to answer the questions. Again, 20 seconds, I will keep quiet. Tell me what's the answer. Thank you, Santosh. C. Perfect. Maintenance of granuloma, I need interleukin 12. Interleukin 12, interferon gamma, right? And interleukin 1 and 2. Interferon gamma is very, very important for me to convert a normal macrophage into an epithelioid cell. This came once in an exam. Remember that. Interleukin 12, interleukin 1 and interleukin 2. This helps me converting a T cell into an Th1 type. This Th1 produces interferon gamma to convert it more. It's like a vicious cycle. Obviously, educate me. PDF will be available in the Telegram channel of PW. Once the class over, I'll share with them and they'll put it in the group. Fine. Okay. Perfect. Next. A very simple one. You will jump into this. Again, it's a PYQ, but just framed in the form of a scenario-based question. Simple. I'm talking about a negative acute phase reactant, which means it'll reduce during inflammation, right? Reducing during inflammation is albumin. Okay. Sindhu, I'll ask them to have a look at it. You should get it there. Fine. Albumin is a negative acute phase reactant. Rest are them a positive acute phase reactant, right? Positive acute phase reactant. First of all, acute phase proteins or acute phase reactants are actually related to your liver because of interleukin 1, interleukin 6, TNF. These will push the liver to alter the protein production, increase the production of acute phase proteins or acute phase reactants, right? We have very common acute phase reactants. Fibrinogen is one. That's the reason ESR is becoming elevated in case of an inflammation. It's fibrinogen dependent, right? You have your CRP. That's one more thing. C-reactive protein, it's increased. Ferritin. What we did during COVID, serum ferritin, we looked for every time when there's a COVID, we ordered ferritin to look for degree of inflammation, right? Thrombopoietin. Thrombopoietin is a new acute phase protein. This kind of explains why in few patients of fever, why I have an erratic elevation in platelets, right? Thrombopoietin is also an acute phase reactant. Do remember them, right? These are positive acute phase proteins. Negative acute phase protein is your ferritin, your transferrin, your albumin, and your retinol binding proteins. Fine. Okay. That's with inflammation. Let's go to your pedigrees. Pedigree should be the simplest thing in your life, right? Just listen to me for the next 10 minutes. We'll make sure every pedigree which comes in exam will be solvable within 10 seconds. And do remember, if you're not able to solve a pedigree within 10 seconds, the pedigree is wrong. But you have to follow the exact rules. I have simple rules of pedigree. Whenever a pedigree is given, fine. I wish Sindhu, there are mnemonics, but that will complicate it much worse, right? Let's come back to this. Whenever any pedigree is given, the first tool is rule out mitochondrial. If you don't do that, you will end up in error. Because mitochondrial, how to rule out? Mom transfers to 100% kids. How many percent kids will be affected when dad is affected? Dad? 0%. If the 0% kids are affected when the dad is affected, it's mitochondrial. 100% kids affected when mom is affected, it's mitochondrial. Why should I rule this out first? Because mitochondrial is a non-Mendelian inheritance. The rules which I'm going to talk are Mendel's rule given by Gregor Mendel. So it will never go wrong. If it goes wrong, it's a non-Mendelian inheritance. Look at that, right? There are only 5 pedigrees which might be asked in the exam for an undergraduate, right? First, look for an autosomal recessive. Once you rule this out, I'll give you two flowcharts. Look for that flowchart. That's all. Before that, we have to talk about few things. Let's say this is a pedigree. Okay. Let's assume in most of the pedigrees, if you have seen, it will be written like either A, B, C or 1, 2, 3, right? In the sides. These are called as generations. This is first generation. This is second generation. This is third generation. That's how we name them. So generations. I'll be telling that look whether generations are affected or not. That's the first tool I want you to see. Don't look at anything else. Just look at generation affected or not. Answer me. If you have a pedigree like this, are all generations affected? Yes, no, maybe. If this is a pedigree, are all generations affected? Yes, no, maybe. Absolutely, yes. Right? That's all. Which means at least one in every generation is having the disease, right? If I have a pedigree which is like this, which means all generations are not affected because the first generation is not having a problem. This, if you know, pedigree is sorted. Cryptic and Manu told it in blue. Let's not jump into autosomal dominant yet. We'll come to it. Fine. Okay. So now, all generation affected. If the answer to that is no, I am dealing with a recessive disorder. Then look for genders who are affected. If only men is affected, it is X-linked recessive. If both men and women are affected, it is autosomal recessive. Because X-linked will have obviously a gender-based bias, right? So if generations are not, all the generations are not affected, I think of a recessive. If only men, X-linked recessive, not both men and women, it's autosomal recessive. It's simple. It should not take more than 5 seconds. That's enough for you. But please don't forget the first step, right? Next, let's assume if the all generations are affected, which means at least one every generation, not everyone, at least one affected, then I'm going to think of a dominant disorder. Dominant, I have to ask two more questions. Is there a dad to son transmission? Let's assume I am a dad who is affected by a X-linked disorder. Let's assume my X chromosome has a problem. If I am giving birth to a son, what chromosome should I give in order to give birth to a son, X or Y? I have a faulty X chromosome. I am giving birth to a son. So I should give you my Y chromosome. Only when I give the Y chromosome, the zygote will become a son. So is there any way possible I will transmit my X-linked disorder to my son? Never. Because for me to form a son, I have to give Y. So the X chromosome never goes. So if there is no dad to son transmission, I think of an X-linked dominant. But if there is a dad to son transmission, it's not related to X chromosome, it's related to autosomes. I can clearly say it's an autosomal dominant, right? To prove it is X-linked dominant, I need to ask one more question. Same thing. X-linked dominant, I have faulty X chromosome. I'm giving birth to a girl child. Every time I give birth to a girl child, will I transfer the X chromosome? I have to. There's no other way, right? Even if there's a 10, 15 girl child or girl zygotes produced, all of them will have my faulty X chromosome. If all the daughters of the affected kid is having the disease, it's X-linked dominant. If it's no, it's going back to autosomal dominant. Fine. This is the autosomal dominant pedigree. This is autosomal dominant flow chart. This is an autosomal recessive flow chart. These both are enough for you to solve all the pedigrees. It's very, very simple, right? Let's go and apply these pedigrees. I'll have 2 or 3 pedigrees. Just apply them. If you're able to apply before the exam, look at these 2 flowcharts, write the exam, get the right answer, forget it. That's enough. Okay, let's go to it. All generation affected, yes or no? 1, 2, 3, 4. It's not affected because the first generation is not affected. Dominant or recessive? I don't want the answer. I want the flow. Dominant or recessive? So I'm thinking of a recessive, right? If I'm thinking of recessive, the only question I'm going to ask is both men and women affected or only men affected? Both men and women affected. So it is autosomal recessive. Done. Nothing else is required. It's just generation, recessive or not. If recessive, both men and women or only men. If it's both, it is autosomal recessive, right? As simple as that. Fine. Let's look at one more guy. All generation affected or not? The answer is no, it's not affected. If it's no, I think of a recessive disorder. Right? Simple. If I think of a recessive disorder, next question is only men, both men and women. Only men. I think of an X-linked recessive disorder. It should be possible in 5 seconds. If you go systematically, you will not make a mistake. Since it's not dominant, it's recessive, right? I think it's a typo. Ignore that. Fine. Let's look at this. All generation affected or not? All generation affected or not? Answer is no. So obviously you'll start thinking of, okay, it's recessive. Then you look for both men and women being affected. Here, both men and women are being affected. So you'll type, it is classical, it is autosomal recessive, right? Amazing. So everyone who has commented autosomal recessive or who have not commented and thought of autosomal recessive, give a strong hit in your head. What's the first rule? Rules are very, very, very important. The first rule is rule out mitochondria. Make a mistake, you will never forget. And let's make sure the mistake is not happening in NEET PG. The first rule is rule out mitochondrial. The reason why I said this is the pedigree flowcharts given by Gregor Mendel. Mitochondrial is a non-Mendelian inheritance. Rule out mitochondrial. Mom affected, all son, all kids. Mom affected, all kids. Dad affected, no kids. This is the first and the foremost rule. If you miss this, you miss 4 marks. If you don't miss this, pedigree, you will never have a problem. First rule, whenever any pedigree is put to you, look for mitochondrial. Rule that out. Then these 2 flowcharts are enough. Mendel got Nobel Prize with this. 4 marks in NEET PG. It's nothing related to it, right? Let's go conceptual. No hanky-panky stuff at all. Let's read science the way it should be read, right? Okay, but please don't forget, first always rule out mitochondrial because I'm repeating it, it is non-Mendelian inheritance. Once you remember that, that's fine. Fine. Okay, thank you, Lord. Fine. Perfect. Now let's solve one more issue in genetics. The second issue in genetics is I have to memorize all the syndromes, which is dominant, which is recessive. And we have mnemonics for that. A, B, C, D, E, F, G, H, right? That's not mnemonics, that's alphabets. That kills us. Let's go concept wise. Okay, very simple concept so that you can apply to most of the common diseases. A rare disease like in ophthalmology, Best syndrome, where do you see? That I can memorize because you are never going to see Best syndrome in life, right? It's very simple to remember. For a dominant inheritance, I am not saying autosomal or X-linked. For both autosomal dominant and X-linked dominant, this rule holds true. Okay. For a dominant inheritance, dominant means how many alleles are involved. How many alleles are involved in dominant? 1 or 2? How many alleles are affected? 1 copy is affected, right? If 1 copy being affected, I have a disease, I call it dominant, which means other copy is normal. Yes. If other copy is normal, they will present early in life or late in life. They have to present late in life only. ADPKD, 40-50 years. Every dominant disorder will present later in life only. There are exceptions, ignore that. Talk about 98%. That's enough for us. They have to have later in life presentation, right? Second, most of them are structural protein errors. You must have read about hereditary spherocytosis. Structural protein problem. Spectrin and chirin, right? Marfan syndrome. Plastin, structural protein problem. Ehlers-Danlos, structural protein problem. Any structural protein problem, I'll end up having dominant disorder only, fine? Simple reason, let's assume my collagen, both of the alleles are gone. Can I have a skeleton? It'll break. I'll have an intrauterine death, right? Next, cancer syndromes. You must have read out lots and lots of cancer syndromes, right? Neurofibromatosis, von Hippel-Lindau disease, right? Lee-Fromney syndrome, congenital retinoblastoma. Almost every cancer syndrome will be dominant only. There are a few exceptions. Ignore the exceptions. Let's go with the plenty. And one more thing, criteria for diagnosis. Can I say neurofibromatosis as criteria for diagnosis? You have the major minor, von Hippel-Lindau, major minor, Marfan syndrome. You have criteria for diagnosis. If you have criteria for diagnosis, it is dominant. So these are few rule sets for dominant disorder. Again given by Gregor Mendel, not by me. So if it fits into this rule set, it's a dominant disorder. How do I remember autosomal dominant or X-linked dominant? X-linked dominant is very, very minuscule. Like that we can memorize. Everything is autosomal dominant. This is Robbins table. If you can solve the table in Robbins or table from Harrison with the concept, forget the exam. It will come inside the table only, right? 100% strike rate is only for books, not for us, because I'm going to lead with the help of books, right? Okay, ADPKD, dominant, cancer syndrome, hereditary spherocytosis. It's a structural protein problem. Von Willebrand disease, presents later in life. Marfan syndrome, structural protein problem. Ehlers-Danlos, structural protein problem. Osteogenesis, structural protein problem. It will fit into this pedigree. It will fit into this rule, right? If you have any syndrome where you want to know whether it's dominant or recessive, look at this first. It's later in life presentation, dominant. Cancer syndromes, dominant. Has structural protein problems, dominant. Has criteria for diagnosis, dominant. Which means I should have something like this for recessive. That makes my life much, much more easier, right? Let's look for recessive also. Recessive, simple logic. 1 copy mutation, 2 copy mutations. Recessive is 1 copy mutation, makes it carrier. 2 copy mutation makes it a disease. Recessive means I have to have 2 copy mutations, right? If I have 1 copy mutation or 1 allele mutation, I'll call them a carrier state or a trait. I'm sure you must have read about this, right? I'm just going to rephrase the question. If this is true, will dominant disorder have carriers? Yes, no, maybe. Can a dominant disorder have carriers? A dominant disorder can never have carriers, because one is gone means in dominant is a disease. It's not a carrier state. So in other words, every disease, whatever you know has carrier state, should be recessive. Thalassemia, recessive. Sickle cell anemia, recessive. There are carrier states. Why should I memorize the recessive inheritance? You know the inheritance by default, right? So it's carrier state, right? So recessive 2 copy errors will have definitely early life presentation. Presenting at birth, recessive by default. All the inborn errors of metabolism or your enzyme errors has to be recessive. There's a big table for mucopolysaccharidosis in your biochemistry, right? Everything is autosomal recessive except for hunters. Hunter is a male. Just remember, X-linked recessive. Rest everything has to be autosomal recessive. Almost every glycogen storage disorder is autosomal recessive. Don't memorize. It has to be recessive by default because they present at birth, right? Carrier state is there. It's recessive. Fine. Okay. Fabry, fine. Okay, it's recessive. So these are my rule sets. Let's go with the Robbins table. Cystic fibrosis. Can I say presence at birth? It presents at birth. You know that. Meconium ileus. Recessive. Phenylketonuria, enzyme, lysomal, again enzyme, Wilson's, presence early, enzymes, all recessive. Trait, both of them have trait or a carrier state, recessive. Congenital adrenal hyperplasia, can I say it's an enzyme defect? You know what enzyme? Can anyone tell me what enzyme defect? It's a recessive disorder by default. Alkaptonuria, enzyme defect, recessive disorder by default. Rules. These are Mendel's rules. It will never go fault. There are exceptions. Let's read sometimes later. But for a NEET PG, there should be more than enough for you, right? Just 4 rules here. Cancer syndromes, later in life presentation, structural protein problem, criteria for diagnosis, dominant. Early in life presentation, all inborn errors, all your enzyme defects, carrier state is there. I think of a recessive disorder. Very, very simple things, right? Just remember them. That should be more than enough for us for genetics, fine? Then few investigational choices. That will be the last thing in genetics. I know genetics might be boring, but there are very high yielding plays in genetics which can get repeated. Let's learn them. So whenever you have a patient with a chromosomal disorder, we had a question in this NEET INSD on aneuploidy. Aneuploidy, it's simple. Euploidy means 46 chromosomes. Aneuploidy, not 46 chromosomes. That is aneuploidy. So An is absence, anaplasia, no differentiation, aneuploidy, no 46 chromosomes. Any disease with aneuploidy, Turner's, Klinefelter's, your trisomy, Downs, Pato, Edward, or any disease with translocation, 922 and everything, right? All these group, I'll think of fish is better than karyotype. Okay, In only one place, I'll prefer karyotype because fish is very, very, very specific. That's why I prefer fish than a karyotype. Karyotype is very, very, very sensitive. If a question is saying like I have to diagnose Ewing sarcoma, translocation base 1122, fish. CML 922, fish. If it's translocation, fish by default. I have to diagnose Down syndrome, I'll prefer fish by default. Where will I prefer karyotyping is simple. Let's say it's an abortus. Abortus in the first trimester. Can I say genetic disorder is one of the important causes relating to OBG? Yes. Jitu, point mutation will not be picked up in both of them. Fine. It is. Now, in abortus, first trimester abortion, can you say it's due to Turner or Downs or Edward or Pato or trisomy 16? Can you say? I cannot say. I don't know what it is. I cannot pinpoint one. That time, I will prefer karyotyping. Because karyotyping is sensitive. I can look at trisomy 16, I can look at your Downs, I can look at your monosomy X, I can look at everything. There I need a sensitive test. In every other place where I'm going to think of a chromosomal disorder, in diagnosis for a patient, I go for specific, I go for fish. The only place where karyotyping is more helpful is abortus, right? Chromosomal arm or exon deletion. The best example for this is your, which disease has that sign climbing on themselves? You will put pressure on your knees, hips, Grover sign positive. Which disease is that? Grover sign positive, DMD, Duchenne's muscular dystrophy. There's one more disease called as Charcot-Marie Tooth disease. You must have read about them. These are problems with exon deletions and duplications, right? Both for DMD as well as Charcot-Marie disease, the investigation of choice is a test called an MLPA. Okay, MLPA is the investigation of choice, right? It's multiplex ligand dependent polymerase chain reaction, but just remember MLPA. For chromosomal arm deletion, duplication, I go for MLPA. Fine. Point mutation. Like someone asked for point mutation. Can I say sickle is a point mutation? Sickle is. Tal can also be, right? For point mutation, investigation of choice is undoubtedly your PCR and its variants. Could be a real-time PCR, could be a reverse transcriptase PCR, PCR and its variants, that's all. That's the investigation of choice. But if the question is saying gold standard for point mutation, you have to go for sequencing. The first person who sequenced a gene is Sanger, who sequenced insulin gene. That's why he gave his name Sanger sequencing. Gold standard is Sanger sequencing, but for all practical purposes, we can do a PCR by default. This is for every point mutation. There's an old PYQ. Point mutation cannot be picked on karyotyping or your fish because they are very, very small to look on karyotyping of fish. Fine. Okay. Quantitative. If you have to measure the mutation, I know mutation is there, but if you have to measure, what's the test you do? If you have to measure a mutation, what's the test you do? I'll tell you utility of quantitative soon. It is real-time PCR. It is qPCR. First error. RT-PCR is not real-time PCR. qPCR, quantitative PCR is real-time PCR. Cryptic commenter, RT-PCR is not real-time PCR. qPCR is real-time PCR. Q here stands for quantitative. Okay. RT-PCR is reverse transcriptase PCR. Reverse transcriptase can also be real-time, please remember. Why should I measure? The best example is, which disease do you give imatinib for treatment? Anyone? Imatinib for treatment. CML. I gave imatinib for a patient. I need to see whether it's working or not. So should I know the number of BCR-ABL transcript? Yes. That's where I use this. I give imatinib. Before treatment, BCR-ABL was 1000. I give imatinib, it has to come to 100. It is not coming to 100, resistance. Change the drug. Change to ponatinib. Change to dasatinib. I need to know the viral load. Is it must for me to know viral load in HIV? Hepatitis B? Required. COVID? Not that much, but yes, for HIV, I need to know whether it's working or not, right? Fine. Here. Again for cancer. Best example, I gave imatinib because you can easily relate it. Fine. I can also do reverse transcriptase, right? We call it real-time reverse transcriptase PCR. This can be done for simple things because reverse transcription can be done only for RNA products. If I'm doing taking care of an RNA virus, I do this. HIV I can, COVID I can, RNA virus, convert to DNA and do it, right? Reverse transcriptase is done for anything related to RNA, convert to DNA. Fine. Cryptic commenter, reverse transcription is converting an RNA to DNA. Let's assume HIV virus. I'll have to convert the RNA to DNA first. Then if I have to do the viral load, I use this real-time reverse transcriptase. qPCR is only real-time PCR. Like imatinib, BCR-ABL, it's already a DNA product. I use only qPCR. If it's HIV virus, convert it to DNA, then quantitate. COVID, convert to DNA, then quantitate. There I use real-time reverse transcriptase. Fine. Okay. Great to let in blue. Hope that clarity you'll have much more when you go to MD or MS of your field of choice. Done. These are few informations regarding investigation of choices. Fine. Great. Let's go to amyloid. Amyloid is something which is definitely a repeated topic. You might get one or something question related to amyloid at any point of time. And the most important thing is amyloid is not being discussed in other subjects. You might have multiple overlapping topics in pathology. This will stick to pathology alone, right? It's a non-branching beta pleated sheets. What does oid mean? Oid means like. Amyloid was thought to be amylin-like. They thought it's starch-like. It is not starch-like. It is protein. Now we know that it's protein. It's a malformed protein product. That's all, right? It's a beta pleated sheet. This can also come in an exam. Fine. It's a non-branching beta pleated sheet. Look at this. We'll use this very soon. Now, multiple different types of amyloid. Tell me, where do you see all 111? Where do you see AL? Hi, Negi. AL amyloid, you see them in myeloma. Right? AL is light chain. Light chain amyloid is where it deposits in kidney. That makes it the common site as well. Perfect. Great. Where do you see A? AA, it stands for SAA, which is serum amyloid A protein. Actually, serum amyloid A protein is an acute phase reactant. So in a chronic inflammation, too many serum amyloid A protein. Anything chronic inflammation. Okay, any chronic inflammation, I'll see this. Rheumatoid arthritis is much more common than TB here because TB I can treat. Fine, perfect. Anything fever related, anything chronic inflammation related. Amazing. A beta 2M. Beta 2M is beta 2 microglobulin. Dialysis machine cannot remove this. So in patients with chronic hemodialysis, again the older machines, newer machines are much more efficient still. In chronic hemodialysis, I am not able to remove, so slowly accumulates and produces a deposit. That's all. ATTR. TTR stands for transthyretin. Okay. Transthyretin. I have here one is senile amyloidosis. In senile amyloidosis, you have normal transthyretin. It's not mutated. It's normal transthyretin. Fine. Yes, Manu. Okay. One more thing, I have familial amyloidotic polyneuropathy. That's also a problem. Familial amyloidotic polyneuropathy. If it's familial, it's a disease, right? We have mutated transthyretin. Okay. Perfect. Please remember, two of you used the term wild. Wild means normal. Okay. Wild means normal. So normal transthyretin is senile. Mutated transthyretin will be familial amyloidotic polyneuropathy. ACAL. Where do you see cal? Calcitonin. Cal cancer of calcitonin. You see them in medullary carcinoma of thyroid. Okay. Cal stands for calcitonin, which is in localized amyloidosis. Fine. Perfect. A beta. Where do you see A beta? A beta. A beta is classical. You see them in Alzheimer's disease. Okay. A beta is actually a broken part of APP. APP is amyloid precursor protein. This broken part is the A beta, which gets deposited in the brain. Now it makes beautiful sense. A beta, so the APP protein is seen in chromosome 21. Who has more chromosome 21? Who has more chromosome 21? No cat. Prions are a bit different from amyloid, but they are also protein product. Down syndrome. Now, can you relate Down says increased risk of amyloid? Because Down says 3 chromosome 21. So more APP, more deposit. That's why patients with Downs will have an increase in risk of amyloid. An increase in risk of amyloid because of that. That's all. It's simple. No need to memorize. You know the logic. You can easily relate it. Fine. AIAPP. This is islet amyloid polypeptide. It's an islet amyloid polypeptide. That's all. Islets of Langerhans. So it is seen in diabetes. Which diabetes? Type 1, type 2. देखिए आपका डाउट क्या है पूछो, मैं अंग्रेजी में रिप्लाई करूंगा, हिंदी थोड़ा दिक्कत है. You see them? Type 2 diabetes. Perfect. Because in type 2 diabetes, I'll have more insulin production, more C protein, more amyloid deposit. Type 1, no insulin production, no problem at all. Fine. Okay. This is your islet amyloid. And also I can see them in insulinoma. If it's a tumor, obviously it doesn't make, it's easy, right? Insulinoma can also have that, right? So these are places where you can see amyloid. It can have a scenario based question or a one-liner based of it. And obviously most common organ is renal. Most common or cause of death in amyloidosis. What's the most common cause of death in amyloidosis? Cardiac. Most common organ is renal. Most commonly you'll have renal failure. But renal failure, I can do a transplant or a dialysis. It will not cause death. Heart amyloidosis, conduction defects, restrictive cardiomyopathy. Heart transplant is not that common, so it's a common cause, right? And the most sought out or the most sensitive or specific, whatever you want, is abdomen fat pad. It is not rectal biopsy because it's difficult to perform a rectal biopsy. The reason I'm going for abdomen fat pad is amyloid always deposits around a vessel. That's why I need a vessel to demonstrate. I go for rectum because rectum also has more vessels. Remember hemorrhoids, very high density of vessels. Fat also has very high density of vessels. Remember insulin, I give it there, right? It will be there, Moni. I give it there, right? So around the vessel, that's why I take fat pad aspect. The same reason for I take rectal, or the same reason you take a lip biopsy, fine? Microscopy, amyloid will be pink in color in a HNE. This is just an amyloid. Amyloid is acellular, extracellular, proteinaceous, or pink color deposit. When I do a Congo red and I look in the light microscope, can I say this is salmon pink? It's pink only, little bit lighter orange shade of pink, right? This is Congo red, the salmon pink appearance. This is seen in light microscopy. When I same put a polarized light, we have the apple green birefringence. Okay, those are three things in amyloid. Please remember them. There are many stains for amyloid. Congo red is the best. You have thioflavin, you have PAS, you have multiple things there. But Congo red by default is the best. I hope they won't ask anything beyond that. The reason for polarized light apple green is this is non-branching. This was asked in one INACT beta pleated sheet. Okay, you know what Congo red does? Gopika fat pad biopsy. Congo red bridges them. So Congo red goes and bridges them. That's all. So it's a beta pleated sheet. I bridge them. When I throw a light now, will it create a different image? It does. That's apple green birefringence. That's all. It's a property of light. All of you must have seen a polarized microscopy. How many of you have seen a polarized microscopy? How many of you have seen a polarized microscopy? Yes, no, maybe. So Congo red bridges the beta pleated sheets, which causes the polarizing effect. None of you have seen a polarized microscopy? No? Come on, you have. Have you been to 3D movies? You have been to 3D movies? Have you played with the glass? Change like this, pull it out, put it inside. Have you done that? That time, have you seen a color change? Have you noticed that? You must have noticed that. That's polarizer. You don't want hospital to learn medicine. It's science. It's there in your life. That is polarizer. That's all. Change in color. The same concept happens here. Change in color. That's a polarizer. Fine. Not at all red and blue. You just need to, if you want to read more, that's better. But yeah, pathology is more theory dependent subject. Fine. Okay. Simple. Polarizer is simple. Silicose is polarizer. No, I'll give you a simple example. Have you been to beaches? When you go close to the shore, the sun becomes very, very, very bright. You know why? The sand of the beach, which is silica, reflects the light. Polarizing effect. That's all. That's why silicose is polarizing effect. Simple, no? Medicine is very simple if you look at from that spectrum. Okay, let's go to MCQs. Our problem is this. Try to solve this. It's an easy one. Let's go to the next after you solve this. Science is school cryptic, not me. A, B, C, or D. Such a big history. Again, just to give you a hint that cardiac amyloidosis can present with this. Right? Okay. Underpolarized light birefringent. So obviously I have a beta peter sheet misfolded protein of amyloidase. Okay. Next. Might be a bit difficult. Let's see. Just try it out. It's not a very simple question. I'll give a simple scenario which can come in NEET PG exam because this is a little bit more complicated. If you're writing USMLE might help. Okay, let's ignore this question. The answer for this question is option D. I'll not go to that because it's a little bit more complicated. I'll give you simple scenarios. Fine. One parent has thal major. Okay, this came in an exam, right? And other parent is completely normal, which means genetically also normal. Genetically also the person is normal. What's the chance of the kid to have the disease? To be affected. Can anyone tell? This was an old PYQ. What's the chance of the kid to be affected? One parent is thal major, other parent is completely normal. What's the chance of the kid to be affected? The answer to this is, most of you will answer 25. I'm sure the answer to this is 0%. It's not 25%. And it's 0%. Please remember, I'll tell you why. Why very, very soon. Okay. One parent is completely affected. Let's assume small a is completely affected. The other parent is completely normal. Let's assume capital A is for normal. Which means, can I say the maximum is all will be carriers? Or will there be anyone affected? 0% affected and all will be carriers. Cryptic update, that logic is true, but let's say the patient had some bone marrow transplant and the patient survived. Fine, all carriers and not affected. Please remember, this is a difficult trick question. Fine, okay. Now let's come to the easier ones. Two parents are carriers for phenylketonuria. What's the chance of the kid to be affected? What is the chance? Okay. Chance of the kid to be affected? This is straightforward one, right? You won't have a problem. This is perfect. 25% chance of the kid to be affected, which means both are carriers. Obviously, one comes, right? That's the general inheritance risk of an autosomal recessive trait. Fine. Next, let's say one parent is having Marfan syndrome. Okay. What's the chance the kid to have the disease? One parent is having Marfan syndrome, chance of kid to have the disease, which is, this is also a simple one, autosomal dominant, which is perfect, 50%. That's how it is, right? Amazing. This is very simple. Let's tweak this a little bit. Both the parents are having Marfan syndrome. What's the chance the kid to have the disease? This one. Both the parents are having Marfan syndrome. What's the chance of the kid to have the disease? Great. Please don't memorize this and write as 100%. It can never be 100%. It can be only 75%. It's not 100%, right? So this might be the knee-jerk response. You might say it's 100. It's 75. This was an old NEET PG question. Again, it will be 0% if one parent is genetically normal for any autosomal recessive disease, not just thalassemia. Fine. Just remember that. Cat homozygous autosomal dominant disorder, they will be aborted, they will not be born. Any homozygous autosomal dominant disorder, the kid will not see the life, the kid will be aborted. That's the reason the homozygous heterozygous will not happen. Fine. Okay, perfect. Let's go to neoplasia. So neoplasia is something which might not have a direct question from neoplasia, but I'm sure at some point of time cancers will have a question, right? This INICD also had a question on ovarian tumors. There's much of worry that whether it's serous or mucinous. Most of them wrote mucinous because there are cystic spaces. Cystic space is not equal to mucinous adenocarcinoma. 40-year-old having ascites with your CA120 of 996, benign or malignant? It is malignant. That's the basic concept. Okay. Dr. Sharanya, why 75% is? I'll just quickly write that. Let's say capital A, small a. Small a is being affected. Again, this is capital A, small a. Small a is being mutated. This kid will be normal in the permutation combination. Rest everything will be affected. So it is 75% affected and 25% normal. Fine. So basic concepts of neoplasia will help us to swim through complex scenarios. I need not diagnose everything only with the markers, only with the CT scan, only with the MRI scan, or with the genetic test. I can diagnose with simple scenarios. Jitendra, ascites is a feature of malignant ovarian tumor first. CA125 of 1000 is a feature of malignant ovarian tumor by default. So these two are enough for me to call it malignant. I don't even come into microscopy. These two are enough for me to call it malignant. In the gross, and also the history, the question had omental caking, which means omentum deposit. Omental deposit in ovarian tumor is malignant by default. Right? So these are informations which I want you to remember when solving a scenario-based question with related to neoplasia. Fine. Let's go to few genes. Whatever genes we read today are very important because these are all used in day-to-day practices. Whatever genes which are there in Robbins, which are not used in day-to-day practices, we are not going to read them at all. Fine. Okay. Again, here I'll restrict myself to very simple things. EGF receptor family, I have ERBB1, that is EGFR, and I have ERBB2, that is HER2/neu. Where do you see HER2/neu? This also came once in an exam. If I change the name to ERBB2, many of you will miss it. ERBB2 or HER2/neu is seen in, obviously seen in breast cancer. Okay. EGFR, at least one, I don't want you to forget this. It is seen in perfect lung adenocarcinoma. Okay. ERBB1 is the other name and ERBB2 is the other name, right? So whatever I ask, you should be able to write the answer. ALK. ALK, two things don't forget. ALK stands for anaplastic lymphoma kinase. Fine. So ALK stands for a lymphoma called as ALCL, anaplastic large cell lymphoma. Okay. And also it's seen in lung adenocarcinoma. It's by default named as anaplastic lymphoma kinase. Fine. KRAS. KRAS is the most common proto-oncogene mutated. Almost every cancer in my body will have one or other point of time KRAS. Things don't forget: lung, colon, pancreas. Wherever you go in the pathogenesis, it will be there. But these three don't forget, because pancreas, it said that if KRAS is not mutated, it's not pancreas. Colon and lung, it affects the prognosis. Also remember, whenever KRAS is involved, it has a poor prognosis. KRAS mutated lung adenocarcinoma is poor compared to EGFR mutated lung adenocarcinoma. Same with colon as well, because the chemotherapy will not work very much whenever KRAS is mutated, right? ABL. Where do you see ABL? ABL is something very, very, very simple, right? You see ABL in CML, BCR ABL. ABL is a proto-oncogene there, right? It's seen in CML, fine, perfect, in Philadelphia. JAK2. JAK2, obviously one thing is, you know that it's seen in polycythemia vera. If the question is most common associated JAK2, polycythemia vera, but it's also seen in essential thrombocytosis. It's also seen in myelofibrosis. It's seen in almost every myeloproliferative disorder. The most common is by default polycythemia vera, right? Every myeloproliferative disorder, I'll see them, fine? Okay. c-KIT. c-KIT, whenever it's positive, remember this, the IHC involved will be CD117. Do you remember now? Why does GIST is CD117 positive? Because of c-KIT mutation, right? c-KIT mutation is seen in GIST, can be seen in mastocytosis. And whenever c-KIT is positive, it is a tyrosine kinase. It's a tyrosine kinase, and by default, I can use imatinib for that. Seminoma also, it is positive by default, fine? Okay. Seminoma means also dysgeminoma. I'm not going to melanoma primarily because there are lots of things in melanoma, not just c-KIT. c-KIT also will happen, fine? Okay, great. And all these are proto-oncogenes. Whatever we read here are proto-oncogenes. Proto-oncogene, the normal function is to help cell division. So tell me, in all these conditions, what mutation should cause it cancerous? Gain of function, loss of function. All of these are proto-oncogenes. Their normal job is to help in cell division. So by default, whenever I have a gain of function mutation only, it can cause a cancer. All these are gain of function mutation only. It cannot be loss of function. It's loss of function, no division at all. Since normal is cell division, gain of function, more cell division. Fine? Perfect. And whatever we are going to read now here, they are all tumor suppressor gene. There are few things very, very common for tumor suppressor gene. Tumor suppressor. So what do you think is a normal function? Normal function is to reduce division. Right? Perfect. Listen to me very carefully. When I say the normal function is to suppress cell division, what mutation should cause cancer? Gain of function, loss of function. All the tumor suppressor gene should be loss of function mutation. That's the first thing. Okay. Again, listen to me carefully. I'm having 2 copies of every gene. Let's assume one copy has lost the function. Can other copy still suppress the cell division? Yes, no, maybe. I repeat, I have 2 copies of gene. One copy is lost. Can other copy still suppress cell division? It can. So when will I have cancer? When the second copy is also gone. That's your Knutson's 2-hit hypothesis. That was discovered in retinoblastoma, but true for every tumor suppressor gene, right? Okay. Your Knutson's 2-hit hypothesis is true for every tumor suppressor gene, but it was discovered in case of a retinoblastoma, right? I should have 2 allele loss for me to cause a cancer. That's what Knudsen said, right? Perfect. So there are few tumor suppressor genes which are must for us to remember. Retinoblastoma. If possible, remember chromosome 13p14. That's a location. I hope they won't ask these chromosome number in future at least. But yes, I'll see retinoblastoma and also I can see osteosarcoma. These are 2 tumors where you can see them. Pretty common to see retinoblastoma mutate in case of an osteosarcoma. Fine. Okay. Pineoblastoma is fine. If you want to add to it that as well. Fine. P53. This is the most common gene mutated across every cancer. P53. This please remember. I want you to memorize this. I don't want you to forget this at all. 17p, 13 or 17p is enough. Wherever you see 17p loss in any cancer throughout the body, worst prognostic factor. I can generalize. Acute myeloid leukemia, chronic myeloid leukemia, myeloma, non-Hodgkin's lymphoma, breast cancer, anywhere, when 17p is lost or 17p is deleted, it's by default a worse prognosis. Always remember, and this was also called as a guardian angel. The guardian angel of the genome. The guardian angel is not changed to P10, it is always P53, right? And like I said, Li-Frommney is the mutation. So now, cancer syndromes, Jitendra, like I said, there are many places where RB will be involved, but I'm going to remember them based on retinoblastoma and osteosarcoma, fine? Coming back to this, cancer syndromes, I have to identify with them few clues. Let's say a person has both breast cancer, ovarian cancer. What's the first gene comes to your mind? Breast cancer, ovarian cancer. BRCA, right? By default. Like that I have a cluster. I say retinoblastoma, osteosarcoma. RB gene comes to my mind. I say lobular carcinoma of breast and your gastric diffuse carcinoma. CDH1 comes to my mind. So I have few clues like that. Whenever you see hematology, breast, CNS, sarcoma, this combination you think of Li-Frommney. These combinations are very important for me to pick up cancer syndromes, right? Let's say CDH1. CDH1, it codes for E-cadherin. Normally it codes for a protein called as E-cadherin and will be lost in case of lobular carcinoma of breast and also diffuse gastric carcinoma. Why do I call it diffuse gastric? Diffuse means all over. E-cadherin is lost. Function of E-cadherin is to hold cells. I don't have anyone to hold, so it diffuses everywhere. Let's make it even more better. If it diffuses everywhere throughout the stomach, can I say throughout the stomach, I might have fibrotic or desmoplastic response? Yes. Like Jittu said, can I say because of the diffuse fibroblastic response, the entire stomach becomes very firm, like a leather bottle or a Linitis plastica. It's related to the pathogenesis. And if you remember surgery, it will be written that in endoscopy, I won't see a mass because it's diffuse. Then how do I pick up? I have fibrosis underneath. Rugosity will be lost. That's how you pick up diffuse gastric carcinoma in endoscopy. Because Linitis plastica has a cut surface appearance. I cannot see them in endoscopy. Medicine is beautiful. Let go of this exam. After June 15th, you want to love medicine, start reading physiology and pathology. It'll make sense. Once it makes sense, it's not a burden. Fine. Let's come to VHL. Von Hippel-Lindau, seen in chromosome 3. Okay. Von Hippel-Lindau syndrome. Few things to remember. Clear cell RCC. Cerebellar hemangioblastomas. Okay. These are few things to remember. And also remember, both these will have PNS for paraneoplastic syndrome of polycythemia. Because von Hippel-Lindau is related to polycythemia. Everything is related. Fine. Okay. APC, tumor. APC is colon polyps. Your familial adenomatous polyposis is your APC, right? One more simple question I'm asking you. Have you heard about this concept? Incomplete penetrance, variable expressivity. Yes, no, maybe. How many of you heard about these? Incomplete penetrance and variable expressivity. You might have. Definitely you might have, right? Which disease has this? Which inheritance has this? Dominant or recessive? Dominant has this, right? Perfect. So dominant syndromes will have incomplete penetrance. We just now read in genetics. Can I say all these cancer syndromes are dominant? Not neurofibromatosis, every dominant syndrome. All these cancer syndromes are dominant? It has to be dominant. So in that case, sense, can I say APC mutation can have variable expressivity? Yes, no, maybe. It can. Beauty. That's the beauty of learning medicine. And interlinking facts. I have a variable expressivity called as Gardner syndrome, which is APC loss plus colon polyp plus osteoma and skin defects. I have a variable expressivity of APC, which is Turcot syndrome, which is APC plus colon polyps plus medulloblastoma in your CNS. It's the same thing. I'm going to apply it in different places, right? CNS tumor Turcot, osteomas. I remember Gardner person having injury in the skin and bone tumor is for Gardner syndrome, and Turcot syndrome for your CNS tumors, Turcot brain syndrome, right? Simple. STK11. This also came related in your INCD, right? Not at all. Everyone is, medicine will make you feel humble. You're being humbled by medicine. That's all. Tolerant, bro. You're not dumb. Okay. STK11 or LKB1. Okay. Perfect. Seen in Peutz-Jeghers syndrome. Okay. It's in Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, obviously, I'll have colon polyp. Along with that, there's an increase of stomach cancer. Please don't forget pancreas. The most important thing in Peutz-Jeghers is pancreas. It said that it will increase the risk of pancreatic cancer by 50 times. 50 times. More than colon, more than gastric. It will also increase the risk of breast cancer. When I see pancreas, breast, stomach and colon, I think of Peutz-Jeghers syndrome, right? Perfect. Chitu told one more information. Mucosal pigmentation. Great. Fine. Want to know the logical explanation of mucosal pigmentation? If many of you say yes, I'll give you a logical explanation. It's beautiful. You will never ever forget why mucosal pigmentation happens, right? Peutz-Jeghers polyp and also the arborizing polyp, like Manu said, that is also related to the pathogenesis. Fine. See, Peutz-Jeghers syndrome, the only problem is the STK11. STK11 is a tumor suppressor gene. Loss of function, gain of function. Loss of function, right? I don't have enough space here. I'll just add one more page here just to explain, but let's go back to it very fast. So the normal function of STK11 is to maintain polarity. That's one of the normal function. And also it helps to suppress cell division. When I say maintain polarity, what does polarity mean is, this is my mucosa muscularis propria, and let's assume this is my serosa, okay, in a GIT. This is polarity. I have layers. This is polarity. This is simple polarity, right? Now let's say if I have loss of function of your STK11, can I say, and will you guys accept, I'll have loss of polarity also? In Peutz-Jeghers syndrome, will I have loss of polarity also? Yes. Yes. Which means my body cannot maintain the layers. So my body don't know where to put muscle, where to put epithelium. So what it actually does is, it puts muscle between the epithelium. Now does it make sense? It's an arborizing polyp, looks like a tree. When you see muscle between epithelium, which is not a normal location, that's why we call it a hamartoma. It is arborizing polyp, that's all. Now let's look at a different perspective. Oral cavity is a part of GIT? Yes, no, maybe. It is a part of GIT, right? What's the oral cavity epithelium? What's the epithelium in the lip? Stratified squamous? Absolutely right. Normally, in a stratified squamous, where should be melanocytes? Basal, topmost. Normally, melanocytes will be there in basal layer, right? Perfect. Who told that to stay in basal layer? STK11. Maintain the polarity. Now, I have no STK11. There is no one to maintain polarity. So the weird rowdy melanocyte goes to the top. So when melanocytes don't know where to say and melanocyte moves up, what will be the color? Pigmentation. That's why you have oral mucocutaneous pigmentation. That's medicine for you. It's simple. It's beautiful. We are running behind a stupid MCQ and losing the beauty of medicine. Run behind the beauty of medicine. MCQ will automatically fall in place, right? And please tell to your juniors, it's fine. It's fine. Let them read more. Let them get more knowledge, MCQ will be sorted without any problem. Okay, let's go to PNS. Paraneoplastic syndrome by default is one of the important topics which you guys have to read. Fine. Okay. Can we take a 10-minute break and come back to this, or 5 minutes break? I won't close this. I'll just turn on my audio, or turn off my audio and video. I'll just go and have a cup of water. Go have a cup of water. If you want to pee, go pee. 5 minutes. 5 minutes is enough, right? It's now 1, and let's start by 1:05. Fine. Okay, guys. See you by 1:05. Hey guys, can you hear me? Can you see me? Are you guys back? Back? Hello, SS. Okay, great. Let's start. Just 5 minutes just to empty your bladder and fill in your tummy with coffee, tea, or water. Hello, Manu. So let's go back to neoplasia. We have two important things. These are more factual, and but there is a very good chance, like we had the serous carcinoma and CA125 linked by a tumor marker or a paraneoplastic syndrome, which will definitely make sense for you in the exam point of view, right? Fine. Okay. Let's start. Okay, so paraneoplastic syndrome as well as your tumor markers might not be a straightforward question. It will be linked with some scenario so that you can apply them. That's all, right? So first of all, what is a paraneoplastic syndrome? By definition, I'll call something as paraneoplastic. Is when the symptoms or sign is not related to anatomic origin or physiology. I'll try to explain this. Fine. Let's take, for example, I have a patient with a prolactinoma, which happens in the pituitary. Can I call galactorrhea as a paraneoplastic or a symptom? What do you think? Is galactorrhea a paraneoplastic syndrome or a straightforward symptom? Is a straightforward symptom because it secretes prolactin and causes prolactinoma, galactorrhea, right? Simple. A patient having an Cushing's syndrome in an ACTH secreting pituitary adenoma, paraneoplastic or straightforward symptom? Cushing's in ACTH secreting pituitary adenoma. It is symptom. A patient having Cushing's in lung cancer, paraneoplastic or straightforward? It is paraneoplastic because lung cancer has nothing to do with glucocorticoids, mineralocorticoids, or ACTH secretion. That it is paraneoplastic. It should not be related anatomically. It should not be related physiologically. Then I can call it a paraneoplastic syndrome. That's all, right? Cushing's is the most common endocrinopathy in case of paraneoplastic syndrome, and the most common paraneoplastic syndrome overall is by default hypercalcemia. Fine. Where all do you think you will see Cushing's syndrome? Cushing's as well as one more paraneoplastic syndrome, which is SAADH. Both of them are common in small cell CA of lung. This is one of the commonest disease with so many paraneoplastic syndrome, right? Small cell carcinoma of lung. You can see lots and lots of Cushing's and lots of SAADH as well, right? At the same time, where do you see hypercalcemia? It's also seen in a lung cancer only. Which type of lung cancer? You see hypercalcemia in? Perfect. You see them in squamous cell carcinoma of lung, right? You can also see them in breast cancer. You can also see them in myeloma. Okay. In all these conditions, there's a substance called as PTHRP secreted. Most of the time, I have a substance called PTHRP, which acts like parathyroid, parathormone related peptide, something related to it, which does the function of parathormone, causes hypercalcemia, right? Perfect. Polycythemia vera, where do you see them? We already read one hipalindo. There also I gave a hint. Polycythemia is seen in renal cell carcinoma, cerebellar hemangioblastomas, okay, and also it is seen in hepatocellular carcinomas. Few variant of hepatocellular carcinomas, there's a possibility you can see paraneoplastic syndrome of polycythemia vera, right? Again here, this function is they secrete erythropoietin. Because of more erythropoietin, I have more of RBCs, which results in polycythemia vera. Acanthosis nigricans, where do you see? Simpler way to remember, it's seen in internal GI malignancies. Just remember as internal GI malignancy. Quite a few conditions can have acanthosis nigricans, gastric, some case of colonic as well. Lung cancer, you will see them. And also you see them in leiomyosarcoma. Uterine leiomyosarcoma, it's one of the classical paraneoplastic syndromes, acanthosis nigricans. Why is acanthosis nigricans coming is, it's simple, due to EGFR. Epidermal growth factor receptor was mutated in lung cancer, right? Epidermal growth factor receptor, it divides epidermis a lot. That's why I have EGFR as a name. When epidermis grows a lot, basal layer divides a lot. Basal layer is where I have melanocytes. That also proliferates a lot. So the color, thick black skin in the nape of the neck is acanthosis nigricans. If it's not cancer related, the first disease you have to remember is insulin resistance and diabetes, fine? Trossius phenomenon. What does Trossius phenomenon mean? Trossius phenomenon is different. Trossius syndrome is different. Trossius sign is different, right? Trossius phenomenon is your superficial thrombophlebitis. Okay. Superficial thrombophlebitis is Trossius sign. So Trossius phenomenon. Where do you see Trossius sign? You guys should know about Trossius sign. Migratory superficial thrombophlebitis. Absolutely right. Perfect. So Toludin has said pancreas and Manu has said adenocarcinoma of lung. I'll give you a very simple correlation. Any mucin secreting carcinoma can cause it. If you take a very old PYQ, it is said that only pancreatic. Now we have changed it. It's not just pancreatic. I can see them in stomach. I can see them in lung. I can see them in pancreatic also. Because all of them will secrete mucin. That's all, right? So any mucin secreting can be pancreas, can be lung, can be gastric, can be colonic. If it's mucin secreting, because mucin can trigger clot formation. That we know with the help of DIC. So that goes and triggers clot formation where you have mucin secreting adenocarcinoma. Hypocalcemia, you have Troisius sign, right? Red cell aplasia and also myasthenia gravis. Which tumor? Both of them has been asked in PYQ at different points of time. Both are autoimmune conditions. So autoimmune destruction of RBCs and myasthenia gravis is seen in case of thymoma. An organ which controls or stops the autoimmune function is going rogue. So I'm going to have this, right? Both of them are related to thymoma. Both are immunological dysfunctions, fine? Okay. Tumor markers. Tumor markers are not only diagnostic. It's an adjunct to diagnosis. Tumor markers, let's say PSA. Am I right in saying that BPH also there'll be elevated PSA? Yes or no? Benign prostatic hyperplasia. Will that be elevated PSA? Absolutely yes. So it's not by default only cancer. Inflammation can have. CA125 will be increased in endometriosis. Right? Right? CA125 can be elevated in case of an endometriosis. Chocolate cyst. It's not just cancer. In quite a few conditions, I can be elevated. But if it's like thousands, very high, by default, think of a cancer, right? HCG, where do you see them? You can see them in choriocarcinoma. In choriocarcinoma, by default, elevated beta HCG, right? One more thing, I am sure most of you guys will remember. Where else you see elevated beta HCG? That's a part of a PYQ which has been perceived wrongly. In 10 to 15% of seminoma. Not every seminoma. Please remember, beta HCG has nothing to do with seminoma, but 10 to 15% of seminoma can have syncytial trophoblastic cells. That can also. And like Akshaya said, molar pregnancy will definitely have elevated beta HCG. When I talk about tumors, these ones. Fine. Calcitonin, it's medullary carcinoma of thyroid. Right? Catecholamines, where do you see? Catecholamines or a metabolite of catecholamines. You see them in pheochromocytoma. The VMAs, catecholamines, metanephrines and everything, right? Problems in the adrenal medulla, I have them, right? Okay. And just these are few ectopic hormones. Alpha fetoprotein, where do you see alpha fetoprotein? Yolk sac tumor, Ria, do you see, what do you see in yolk sac tumor? We see the alpha fetoprotein is seen in yolk sac tumor, right? Okay, alpha fetoprotein, HCC, yolk sac tumor, you can see an elevated alpha fetoprotein, or a non-seminomatous germ cell tumor, I can see an elevated alpha fetoprotein, primarily yolk sac tumor, right? Okay, perfect. Now, I just wanted to add one more thing here. Hepatoma. What do you understand by the term hepatoma? What do you infer by the term hepatoma? It looks like it's a benign tumor, right? Hepatoma is the malignant old name for hepatocellular carcinoma. It's been removed because it caused confusion. But if there's any old examiner who says that hepatoma is there, which means it's hepatocellular carcinoma, not an hepatic adenoma. Please remember that it's an old name for HCC. Please do remember that. It's malignant, old name for HCC. Since it's causing this confusion, they have removed it. Fine. Okay. Carcinoembryonic antigen. It's also related to mucin, which means in colon, in lung, in pancreas, wherever I can see migrating thrombophlebitis or Troisius sign, I can see CA being elevated. Very, very non-specific by default. PSA, I can see in both BPH as well as prostatic carcinoma. Prostatic carcinoma, they asked about Gleason scoring long back. If they want to go into the microscopy of prostatic carcinoma, remember this. There's an IHC for prostatic carcinoma called as AMACR. AMACR is a very, very good marker because AMACR will be positive only in malignant cells of prostate, not benign cells of prostate. So helps to easily differentiate them. Because prostatic carcinoma has been in news recently. Joe Biden having prostate carcinoma. If your exam paper setter is watching news, it might hit them, they might ask it. Fine. CA. Okay. All these CA proteins are nothing but mucin and its glycoproteins, right? There's a guy on Instagram called as a med school bro. Few influencers and few mnemonics are good. It sticks in your head. One of the mnemonic is this, right? CA125. He said that pancreas looks like 9. Decent. Remember like that. It's CA199. 125, you know that it's only in the epithelial tumors of ovary. It's not there in germinomas. Epithelial tumors of ovary. It's not in dysgerminoma. It's not in yolk sac. Only epithelial tumors of ovary. You'll be elevated, right? And 15.3. He said that 3 looks like breast parenchyma. So breast cancer. I know it's cringe mnemonic, but sometimes this is what strikes in the exam hall. If it works for you guys, right? So breast cancer, when you have pancreatic cancer, this can also be there in colonic cancer, but not that much useful. But pancreatic cancer is the most important for 19.9, 15.3 for breast, and 125 epithelial ovarian cancers. Fine. Okay. That's few things which tables I want to cover in your tumor chapter, right? Let's go with few MCQs. Let's see if we can pick this up. I hope you can pick it up. Let's see. See, we are learning facts. We are trying to apply them into MCQs. The same way is going to happen in your NEET PG exam also. It's a scenario-based question. They are simple facts woven into MCQs. Okay, Manu has gone with C. Anyone else? So can anyone tell me what's a diagnosis first? We obviously have this initial point there, small cell carcinoma. What do you think is the right diagnosis? Lab shows sodium level altered, osmolarity altered, imaging shows a hilar mass, small cell carcinoma. So can I say it is like SADH? Yes. So if means it's due to inappropriate ADH secretion, it's a link to a paraneoplastic syndrome where a lung cancer cell is creating ADH secretion. Fine. Perfect. Okay. Next. It's a very basic concept. Let's see if we can answer this. See, this is very simple, right? A 45-year-old person presents with the painless growing lump in the breast for 6 months. Excision, well circumscribed, freely mobile, histology shows uniform cells without mitotic figure or necrosis. The question is, which helps me to say it's a benign tumor? Poorly defined margins, malignant. Frequent mitosis, malignant. Local invasion, malignant. By default, the only thing which can help me to say it's benign is a well-defined circumscribed encapsulated mass. Lipoma versus adipose tissue. How do you differentiate? Central obesity can be called as a huge lipoma, right? Such amount of fat. The differentiation between a normal tissue and a benign tumor, that's lipoma, is capsule. Because lipoma also will have normal looking fat. Adipose tissue also will have normal looking fat. The differentiation is capsule. The differentiation between benign and malignant is also capsule. Remember, these are very simple points which might help you in writing a good answer, right? For me to call something as malignant, there are few hallmarks. All these are hallmarks for malignancy. One is anaplasia. Whenever it's in anaplasia has a worst degree of dysplasia, no differentiation at all. It's an is loss of differentiation is anaplasia. By default, I'll think of a malignancy. Invasion. By default, I'll think of a malignancy. Metastasis. By default, I'll think of a malignancy. Right? These two are like classical hallmarks. If I see this, it's definitely malignant, right? Things. In few organs, especially endocrine organs, right? Can I say pleomorphism? If it's there in a microscope, I'll think of a malignancy. Yes, no, maybe. Ria, I'm talking about microscopy where capsule helps. Other things what you're saying is definitely true. Pleomorphism, I'll always think of a malignancy, right? But in endocrine, that is not taken into consideration. In endocrine, pleomorphism is to extent normal, because let's assume adrenal gland, adrenal cortex. If you're there in front of the class and if I pinpoint the finger at you and say, tell me the answer, steroid will be more, flight and fright hormone. So my adrenal gland normally secreting this, suddenly secretes more. Normal secreting this, suddenly secreting more. So every endocrine gland or organ responds to my human interaction and stimulus. So pleomorphism is common there. So pleomorphism is normal in endocrine. That's why I always go for invasion. Invasion is very, very, very important in endocrine structure, not pleomorphism. You'll relate it. Follicular carcinoma of thyroid, pleomorphism or capsular invasion? Capsular invasion, right? Pheochromocytoma, pleomorphism or metastasis? Metastasis. Pituitary adenoma, pleomorphism or metastasis? Metastasis, right? So invasion mets are very, very important for all endocrine structure, be it in pituitary, be it a pheochromocytoma, be it in follicular carcinoma of thyroid. I need invasion of metastasis. Without this, I cannot diagnose because it's endocrine. Endocrine is different, other body organs are different, right? So these are few factors for malignancy and benign. Fine. Okay, let's go to RBC. RBC is amazing. Most of the RBC disorders we're going to learn with the help of images. Images say beautiful story in RBC, right? Sure, Sindhu. I'll definitely share once my class gets over. I'll ask them to upload it immediately. Don't worry about it. Fine. Okay. If you know normal, you know everything in RBC disorders. We'll look at an image. We'll, like I said, hematology, I'm going to concentrate more on the clue points. You look at this is the answer. You look at this finding, this is what I'm going to investigate. This is the finding, what's the next step? These are few things we're going to target with RBC. Before going to that, we have to know one normal RBC. Without normal, abnormality lost its beauty. What's the structure or shape of normal RBC? What's the shape of a normal RBC? Biconcave disc shape. I know it's nearing lunchtime. Interaction gives us more amount of knowledge and more mistakes, so that main exam you will not make a mistake, right? Biconcave shape. It's biconcave. So can I say because of the biconcave shape, hemoglobin will go to the periphery? Because someone in the center is compressing the cell, right? So because of the shape, because of the compression, hemoglobin will always be in the periphery. So when I look from the top, microscope is from the top. I look from here, slide is here. When I look from the top, the cell looks like this. Can I say the central part of the cell should be pale? Central pallor, that's 1/3 of the cell, is normal. True? It's normal, that's all. Since an RBC is biconcave, central 1/3 will be pale by default. If the central 1/3 is becoming 2/3, hypochromic anemia. If the central 1/3 pallor is not there, it's abnormal. That's all, right? Now, let's look at the first image. Fine? Okay. I'll zoom this a little bit. Can I call this RBC normal? This RBC, this RBC, this RBC, this. Can I call that normal? You have a central pallor? Yes. Okay. Can I call this RBC normal? Maybe to some extent this RBC normal? Yes. You have central pallor. Perfect. Now, I'm going to mark a few cells. These few cells, are you having central pallor? Yes, no, maybe. I don't have a central pallor here, right? There are quite a few cells here where central pallor is not seen, which means, can I say it is not biconcave? It is not biconcave. It is spherical. Perfect. Don't go the shape of the RBC, which is a bit difficult in a microscope. It's a two-dimensional structure. So here, the problem is this RBC, which is supposed to be like this, has become like this. When it became like this, what happened was the central pallor went away, right? So something is stretching my RBC to be biconcave. Let's imagine a rubber band. I'm stretching a rubber band to make it biconcave. I leave it. How does it become? Spherical or oval, something of that sort, right? So the stretching proteins are your ankyrin spectrin, band 3.2, band 4 and everything. Band 3 and band 4.2 everything. Fine, that's all. So the stretching proteins are your ankyrin, are your bands 3, 4.2 and your spectrin. Can I say these are structural proteins? They are structural proteins. What inheritance? Dominant. If it's a dominant inheritance, what's the age of presentation? Later in life. Superb. If it's dominant inheritance, how many alleles are mutated? One allele. Which means other allele of ankyrin is normal, right? Perfect. So the anemia here, will it be very severe or less severe? Will be less severe or very severe? One allele is normal, only one is mutated. Will be less severe. Perfect. So here anemia is less severe because of one allele being normal. Whenever I have hemolysis, I'll have little bit of bilirubin elevated. Conjugated, unconjugated. Unconjugated. So throughout life, till the adult life, bilirubin is becoming more every single day. Can it produce gallstones? It can. That's a disease. Adult presenting with hepatomegaly and a pigmented gallbladder calculi, think of spherocytosis. They don't present with anemia because they are less severe diseases, right? Simple. I just have to connect the dots. When you connect the dots, no, it's nothing. So once it's lost, it becomes spherical, and these spherical RBCs will be destroyed in the spleen. So since it's destroyed in the spleen has to work more. That's why I have splenomegaly there, right? So the symptom is simple. Symptomatology, it's an adult because of dominant inheritance. Less severe anemia, they'll present as splenomegaly because it's working more, and a gallstone. Most likely the gallstone will be pigmented gallstone, that's all. That's a classical triad of spherocytic anemia by default. There are autosomal recessive variants also, but it's 2%. Let's consider the 98%. That's enough for me. Fine. Okay. Adult splenomegaly gallstones, I have this, right? Now, just one more important superb concept for you to never forget spherocytosis. I told this is an expanded rubber band. I'm leaving it. Once I expand the rubber band and I leave it, when I leave, will this rubber band consume kind of smaller volume? Yes, no, maybe. This is expanded, stretched. There is more volume. I leave this. Slight reduction in the volume. Yes? Perfect. Is there any alteration in the hemoglobin here? There's no alteration in the hemoglobin at all. But slightly smaller cells, right? So what will happen to the concentration? Slightly smaller cells, same hemoglobin. What will happen to the concentration? So MCHC will be elevated. There's a clue. There's no other disease where MCHC will be elevated. If you have an MCHC elevated in case of a RBC disorder anemia, it is spherocytosis or a spherocytic anemia, that's all. Now, if MCHC is elevated, you know how to identify an RBC. They are smaller, they are darker, they don't have a central pillar. That's it. So microscopy, when you have a smaller RBC, when you have a darker RBC, when there is no central pillar, I know by default it is spherocyte. I never said spherocytosis. I said spherocyte. Which you think is common? Acquired or inherited? Throughout every disorder, which you think is common? Acquired is a more common, right? This is how a spherocyte looks like. Acquired is a very, very common than inherited. So the next question comes. When a person or a pathologist, inherited is not common at all. Acquired is common. Inherited is never common. Inherited is common only in MCQ exams. At any point of time, it will be TB, it will be fever, it will be diarrhea. Right? Some pathologists sees in microscopy as spherocyte. What's the next step? I have to think of the most common cause. The most common cause for spherocyte is autoimmune hemolytic anemia because it's acquired, not inherited. So if that is the most common cause, what should I rule out first? Autoimmune hemolytic anemia. What's a test? That's an MCQ. The next step in case of a spherocytic anemia. I see a spherocytic anemia. The next step is Coombs test to rule out autoimmune hemolytic anemia, because that's the most common cause. I don't think of spherocytosis. I don't do an genetic testing at all. I do a Coombs test. That's all, right? That's all. Osmotic fragilitis, no use, cat. It's there. It's like our old people in the hospital not doing anything. That's what osmotic fragility test does, right? Do a Coombs test, rule this out. This is an important PYQ, has been asked multiple times, fine? Okay. Now, just an investigation of choice. If it is an hereditary spherocytosis, H is for hereditary spherocytosis. It is flow cytometry. No other test will help. Flow cytometry will easily help. Flow cytometry for band 3 if possible. And I use a stain called as EMA. EMA is a stain used in flow cytometer. For band 3 it is. Sudha, osmotic fragility has no role. In real life, in practice, it has no role. Theoretically, it has. But that will not differentiate AIHA versus spherocytosis. Fine. EMA flow cytometry is the investigation of choice for spherocytosis, right? So now, all these things, smaller, darker RBCs are all spherocytes. So whenever you see spherocytes, it's not this. Fine. It is not at all dotted in blue. If it's see, osmotic fragility will be altered in spherocytes. I am not denying that. The next step is always Coombs. Investigation of choice is always EMA flow cytometry. Fine. Osmotic fragility has a role, not in real life. In MCQ it has a role. Okay. That's with spherocytosis, right? So all this will be for spherocytic anemia. We're going to connect dots for most of them. This is what I want you to look in a scenario-based question. In a scenario, this is what is going to help us. Adult splenomegaly gallstones. And investigation of choice if it's a one-liner. Next step if it's a logical based question. Fine. Okay. Then what is this guy? How does this guy look? That's a spotter. I'm sure you'll answer the question. That looks like someone has bitten it, right? That's a bite cell, right? Schistiocyte. Good. I might call it a helmet cell also, like Cat says, right? So which means you yourself disagree that without a scenario, images are not useful. That's why I need a scenario. I always require a correlate clinically with patient, because that's what helps me in the diagnosis, right? Yes, it can be bite. It can be a spherocyte. Sorry, it can be a helmet cell. It can be schistiocyte also. History will help me a lot, right? Let's assume that it's a bite cell. Bite cell is seen in, like I said, G6PD deficiency. G6PD is an enzyme. So it's a recessive, but here it's X-linked recessive, which means more commonly seen in men. Okay. G6PD is an enzyme in the hexose monophosphate pathway, HMP pathway. When HMP pathway is gone, HMP pathway cannot give me NADP, NADPH. Because of that loss of NADP, NADPH, what happens is I will not be able to recycle free radical scavenging enzyme. That's your glutathione peroxidase, right? Because of this, the pathogen is very simple. I'll have less HMP pathway shunt. If it's there, I'll have less NADP, NADPH. If NADP, NADPH is less, there'll be less recycling of antioxidants. Now, can I say, so here in this patient, tell me if it's right or wrong, yes or no. In this patient, there'll be more trigger to free radical damage. Yes, no, maybe. What do you think? Obviously, yes. Right? Because I cannot recycle this person. Which means, who will be more affected? You or a person with a fever? A person with a fever. Because I need free radicals to destroy the RBCs here. Right? I need free radicals. That's why the most important clue in a clinical scenario based question is the trigger. Without trigger, G6PD cannot happen. That's very, very, very important. It's a trigger induced hemolysis. This history is very, very important for me to know. It's not that, it's not. It's a trigger induced always. Trigger induced infection is the commonest one. Then drugs. Then to satisfy our ego, fava beans. Fava beans is not be seen in India. It's not consumed in India, at least for now. We don't know. If Instagram influencer pushes it from some corner of the country to India, we'll consume that also. Right? Primaquine or your dapsone, trigger-induced hemolysis. There's a trigger, Hemolytic anemia, it's G6PD deficiency, right? G6PD will have both intra and extravascular hemolysis. That's a unique thing, but intravascular is definitely more than extravascular. Fine. Okay. So G6PD deficiency, microscopy will have two findings. Bite cell is diagnostic, where it looks like a bite, right? Or I have one more finding called as Hein's body. What is Hein's body? Hein's body is your seen in, I'm writing NMB for new methylene blue stain. Someone commented in the first half supravital stain. New methylene blue stain is a supravital stain, right? Perfect. So you can see this blue dot, right? Blue dot is nothing but precipitated globin or hemoglobin, whatever makes sense. Fine. It's a protein precipitate which is there. A precipitated globin is the Hein's body here, which can be seen in new methylene blue, which is supravital stain. Fine. Okay. So Hein's body there, bite cell there, I can say it is G6PD, that's more than enough. If someone is going to ask investigation of choice, it's an enzyme defect. Enzyme analysis is the best investigation of choice. That's it. Fine. Okay. That's about G6PD deficiency. It's a denatured globin product which is seen there. Okay. Let's go with this guy. Who's this? Who's that? That's your sickled RBC, right? It's a very simple thing. It's a sickle cell. Sickle cell, the other name is drepanocytes. Drepanocyte is a boat. It looks like a boat. Fine. Sickle is dominant or recessive because we have traits. It has to be recessive. Anything with a trait or a carrier state has to be recessive. It's an autosomal recessive condition. Fine. Where you have a point mutation in the beta globin chain. Okay, you have point mutation in the beta globin chain. You know that the glutamic acid becomes valine. Because of the change in glutamic acid to valine, the hemoglobin becomes less soluble. Because valine is an hydrophobic amino acid. It becomes less soluble. Because of that, I have this problem, right? Subrat, I don't want to take that point. That's why I limited with my beta globin chain. There's lots of things you have to remember before the 6th portion and 7th portion. See, I report next generation sequencing. I report mutations. That's not very easy to understand beta 6 or beta 7. Let's keep it beta chain. Fine. I didn't want to go there because it's difficult. Protein is different. Codon is different. Gene is different. Nucleotide is different. Let's ignore that. I don't know if it comes in the exam what to write. It's based on the understanding of the hematologist what to write. Fine. Okay, let's come back to this. Okay. Sickle cell anemia, most of the time, the presenting feature. So the clue what I want you to look at a scenario based question is sickle cell anemia very hardly presents anemia. Most of the time present as pain crisis. You must have read them as hemolytic crisis, right? It's a hemolytic crisis, that's all. Simple hemolytic crisis. Sorry, the vascular crisis, not hemolytic, vascular crisis. Be it in dactylitis, be it in recurrent abdomen pain resulting in autosplenectomy, right? Be it in vascular crisis, even your priapism, it's a vascular crisis. They present as vascular vaso-occlusive crisis and not as anemia. Anemia also will be there, right? Whenever you have an unexplained abdomen pain, like a dactylitis, fingertip pain, or an unexplained abdomen pain, okay? That's how sickle cell anemia presents. The presenting, and also when I investigate, I can look for anemia by default, right? This recurrent abdomen pain over the period of time can cause autosplenectomy. Not now, over the period of time, tiny occlusion, tiny destruction can cause autosplenectomy, right? And also the patient might have anemia. Fine. When you do a PS, you can easily see a sickle cell. Let's say it's a patient who's an recessive condition or a trait. Is finding sickle cell easy or difficult? What do you think? Is finding sickle cell in a trait easy or difficult? It is difficult. So I have to induce sickling. In that, we have a test called a sickling test. Sickling test is generally done for carriers or trait. In a sickle cell anemia patient, sickling is very easy to identify. So what we do is, we add something called a sodium metabisulfate. Okay, fine. So we have sodium metabisulfite. So the sodium metabisulfate consumes oxygen. It consumes or sucks up all the oxygen, makes even normal sickle in a trait to push into sickle cell cells, right? So this is what will push it, as primarily used for carrier state at all. Carrier state only, not for full-blown case of sickle cell anemia, right? And investigative choice, you know that it is HPLC is better than hemoglobin electrophoresis. Any drugs you know or treatment modality? Any drugs you know? We have hydroxyurea. Hydroxyurea can increase the, one of the mechanisms of hydroxyurea is they increase your hemoglobin F. Hemoglobin F consumes more oxygen. When consumes more oxygen, it will reverse sickling process. When deoxygenation of sodium metabisulfate can cause sickling, more oxygen can increase sickling. And also the final thing is, I have to change the bone marrow if required, bone marrow transplant. Fine, perfect. Okay, great. That's what sickle cell anemia. Then let's go to TAL. Thalas means sea. Thalassemia was discovered in and around the Mediterranean area. Right? Simple. It's in and around the Mediterranean area. Let's go a little bit off topic and come back. Why do you think Mediterranean area or Africa is where all these sickle thalassemia is very common? What do you think? Have you heard that sickle or thalassemia and others can protect from malaria? Yes, no, maybe? Yes. So what happens is human beings evolve. They are like one of the most resistant species, right? Human beings evolve a lot. So these genetic diseases are nothing but evidence of evolution. People are dying because of anemia, of malaria. So my body saw that, okay, this falciparum malaria is killing me by growing inside my RBC. Let's change the RBC. It's an evidence of evolution. Wherever I had lots of falciparum malaria, where all genetics will hit and will change. That's all. Survival of fitness. Now let's take the survival of fitness to blow the mind. Have you heard about L-tor vibrio? Cholera L-tor vibrio, the 7th pandemic of cholera in your microbiology. Have you? You must have, right? We don't teach you that for a fact. Cholera toxin acts via chloride channel. Yes, that's an MCQ. It's an MCQ, right? So cholera toxin, when it acts via chloride channel, during the 7th pandemic, which happened in European states, people died in millions. They were not able to do anything. So what happened was, the beauty was, my body said that, let's change the chloride channel. That's when cystic fibrosis was born. Cystic fibrosis chloride channel receptor mutation. If you read the books carefully, it will be written cystic fibrosis is a Caucasian disorder. It happens in Europe because L-tor vibrio 7th pandemic happened in Europe. How it came to India? Human beings are the vector. If you go and see the Eiffel Tower, you should see the Eiffel Tower and come back, not do something and come back. It should not come to India. It should have never come to India. The same way sickle should have stayed there. It should not come here. Which means, can I say, in future, we guys can expect a autoimmune disorder on which COVID virus was functioning? We can for sure, right? That time we'll see. Your kids might study MBBS and say, this mutation was related to COVID. We are thinking that we created vaccine and we eliminated COVID. Human beings are laughing from the behind. Your genes and my gene is laughing from behind. We do some things which is not under our control at all. Human beings are there for billions of years. Harrison is only 22nd edition. You can't do nothing. You can't do anything with Harrison. Learn medicine holistically. It's far beyond the textbooks. It's there from your genes. Your mother and father transmitted more medicine to you than Harrison can ever would. Only thing is, I'm not looking at it. Look from a different perspective. Take a seat back. After the exam, read more. You learn and love medicine. Once you start loving medicine, no, these books are useless. They are really useless. You can write books, fine? Let's go to this. Let's go to thalassemia. Thalassemia is also autosomal recessive condition, right? Because thalassemia is also a trait. It is an autosomal recessive condition, right? So thalassemia if I say it's beta thalassemia, which is by default more common, I'll have reduced alpha chains or beta chains. Be reduced beta chains or absent beta chains based on beta 0 or beta plus. And because of this, there's a compensatory increase in alpha chains. There's a question once asked, the problem in thalassemia is not reduced beta chains. This excess alpha chain is the reason for the symptoms. The symptoms in thalassemia are due to excess alpha chains and not due to low beta chain, right? Yeah, beta is in chromosome 11, alpha is in chromosome 16. If you want that thing also, let's add on to it. Okay. Excess alpha chains is the cause and not the reduced beta chain. Because of that, I have the problem in the genesis of RBCs. So my RBCs become small and they become irregular and they're not good enough for me to carry oxygen. That's a pathogenesis. Let's not go into that of it, right? So let's take beta thal major. Beta thal major, there's kids present after 6 months. The reason why they're present after 6 months is simple. Till 6 months, I'll have hemoglobin F, alpha to gamma 2, no beta, no presentation. After 6 months, it slowly becomes completely adult hemoglobin. Then the symptoms start appearing, right? The symptom will be very simple. It will be classically written failure to thrive. Because kids don't have hemoglobin, the kid is not going to grow properly, right? Beta thal major, 6 months, failure to thrive, classical beta thal major. Again, I'm just talking about the clue points. X-ray, you can have the hair on end appearance. And because of the X-ray change, because of the rapid increase in the bone marrow, you have the phases. You have the hemolytic phases or your chipmunk phases. Okay, hemolytic or chipmunk phases, all these are classical for beta thal major. And in beta thal major, in microscopy, you will see classical finding of target cells. Obviously, you'll see MCHC is microcytic hypochromic anemia, classical target cells, and you'll see nucleated RBCs. Highlight on this point, this is very, very important for me. I'll tell you why. Whenever you see nucleated RBC, it's a severe hemolytic anemia. This accounts for severity. That's why thal major. Thal minor will also have target cells. Thal minor will also have microcytic hypochromic, but will not have nucleated RBCs, right? NRBC is for nucleated RBC. RBC is generally not nucleated. Here it will be nucleated RBC, right? That's for thal major, right? Okay. So what are these cells? These are your classical target cells, right? So these are target cells. The other name for target cells is podocytes. Because you're pissed off. You guys know everything. So you have to change the question to make it more difficult. Change the name, it becomes difficult, right? Target cells or podocytes, fine? Or maybe bullseye cells. If Manu becomes a scientist, he will name the cells bullseye cells, fine? This is for thal major, okay? Now let's go to have a tiny look at thal minor, okay? Thal minor is a very close DD for iron deficiency anemia. It's a very, very close DD for iron deficiency anemia, okay? Almost presents like an iron deficiency anemia, right? Tell me one test which helps me to differentiate. Tell me one test which helps me to differentiate this. Thal minor was IDA. The one test which I require apart from your HPLC hemoglobin electrophoresis, there's an important PYT which is RDW and Menster's index. Fine. These both are very, very important for me. Menster's index and RDW, right? Again, apart from your hemoglobin electrophoresis HPLC, these are very important for me. Fine. Okay. So now let's understand what is RDW. RDW is a very simple concept. You understand it, you'll never forget it. Menster is also a very simple concept. RDW is red cell distribution width, which means I'm arranging the RBCs in the form of the means corpuscular volume or MCV. Let's assume I'm arranging your entire classroom based on your weight. I'll have a range, right? Okay, 50 kilograms to 100 kilograms, just a range. That's RDW. So RDW is in simple words, scientific words, degree of anisocytosis, change in the size of the RBC. That's all. Variability in the size. Fine. Okay. Now I'm giving you two options. Iron deficiency anemia is nutritional. Thalassemia is by birth. Just answer me one question. If I eat well, will a thalassemic patient produce normal sized RBCs? Yes or no? They won't. They won't, right? If I eat well, will an iron deficiency anemia produce normal size RBCs? Thank you, Nirmal. If I eat well, will iron deficiency anemia patient produce normal RBCs? Yes. So now tell me, in a patient with an iron deficiency anemia, there is a possibility I can have smaller RBCs as well as normal size RBC. Yes. So what happens to the range? Wider or narrow? Because IDA changes with food, or it's dynamic, which means I can have both normal and microcytic RBCs, which means RDW is wide. Don't memorize. It's simple. But thalassemia is a static pathogenesis. So RDW is normal or narrow. The normal RDW is 14 to 16. 14 to 16 is the normal RDW. It's wider. It's thalassemia. Or can I say it's wider even in megaloblastic anemia, nutrition related? In other words, any disease with a dynamic pathogenesis will be wider. Any disease with genetic pathogenesis is not dynamic. It's decided at birth. It's normal or narrow. That's it. They will ask today iron deficiency anemia. After 2 years, they will change to megaloblastic anemia. It's not new MCQ. It's the same. It's same. I'm going to extrapolate it. That's all. Fine. Okay. One more. The Mensters index. I don't have enough space here. I'll write here for Mensters index. Please apologize. So Mensters index, someone told it's RBC by MCV. Where was it? The number is amazing. You'll never forget it. It's 13, right? So Mensters index is MCV divided by RBC count in millions. That's Mensters index, and the number is beautiful number of 13. You'll never forget that, right? Okay, perfect. So now I'm going to compare two diseases, TAL and IDA. Can I say in both MCV is reduced? It is. So mathematically, what is the changing factor? RBC count, right? So Mensters index is 1 divided by RBC count, because in both it's reduced. Or let's say assume MCV by RBC count only. Which of these two you think is hemolytic anemia? TAL or IDA? Which is hemolytic anemia? TAL is a hemolytic anemia, right? So if there's a hemolytic anemia, what will my bone marrow do? Will it proliferate more or proliferate less? Bone marrow will proliferate more, right? If bone marrow proliferates more, what will be the number of RBCs in thalassemia? More or less? So in thalassemia, because it is an hemolytic anemia, you guys only said that the RBC count will be more. If the RBC count is more, what will happen to Mensters index? Less than 13, more than 13. Denominator is increasing. 5th standard mathematics, what will happen to numerator? It will be reduced. It will be less than 13. That's it. No mnemonics. Mnemonics spoil you. On the other hand, iron deficiency anemia is a nutritional anemia. I don't give enough nutrition to my bone marrow. Will my bone marrow divide more? It will not divide more. If the bone marrow does not divide more, RBC count will be less. If the RBC count is less, that is denominator being less, what happens to the numerator? It will become more. That's all. So in an iron deficiency anemia, where it's a nutrition related problem, I'll have less bone marrow division, BM for bone marrow. If there's less bone marrow division, by default, my Mensters index will be more than 13. That's it. You'll never forget it. It's a simple concept. And these two are very, very important for a pathologist or for an undergraduate to differentiate between thalassemia and an iron deficiency anemia. Very simple. Fine. Perfect. Then let's go to classification based on microscopy. Microcytic, normocytic, and macrocytic anemia. You remember this mnemonic, right? Sitama. I hate mnemonics. Two reasons I hate mnemonics. One, I cannot create mnemonic. I'm dumb in creating mnemonics. I accept that. Second is, it destroys the younger generation. I can tell now, and I will also tell in future, you guys are smarter than me. You guys are 100% smarter than me. But the system of education is destroying your smartness, making you much more dependent. Mnemonics does that, right? If you want to go with mnemonic, fine, but I want you to go with ISTA. Let's change it. Because iron deficiency anemia is what I want you to remember first, not sideroblastic. When you read Sitama, when you see a microcytic, first thing will come to mind is sideroblastic. You will never see sideroblastic in your life. Let's at least change it, right? Only two things I want to remember. IDA is microcytic. Tal minor is microcytic. Then yes, for an MCQ, sideroblastic is microcytic. Sideroblastic, you will never see it. But let's keep it there because there's textbook. Let's keep it there, right? Okay, change it. I put I first, then put Sita second. Fine. I'll call it microcytic anemia. When my MCV is less than 80, we call it microcytic anemia. Okay, fine. No, Toledin, you are just young. I'm old. That's why there's a difference. Nothing else. Fine. So when you have a RBC smaller than the nucleus of small lymphocyte, I can call it microcytic anemia. Lead poisoning also, yes, we can add to it. Fine. Normocytic anemia, when MCV is between 80 to 100, we call it normocytic anemia. Two important things in normocytic anemia. One, anemia of chronic disease. Okay. Anemia of chronic disease is normocytic. It also has microcytes, but I categorize them into normocytic anemia only. And anemia in CKD. Anemia and CKD, the problem is this came in this year, this INICD, right? The problem is no erythropoietin, so the treatment is erythropoietin. CKD, kidney fails, erythropoietin is gone, I give erythropoietin for treatment, fine? Okay. Macrocytic anemia, more than 100 femtoliter, MCV, we call it macrocytic. Of that, big guy is megaloblastic, which is your B12 or a folate problem. And also you'll have alcohol, we can have liver disease. Any case of liver failure can cause macrocytic anemia, and even your hypothyroidism can cause macrocytic anemia, which is not megaloblastic, right? Fine. So we categorize them based on this. Fine. Okay. Perfect. Now, one more important thing which can come in your hematology is your iron profile. Iron profile is definitely important. You have memorized iron profile till now? Let's go and look at it logically. Because the up arrow, down arrow, up arrow, down arrow kills your life, right? And there are multiple diseases where you can compare. I'll tell you the logic behind iron profile. You can go and apply it to any disease, whatever you want, right? Because memorizing is tough. Okay. There are only 4 tests for me in iron profile. 4 normal tests required. Serum iron, transferrin saturation, serum ferritin, TIBC. I do have many other things also, but these are the 4 common things which might come in a scenario-based question. Let's compare like this. Serum iron and transferrin saturation. Let's understand the logic behind this. Let's say you are in a classroom where there are 50 seats. All those seats are iron binding sites of transferrin. Let's assume 10 people come into the classroom. Will this classroom be full or empty? It will not be full. Multiple seats will be empty, right? Let's say 500 people come into the classroom. I have only 50 seats. Will it overflow? It will overflow, right? I'll compare this to iron and transferrin. Now let's say I have 5 molecules of iron and 53 seats on transferrin. It will be empty, not saturated. I have 500 molecules of iron and 50 seats in transferrin, which will be saturated and it will overflow. So in other words, can I say these two are directly proportional? Can I make that assumption? Yes. If iron increases, what happens to saturation? Increases. If iron reduces, what happens to saturation? It reduces. Because these 4 tests you already know. If one increases, other will increase, one decreases, other will decrease. Is that clear? If clear, tell me yes. Then let's go to the next. Perfect, right? So saturation and T-sat and serum is always directly proportional. Now let's go to the next guy. What's the function of ferritin? Function of ferritin? Storage form, right? Perfect. Function of ferritin is storage. Okay. Let's find one more analogy for this. TIBC is, I'm going to rephrase TIBC a little bit for understanding. TIBC is affinity. Its affinity to bind iron is total iron binding capacity, right? Let's take an example. Had your lunch or yet to have your lunch? Yet to have the lunch, right? So which means my tummy, which is the storage, is empty. since I didn't have the lunch. So now I even give you a hostel food. You will eat because you are hungry. That's all. That's it. So let's say after you have your lunch, even if we could give you a decent food, you will say, no, I don't want because my tummy is full, right? So when the storage is gone, my affinity to binding is very, very, very high. When my storage is full, my affinity to binding is very, very less. Decent? So can I say these both are inversely proportional? Can I make that assumption? These both are inversely proportional? Yes. So the storage is more, affinity is less. When the storage is less, affinity is more. That's it. Perfect. So 2 are direct, 2 are inverse. Now let's go to iron studies. What will happen to serum iron in iron deficiency anemia? It's like asking what is 1 plus 1. It will be reduced. You don't want anyone to teach you that. If serum iron is reduced, what will happen to saturation? It will be reduced because they are directly proportional. What will happen to ferritin in case of IDA? That's the most sensitive test, right? It will by default be reduced. If ferritin is reduced, what will happen to TABC? It's inversely proportional. It will be elevated. Okay. Manu, there are, like I said in the start, there are many more iron profiles which I can explain. Lack of time. Let's talk about that after some time. Or just DM me on Instagram or Telegram. Instagram privately, I'll try to reply to you, right? So these are the 4 common iron profiles done. Very simple, right? No need to memorize. Now let's go to anemia of chronic disease. The only thing I want you to remember in anemia of chronic disease is start from this place. Then it's more logical. Okay, that's more logical. Anemia of chronic disease. Fine, I'll come to it, Manu. Anemia of chronic disease is chronic inflammation. What will happen to ferritin in chronic inflammation? Ferritin is a acute phase reactant. We read in the morning, right? It will be more. Perfect. If ferritin is more, what will happen to TABC? It will be reduced. If it's required, I'll write here because ferritin is an acute phase reactant. So obviously in inflammation, it will be elevated. In anemia of chronic disease, it will be elevated. That's all. Fine. Now if ferritin is more, storage is more, free available iron will be less, right? I can relate that. I have more ferritin, everything is stored. I'm not letting the iron outside. So free iron will be less. If iron is less, what will happen to transference saturation? It will become less. The only reason iron profile is required is, look at that. It's very, very close, except for this. These two are same. That's why we go for ferritin as the first choice. Ferritin tells me what's happening. Ferritin is the earliest finding, and ferritin is the most sensitive test. It's the most sensitive test in case of an IDA because it changes first. It can help me to differentiate with anemia of chronic disease, and that's what is iron profile, right? You can apply this for everything. Hemochromatosis, more iron, more TSAT. That's all. More ferritin, less TABC. If you know the logic, you can apply it for any disease what comes to your mind. Fine. It's simple to understand that, right? So iron profile based questions might come. If not in this exam, it might definitely bother you when you start practicing. It'll help you a lot. Fine. Okay. Manu, hold me for now. Sidro, you have to know the concept of Sidro to learn sideroblastic anemia and iron profile. I'll talk about soluble transferrin receptors a little bit later. Fine. Okay. Now let's go to the other guys. Few more images just for us to diagnose things. Okay. What's this guy? What is this guy? Simple guy. Who's that? That's hypersegmented neutrophils, right? Amazing, right? So hypersegmentation or hypersegmented neutrophils is a very specific finding for megaloblastic anemia. Okay, fine. So how do I pick up clinically megaloblastic anemia, right? There are few very classical findings to say, okay, this is megaloblastic anemia. Megaloblastic can be due to B12 or folate. So how do I differentiate whether it's B12 or folate? Right? B12 or folate difference is very simple. One, if the question has vegan diet, think of B12, vegan, not vegetarian, right? If the question has diet with less fruits or greens, think of folate. Apart from that, I have other things also. I'll come to that soon, right? Okay. Less fruits and folate, think greens, think of folate. More vegan diet, think of B12, right? And by default, on examination, neurological symptoms. Here there'll be no neurological symptoms. That's the easiest one to identify. But history also helps me at some time. If neurological is not given, history helps me. And the final one is to, here B12 levels will be reduced. Here folate levels will be reduced. With the help of blood test, serology, I can easily differentiate them, right? Okay, fine. So these are the ways to differentiate this. There are two things which you have to know regarding folate, even outside of your megaloblastic anemia, right? The best source of folate is fruits and green leafy vegetables. But your book will say, can I say folate is also present in meat, egg, milk? It is. It's true, I'm not denying that. Have you heard something called bioavailability? You must have. Let's assume 10 milligram is present in meat. What my body is able to absorb is what is important. If it's there in food, it doesn't matter for me. What is absorbable is important for me. The problem with folate is, it's a very heat labile vitamin. If you cook the food, folate will disintegrate. That's why meat's folate is not important for me. Milk I don't drink raw. We either make coffee or a tea or something of that sort. Heat, destroy. Fruits I don't cook. Unfortunately, barbecue nation cooks pineapple also. If I heat a food, folate will be destroyed. So fruits and greens, the salads, lettuce, which is a very good source of folate. Now, let's understand the importance of this knowledge into the real life. Sometimes it's like I'm over treating things which is not at all required. When was the last time any of you had a fruit? Can I say your parents, most of them, might have at least banana regularly? Yes, no, maybe. If not an apple or a dragon fruit, will they have banana regularly? Leave mango, seasonal fruit leaf on a regular day. Leave mangoes, regular day. They'll have banana regularly, right? Why did our generation stop eating banana regularly? Status symbol. That's a problem. Now, I'll tell you where it impacts. When I was doing MBBS, the treatment of folate for a pregnant woman was in first trimester. It's been 12, 13 years. What's the treatment of folate recommendation now? In the first trimester or when they're planning to have a baby? They're planning to have a baby. My habit of not eating fruit regularly had made extra 3 months consumption of folate. Right? Medicine is far beyond what you see. After some time, they'll say, when you're a menarche, have a folate. We destroy medicine. We are enough to destroy medicine. Like human beings are the only person who is going to destroy medicine. What happens? Okay. That's simple. Right? There's a beautiful story about B12. B12 is a vitamin. You learn B12 once, then you love biochemistry. Because we hate biochemistry, Just 5 minutes, let's go a little bit off topic just to stimulate interest in medicine. Because interest in medicine is more important than medicine per se. The function of B12 is, if you remember, the function of B12 is, B12 helps in thiamine metabolism. Also your folate. It helps to produce thiamine, right? The ATCG. It helps to produce that. So which means B12 is very, very, very important for fast dividing cells. Yes, no, maybe. Yes, is it important for fastly dividing cells, right? So when I don't have B12, what happens is fastly dividing cells will stop dividing properly. Yes, that's all, right? Now let's assume I'm having B12 deficiency. My bone marrow is not performing. That's why megaloblastic anemia will be pancytopenia, not anemia, because fastly dividing cell, stem cell is gone. When I don't have B12, my GI, which is fastly dividing cell, what happens is it will not divide properly. That's why you will have lots of gut disturbances. You might have diarrhea, constipation alternating. Fastly dividing cells of the skin, can I say skin is fastly dividing? Skin will become weak or thin, easy bruisability. You just flip, they allow bruise. At the same time, have you heard about knuckle hyperpigmentation? The stretched areas of the joints are being just stretched skin. Since the skin is thin, it's been damaged, and skin produces pigment in response to inflammation. Post-inflammatory hyperpigmentation, that's that. If you're wearing specs, this part will be black. Why? Post-inflammatory hyperpigmentation. If you rub your nose, you'll have the sign in allergic rhinitis, post-inflammatory hyperpigmentation. So in a B12 deficiency patient, the skin becomes stretched, post-inflammatory hyperpigmentation, classical finding. Can I say tongue is also a part of B12? So GIT? Yes. The tongue papillae is the epithelium there. They'll be flat, red beefy tongue, B12 deficiency or megaloblastic anemia. That's how amazing B12 is. I know B12, I know everything related to that. How many of you like biryani here? How many of you like biryani here? Most of you like biryani, love biryani. Why? Because of B12. You won't understand that B12 is the reason you are liking biryani. I am liking biryani. Because if I have good amount of B12, the tongue taste buds will be very dense, papillae will be very dense, so that the foreigner can taste a Russian salad. I don't even like the Russian salad. Salad will be there in a buffet. We go to starters directly. We don't go to salad at all because my tongue cannot taste a salad. My tongue anatomically is deficient of papillae per square millimeter compared to an European's tongue. Because Europeans' diet is red meat. They have huge amount of B12. I don't eat red meat. I don't have that huge amount of B12. So my consumption changes. I need spice in every food. Be it a pani puri, I need a masala puri. Anything I need this. That's how super B12 is. And now the thing is, look medicine from a far view. Can I say quite a few of your parents, or maybe when you are an intern, you must have prescribed B12 supplements to your patients? Yes, Bicosules, vitamin complex. Stop doing that. I eat a supplement when I'm deficient. I don't eat a supplement because I'll become deficient. Now imagine I'm loading B12 into a population like my country every single day. Will the GI proliferate a lot? Yes. If it proliferates a lot, is there a tiny chance of it becoming a cancer? After the class, Google it. Excess consumption of B12 is one of the important risk factors of colonic cancer. It will not come in textbooks, but that's a reason. India didn't have colonic cancer long back because my diet was different. What we are doing is we are abusing drugs. So let's come back to the exam, right? So history wise, you can have this. The common symptoms are you might have a flat tongue, a red beefy tongue. You might have knuckle hyperpigmentation. That's common. And all those are very, very classical findings, right? B12 is just amazing. Okay. It's definitely bad. Sure, Sudha. But they will definitely come for B12 injections, right? If you're in an OPD in a PHC, that injection is what gives them the push. That alone they'll come for, right? And hypersegmented neutrophils is a classical microscopic finding. There's one more question which came. If you have only B12 deficiency, so it's treatment related. What's the treatment? Do you give both B12 and folate or only B12? This came in an AIMS exam. Treatment is only B12, methylcobalamin injections. You don't give both. You have to give only B12, not both. Both was a very old concept. We have changed it. We have given only B12 if it's only B12 deficiency. If it's folate deficiency, give only folate. Because if we give B12 and folate here, if you give both, what happens is it will redistribute B12, and this will worsen neurological problem. Just remember it for now. I'll explain it later when time we get, fine? It will worsen the neurological problem, fine? No SS. Okay, in folate, yeah, folate can give both, but in B12 deficiency, give only B12, not folate. If you give folate along with B12, yes, it will redistribute B12 and it will worsen neurological deficit, fine? Okay, perfect. Let's go to few more images. What do you think this is? This is an acanthocyte. I was waiting for that card. Someone will say A beta lipoproteinemia. Acanthocyte, the way to identify acanthocyte are perfect. Spur cell. The reason why it was named spur cell is, if you've seen cowboy movies, cowboys will have wheels in the legs. That's called a spur. It will be irregular. Irregular spikes on a cell is called as an acanthocyte or a spur cell, right? First, I want you to think of this liver disease. Liver failure is the most common cause. For an MCQ, yes, this obviously will supersede because this was a PYQ. A beta lipoproteinemia. Whatever be the reason, the pathogenesis is simple. A beta lipoproteinemia, no beta lipoprotein, right? Beta lipoproteins are not there. Can I say if liver fails, my body will not be able to produce LDL, VLDL, HDL lipoproteins properly? Because liver does maximum mechanism for that. Fine. So ultimately same output. What have been the output? The lipoproteins are abnormal. When the lipoproteins are not right or abnormal, it's simple. What will happen to phospholipid bilayer? Will not be normal. So what happens is the RBC, which is like this, will not have a proper phospholipid bilayer, becomes like this. That's why I have acanthocytes. Irregular projections, not regular, irregular projections. That's the reason for acanthocyte, be it in liver disease or in a beta lipoproteinemia. Fine. Okay. This is echinocytes. Echinocytes are burr cells. Echino means it's a sea urchin, looks like a sea porcupine, where you have regular projections. When you have regular projections across the RBCs, where do you see them? We say them CKD or uremia, whatever you want to call them. Chronic kidney disease, where there's renal failure, the toxin causes this problem. Regular projections throughout the RBC membrane, we call it a burr cell. Fine. Okay. What is this guy? This guy? As your? Yes, Abhishek. The reverse for B12, only B12, folate give both because of the trap. Fine. Dacrocytes. Or your teardrop cells. It's Drapanos for sickle cell SS. Fine. Fine. We see them primarily in myelofibrosis. So what happens in myelofibrosis? I'll add few more findings regarding myelofibrosis soon. It's a fibrotic bone marrow. I have to squeeze and come out. So I look like a teardrop. That's all. Teardrop cells. In myelofibrosis, in peripheral smear, there's one more finding. Myelofibrosis, or if the question says, I'll talk about that also. It's a fibrotic bone marrow, right? I don't have enough space in the bone marrow. Dry tap is bone marrow aspirate findings. I'm talking about peripheral smear finding. I don't have enough space in the bone marrow. So what happens is every cell will come outside because space is gone, right? So in peripheral smear, I'll have blasts of myeloid, of erythroid also. Erythroid blast is nothing but nucleated RBC, that's all. So we call this an leukoerythroblastic blood picture. Okay. Leukoerythroblastic blood picture is a finding where I don't have enough space in the bone marrow, everything comes outside. We call it leukoerythroblastic blood picture. That's classically seen in myelofibrosis. If myelofibrosis is not there in the option, this can also be seen in anemia called as myelophthisic anemia. Okay. Have you heard about phthisis bulbi in the eye, ophthalmology? but the entire eyeball will shrink. You must have seen an 80, 90-year-old grandmother's legs. It'll be sunken. Phthisis bulbi. Phthisis means gone. Myelophthisis. Myelo is bone marrow. Bone marrow is gone. That can be due to myelofibrosis, due to secondary multiple conditions, or an infiltrating disorder. There also I'll see leukoerythroblastic blood picture, right? That's what myelophthisic anemia means. Here also I'll see the same thing. In myelofibrosis also I'll see the same thing, fine? Okay. But in myelophthisic anemia, you might not see dacrocytes. Myelofibrosis, dacrocytes will be seen, okay? Okay. Let's see if we can solve a few questions and learn a bit of extra information. Whatever comes to your mind, tell me the answer. Want to change your answer, Panda? Sudhir? This is what silly mistakes mean, right? Initially, it looked like A, because what happens is you must have read this. Where's it, guy? This. You know it is vegan, but in the back of the head, what happens is, okay, something is coming. You've been made by the entire system to answer first. No, answer correctly. Vegetarianism is not related to megaloblastic anemia. Veganism is related to megaloblastic anemia. Fine, that's first. So history-wise itself, I should be able to filter clearly. Second, blood work shows low hemoglobin. Fine. Low MCV, low serum ferritin. Why megaloblastic? It's a classical case of an IDA, right? So it has to be an iron deficiency anemia. The trap was vegetarianism. That's a history just to make sure you make a mistake. It has no relation to the patient here at all, system at all, right? Don't jump to the answer. Silly mistakes cost you a lot. Okay, you guys have given GTs. You must have. Can I say out of the 200 questions, at least 10 questions, while reviewing, you'll know I know this question. I just made a mistake due to silly mistakes. I didn't read the question properly, didn't read the answer properly, didn't look at the image properly. Have you made this 10 questions easily? Yes. So just because of just having patience, 50 questions in NACT, that hurts, right, Sudha? If you change this, let's say we make 10 to 1, right? 9 questions, if I make correct, that is 9 into 5 marks, 45 marks, because plus 4 minus 1. 45 marks in an exam. What will happen? From having a congratulatory post, it goes to writing the exam again. Just be patient. It's fine. Time is very, very important, as well as don't rush. 1 minute for a question, read entire thing and then answer. Keep this rule. 10 seconds. First 10 seconds, never answer a question. Even if you know, don't answer the question. You will have the clock running in the exam, right? Read the question, 10 seconds, don't answer. Most of the errors are made in the first 10 seconds. Silly mistakes. After 10 seconds, you should answer. If you don't know the answer after 10 seconds, you will never know the answer. That's how brain works, right? First 10 seconds, please don't write the answer. It helps you to save lots and lots of marks, right? Hopefully. It'll happen. That's what it says. It's a, how many of you think entrance exam is a assessment of knowledge? How many of you think? It's not at all assessment of knowledge. NBS clearly written a rule book behind creating entrance exam. It's been given to all the top people, HODs and people who are in medical education. It's not an assessment of knowledge. It's not an assessment of MCQ solving. It's an assessment of you. I don't want students to become doctors. I want doctors to become doctors. If you're anxious for a question, you will be anxious while taking a decision in real life. If you're overconfident in a question, you'll become overconfident in real life. If you're underconfident in a question, you'll become underconfident in real life. It tests you, not your skill, not your memory, not your MCQ solving. It's a stability. Let's say you attempt all the 200 questions. Do you think you'll get a decent rank? You won't. This person when he or she comes to practice, will diagnose everything, will never refer, will make more mistakes. Not a good doctor. Let's say I attend only 120, only things I know, not correlating things. Will you get a rank? You won't. This person will diagnose only simple things, will not ask the other person's helps, will not correlate, will not become a good doctor. 120 right, 50, 60 by correlation. That's what you call it guess, right? 10, I don't know, I don't touch. As a person will get that rank. Plus patience to the 3 hours of exam, 3.5 hours of the exam, right? Test assesses you, the doctor in you, not the student in you. You already cleared MBBS, right? You are already a good student. Next question. It's a simple question. Just explain the options a little bit differently. That's all. Diagnosis, simple case of an G6PD deficiency, right? It's a simple case of a G6PD deficiency, and I'm sure everyone knows it. Like I said, it's an indirect link because of the enzyme deficiency, less amount of NADP, NADPH. Because of less amount of NADP, NADPH, we cannot recycle the glutathione peroxidase. That's the reason this patient has a problem, right? Great, amazing. Okay, let's go to simple WBC disorders, right? I think over the period of years, WBC disorders and leukemia, lymphoma, weightage is coming a little bit less compared to 3-4 years. I hope that same thing maintains. And even if it comes, it's mostly a scenario-based question or a very new marker which no one knows. Ignore that. So it's a scenario-based question. How do I solve it? That's all. I have leukemia, I have lymphoma. In lymphoma, I have Hodgkin's, non-Hodgkin's. That's all I have. And myeloma here and there. Fine. Okay. Now, let's say this is a blast. Blast is an immature cell. When I have more than or equal to 20% blast in a peripheral smear or a bone marrow, I use the term acute leukemia. It can be both acute myeloid and acute lymphoid based on what cell it is, right? Now, if this is given in the question, it's very simple for me. Okay, it's blast more than 25% blast. I know it's an acute leukemia. But if an image is given, I need to identify whether it's blast or not. So how do I identify it's a blast or not? In a microscope, how to say it's a blast or not? Okay, I need a little bit of information from you guys. What do you think will happen in RBC? The blast will become smaller, loses nucleus, becomes an RBC, or the blast will become bigger and become an RBC. What do you think? RBC is the smallest cell or RBC is the biggest cell in the erythroid lineage? RBC is the smallest cell. So in other words, from any cell, from the precursor, when I mature, it becomes smaller. That's how it is, right? Which means, looking back this image, if you have, can I say it's a WBC? It's a WBC by default, right? If you have a WBC more than 2-3 times of RBC, we call it a blast. Next comes the high NC ratio. Because when you look only at high NC ratio, you'll confuse with lymphocyte. WBC more than 2-3 times of an RBC, it's a blast. There's an RBC. Definitely the WBC is more than 2-3 times, right? Now I know it's a blast. So what do I next look for? I need to know it's a myeloid or a lymphoid. That's all. So I go for a myeloid or a lymphoid. I'm not going with nucleoli. I'm not going with the color. I'm not going with the cytoplasm. Nothing. Only one thing. Granules present. Or rods present. Myeloid or lymphoid? No granules, no or rods. Because it's much easier. There are differences based on nucleoli also. But it's much comfortable, much easier to identify and apply. Granules present, or rods present, it is myeloid blast. No granules, no or rods, it's lymphoid blast. As simple as that. We can easily differentiate that, right? So how do I identify blast in a microscopy is based on the size. How do I know which blast it is? Based on the microscopic appearance, right? But this is not enough for me. That's where my marker comes into play, right? Because sometimes I will say granules present, you will say granule not present. So that's where marker comes into play, right? So we have how to differentiate lymphoid versus myeloid. So differentiate lymphoid versus myeloid. We go with series of markers. Let's go with one by one marker. So first, for an lymphoid blast, we have a marker called as PAS. PAS having a dot-like positivity is lymphoid. In addition to that, I want you to remember of TDT. TDT is primarily for lymphoid lineage. And for myeloid lineage, I want you to rely solely on one marker, which is MPO. Okay. And there's one more information separately, which is stem cell marker. Stem cell marker is CD34. Okay. Can anyone tell me what is the CD marker for B cell? Simple informations that I'm sure you will say. Any one B cell marker and any one T cell marker. Anyone? One B cell, one T cell. Perfect. 19, 20. But 19 is a very, very good marker. 19, 20 are B cell markers. T cell, CD3. Simple. Perfect. Just one marker for monocytic lineage. Though there are many, okay, CD14, 64 or NSC. Anything remember, 14 is good enough for us to remember, that's fine. 1464 NSC is good enough for us to remember, fine, perfect. Okay, 4 is for CD4 T cell, but pan T cell marker CD3 anshu, okay. Just one more marker for erythroid. This I am sure you'll know. There are many markers, but I want you to remember only one thing, hemoglobin. You'll not forget, right? Hemoglobin is there in erythroid by default, right? One more marker for platelets. I'll ask you one question. I'm sure you will answer that. Right? Angioglycophrin is yes, but HbA is much easier to remember. What is the protein mutated in Bernard-Soulier syndrome or Glanzmann thrombocythemia? Can you remember that? Bernard-Soulier syndrome and Glanzmann thrombocythemia. Do you remember that? What's the protein? Glycoprotein 1b9 and glycoprotein 2b3a, right? So which means glycoproteins are normal in platelets. Can I say so glycoprotein will be normal in platelets blast also? It will be. So instead of calling them a glycoprotein, I give a number to it, CD41, CD61 are nothing but these glycoprotein. Fine. So these markers are required for me to go and apply them to come to an answer. Fine. Okay. Now, this blast, does it have an OR rod or a granule in the cytoplasm? No, this is a lymphoid blast. Okay, it's a very simple lymphoid blast. I'll show you one more blast. This blast, is there an OR rod? What is the structure? Aren't you smudges for chronic? We'll come back to that soon. This is OR rod. So this is a myeloid blast. Fine. So a lymphoid blast, we know myeloid blast. So microscopy wise, it's not difficult to differentiate. For an undergraduate, they'll give very classical OR rods. They won't give hanky-panky things at all, right? So now, how do I differentiate based on history? How do I differentiate based on markers? There are very subtle and very, very important clues for you to know. ALL, a tumor seen in children or adults? ALL, a tumor seen in children. In children, ALL comes, Burkitt lymphoma comes. Rest everything in WBC is in adults. If it's a child, ALL or Burkitt's lymphoma. Rest everything is going to be in adolescents or adults only. It will not be seen in children at all. Fine, perfect. So what are the clues for me to look for in the question? For BALL, just at the before the day before the exam, read whatever I'm writing this for all the leukemias, both ALL and AML. Fine. BALL, child with lymphadenopathy, because B cells are there predominantly in lymph nodes, so lymphadenopathy will be present, and blasts which are positive for CD19, TDT and CD34. Because leukemia is from stem cell, 34 is positive, TD is for lymphoid, B cell is a lymphoid cell, it's positive, but 19 is what tells me it's BALL, right? Next, I can have also TALL. BALL is by default the most common subtype, which close to 85% of the acute lymphoid leukemia is BALL. TALL also is seen in children. But the classical finding is it will not have lymphadenopathy. T cell, what does T stand for in T cell? T stands for thymus. It's thymus dependent, right? So you'll have mediastinal enlargement. If you have mediastinal enlargement, I think of a T cell. This can be primarily seen on X-ray. In X-ray, I have mediastinal enlargement. I think of a T cell. Then blast. What's the most important marker here? CD3 is the most important marker here. TDT will be present. CD34 will be present. That by default will be there. There's no change in that at all. AML, acute myeloid leukemia, does not have classical symptoms like this. It's most often like non-specific fever, purpura, petechiae, like that only most of the time, right? But few of them have very classical symptoms, right? For example, we have AML M3, acute promyelocytic leukemia, right? AML M3. What do you think is the classical symptom of AML M3? What do you think is the classical symptom of AML M3? DIC, perfect, right? So patient presenting with DIC, disseminated intravascular coagulation. Again, clue points, microscopy, you'll have abundant of OR rods, which is called as a faggot cell. Faggot cell is too many OR rods, right? In addition to that, you might have a buttock-shaped nuclei, a cleaved nuclei or a buttock-shaped nuclei, fine? And perfect. PML rara is an absolutely important thing for us to remember. And IHC wise, I don't require anything here. MPO is enough. Myeloid, MPO positive, that's more than enough, right? D-dimer will be elevated because it's DAC parameter, right? D-dimer, PT, APT, everything will be right, like what Anju said. Okay? Perfect, right? Now let's look at AML, M4, M5. Can anyone tell me what does M4 and M5 mean? Just the expansion. Like AML M3 is promyelocytic leukemia. Like that, what does M4, M5 stand for? M4, M5 stands for? Myelomonocytic. Myelomonocytic and monocytic. Perfect. What is monocyte? Can I say monocyte, when it goes to tissues, it can become a macrophage? Yes, no, maybe? Monocytic or monoblastic? Fine. Yes, it can. Normally, can a neutrophil go to tissue without inflammation? It cannot. Eosinophil cannot go to tissue without inflammation. Right? Lymphocyte cannot go to tissue without inflammation. But monocyte can go to tissue without inflammation also. In other words, can I say these two can go into gums, can go into retroorbital, can go into skin without inflammation, without any problem? That's where your chloroma comes into play. Extramedullary blast, because monocyte normally also can go outside. So monocyte blast also normally can go outside. It's not rocket science. It's simple feature of monocyte. It's like us, doesn't stay in a place, keeps on going everywhere, right? So here, chloroma is a very classical finding where you have gum hypertrophy, not gum bleeding. Gum bleeding can be seen in any leukemia. Gum hypertrophy is important, right? Or a proptosis, because it can go outside. Or a leukemia cutis in the skin can go outside. Anshu, these incidence-based things, no, it varies based on lots and lots of studies, right? So, should I pinpoint to something? I won't be able to. If I do, you will definitely find the article which says other ways. And I don't think questions have been asked that way sometime. Chloroma is also seen in M2 like Shraddha said, because M2 can also have monocytes. Not in that much amount of M4, M5, but M2 is very common, right? That's more of the number game. M2 also can have this, right? If you look at books, they'll say M2 is the commonest cause. Because of 100 cases of leukemia, 90 of them are M2, 4 of them are M4, M5. So even among the 90 cases, like 10% goes outside. It's 9 cases. M4, M5 doesn't even come close to that. These epidemiology, no, epidemiological things are very, very tricky. I can say it's right or wrong, so let's not go into that, fine? Okay, M2 also I can have this, but when I say extramedullary, that should be monocyte there, only then goes outside, right? And this, for example, your IHC, this will have both MPO positivity and your 1464 positivity. Then I'll think of M4 and M5, right? I'll think of M5 when there's more of 1464 and no MPO. I'll think of M4 myelomonocytic, both MP1 and this, fine. Okay. Then AML M7. AML M7 is again seen in children, at rare children with Down syndrome. And AML M5 will end up in also having myelofibrosis. Okay. It's also can see in myelofibrosis, and it will be positive for your CD 41, 61. There are a few more markers, but 41, 61 should be more than enough, right? You'll have dry tap. Every feature of myelofibrosis will be there, right? So a few classical points to look for in a scenario-based question, right? I told 20% is the cutoff. There's a place where this 20% is not there. I don't want the 20%, right? So the 20% rule will not be applicable, is not needed if you have translocation 821, translocation 1517, that's your PML RARA, or your inversion 16. When I have either one of these, not all, either one of these, this or this or this, I don't want the 20%, which means I'll give you a scenario for this. Let's say there is 10% blast in the PS, 15% blast in the bone marrow, BM4 bone marrow, and translocation 821 positive. I'll still call this acute myeloid leukemia because of the translocation. These are defined genetic, recurrent genetic alteration. So this is required for you to remember, right? One more PYQ. Inversion 16 might have AML with lots and lots of eosinophils. If the question says AML with eosinophilia, I'll think of inversion 16 as a genetic parameter here, fine? Okay. This is for leukemia. This should be more than enough for us. M4 with eosinophilia or AML with eosinophilia, fine? AML M4 eos, fine. Okay. Okay. Look at the histories. Very, very classical. You can easily pinpoint leukemia and lymphoma, and only two things. They will maximum they might confuse with other findings. Like I gave vegetarian and heavy menstrual bleeding. I can confuse you easily, but don't fall for the trap. Carefully read everything. You'll be able to comment. Vacuoles. I'll come to it, Karthik. Vacuoles can be seen in M6. AML M6 has vacuoles in the cytoplasm. AML M7 also can have vacuoles in the cytoplasm. More than vacuoles, I'll go for blisters on the surface. Blisters on membrane is more classical for AML M7 other than vacuoles. Vacuoles not like specific. Burkitt's blast also can have vacuoles in cytoplasm, right? Burkitt's is a lymphoid blast that also can have vacuoles in the cytoplasm. You'll have vacuoles in cytoplasm plus a sky blue cytoplasm. It's again based on the history. I'll have to differentiate what it is. Fine. Okay. Karthik, biphenotypic, mixed phenotypic. I'll give you a simple example for you to understand that. Fine. When I have a blast which is positive for CD3 and MPO, two phenotypes. I call it biphenotypic, mixed phenotypic. That's all. Okay. Not going into depths of it. I think only once there's an INACD question on biphenotypic and MPAL. It's not a topic for undergraduates. They might not ask it again. Fine. If you have more than one, I call it bi or mixed phenotypic. Okay. Spotter. What do you think this is? It's a classical spotter. What is this? You love this, right? The college girl appearance or the garden party appearance. We remember that more than all the classical findings here. This is a CML, right? This is not a lymphoid blast. See, I do have blast here, but it's not a lymphoid blast. I do have neutrophils here, right? You can see a little bit of eosinophils here, right? That's a CML. This smut cell is not smut cell also, right? I'll show you smut cell and show for sure. Okay, CML. Few pointers in and around the CML. I'm not going to talk about your Philadelphia chromosome. Everyone knows that, right? Classical case scenarios. Let's say two case scenarios. 45-year-old splenomegaly. Massive splenomegaly. You like the term, right? Okay. This also is 45-year-old massively enlarged spleen. There are two scenarios which will have the same symptom, massive splenomegaly. It might even cross the midline, right? This patient has leukocytosis. This patient has pancytopenia. Which you think is CML? Which you think is CML among these two? Leukocytosis or pancytopenia? Leukocytosis CML, right? Leukocytosis plus shift to left. You will definitely remember that. Okay. Dragging sensation also, right? First one is CML, right? And obviously the most important finding, which is always underreported and ignored, is basophilia. I would like basophilia more than shift to left because there's no DD for basophilia. There's multiple DD for shift to left. That's where your leukemioid reaction comes, right? Basophilia, diagnostic. Pancytopenia and particularly monocytopenia. This, I won't think of PNH. I'll think of here hairy cell leukemia. A very, very classical feature of hairy cell leukemia, same massive splenomegaly. This CML. Okay. Same starting point, ending point is different. So please don't choose the answer based on first line alone. Ending point might be different, answer might be different. Patient, elderly patient with massive splenomegaly is not always CML. Look for the others, right? Could be hairy cell leukemia, could be CML, right? CML, we have the other finding. We call them an college girl appearance or the garden party appearance or whatever you want to know, whatever you want to call them, right? Because of lots of cells looking very different, like a party or a college girl, so we call them college girl appearance or garden party appearance, right? So CML, they differentiate between leukemioid reaction. How do you differentiate leukemioid reaction from CML? There's one word for it. It's leukocyte alkaline phosphatase will be elevated in case of a leukemioid reaction, will be low or zero in case of CML. Okay, this might come an older one which can help. Fine. Okay, hairy cell leukemia, microscopy, its clue is hairy cells. You have the hairy projections, that's a clue. There are few more things which have been asked in hairy cell leukemia, few markers. TRAP is a very good marker. Tartrate resin acid phosphatase positive cells, lymphoid cells is hairy cell leukemia, right? Annexin is a very, very good marker. Okay, annexin A1 or annexin V, whatever you want. Both of them are positive, but annexin A1 is more pronounced than annexin V. Fine. Then the mutation, what Toledin Blue said, BRAF mutation. Okay, there's a few points with regards to hairy cell leukemia. It's a tumor with very, very good prognosis. Fine. And CML, you know how to treat. Give your imatinib, look for RT-PCR, look for the change. Right. CML, the most important thing is there is no need for bone marrow examination. I suspect CML, you take a peripheral smear, from peripheral smear, give for FISH or karyotyping or PCR, diagnose, treat. I don't want this at all, right? Great, Karthik. Bone marrow biopsy feature is your fried egg appearance. That also is there in case of hairy cell leukemia. That also might help, right? Okay, great. So, but both of them starts with a similar clinical finding, and this image is that of a CML, multiple cells, lots of mature, immature cells. It's chronic myeloid leukemia. Fine. Lymphomas. So lymphomas, the symptom is same. Symptom for almost every lymphoma is lymphadenopathy. Actually, you cannot differentiate many things based on lymphadenopathy alone. It's primarily a microscopic diagnosis, right? Clinical hematology, DM is there. It's primarily half or more than half pathology. Treatment is the only thing which varies. Because though I can differentiate lymphoma, okay, this is Hodgkin's, non-Hodgkin's clinically, but unless and until microscopy and marker is done, you cannot differentiate. Again, I won't have classical clinical features here. I might have classical microscopic finding and classical markers. I'm going to just mention them if required genetics, right? Let's start with one by one. You're going to tell me everything. CLL. Age I'm ignoring. Like I said, Burkitt is the only person which happens in younger age. Rest everything is in older age. What all you know about CLL? Comment. Any finding you know about CLL? You already have commented a little bit early some of the findings. One is by default smart cell. Yes, and an absolute lymphocytosis. If you see this finding, think of a CLL. Okay, perfect. Marker wise, CD5 positive, beauty. CD23 positive, beauty. If there is something new coming up, if there's a new question come, CD200 positive, remember this. It is required. This is a flow cytometry marker. We rely more on CD200 rather than CD5 and CD23 as of now. Fine. Ibrutinib, superb. Ibrutinib can be a treatment. Ibrutinib is Bruton's tyrosine kinase inhibitor. It's a tyrosine kinase inhibitor, Bruton's tyrosine kinase inhibitor. Fine, perfect. Then I am not rely on this red and blue. These are informations more than enough for CLL. Right. Remember, CLL can present with autoimmune hemolytic anemia and also ITP. When this combination is present, we call them an Evans syndrome. Okay, we call them an Evans syndrome, just a combination of these. Fine. Okay, and come to mantle. Mantle cell lymphoma, it might present as intestinal polyps. As a very unique presentation. When you see a lymphoma with polyps, think of a mantle cell lymphoma. Fine. Mantle cell lymphoma, like you say, it is cyclin D1. That's important for me. Mantle cell lymphoma translocation of every lymphoma has 14 as common. So here it is 11, 14. The way my senior used to say to remember is, remember mantle as MAN put like this. So it looks like 11 there itself, right? 11, 14 translocation, classical for mantle. SOX11 was a PYQ. If cyclin D1 is negative, then I go for SOX11 as a marker. Fine. Okay, only then I go for SOX11 as a marker. But cyclin D1 negative mantle are very rare. So if the same repeat comes, write it. There are SOX11 negative mantle also. We not go into that. Fine. Okay. But these are few important points I want you to remember. Right. Then follicular lymphoma. Follicular lymphoma, the important clue is you have the history for years. A question says lymphadenopathy present for, let's say, 5 years, 6 years, unnoticed follicular, because a very, very slow growing tumor, right? It's a most common indolent lymphoma. When I say indolent, it's very, very, very slow growing. Good as well as bad. Right? Because it'll come to manifestation only with metastasis. 2/3 of them will present with bone marrow metastasis. But if I diagnose early, a very good prognosis, right? Great. Follicular translocation is important. 14, 18 translocation. Like I said, 14 is always common. And in 18th chromosome, we have BCL2. That's a problem translocation wise, which means IHC is also primarily dependent on BCL2. I'm not denying that there will be 19, 20 positive, 5 negative, all these are there. 10 positive, BCL6 positive. But BCL2 is the clinching point. Go with that, right? Follicular lymphoma has a very good prognosis if diagnosed early. When it goes rogue, it's definitely difficult, right? One thing I missed, I'm sure you know that CLL can progress to DLBCL. What is the syndrome called as? Or the transformation called as? CLL becoming DLBCL? Richter's transformation or Richter's syndrome, right? That also might come. It has been asked before, just remember that, fine? Okay. Let's go to Burkitt's. Burkitt's primarily is a child. Child, you know, African child jaw swelling, right? Could be a jaw swelling for an endemic Burkitt. Burkitt can present intra-abdominally or a child with intussusception. This also can be a presenting feature of Burkitt because Burkitt will present with intussusception only, fine? Then you see a microscopy. What's a microscopy of Burkitt? Everyone knows that, right? From the second year, we are reading only one guy, starry sky appearance. Burkitt is perfect, right? My senior used to write Burkitt like this. All mnemonics, what I say now, are copied. It's Burk 8. Right? Simple, remember, no? 8 is the important thing, like Red and Blue say. Start saying Burk 8. Burkitt's lymphoma, 8/14 is the most common translocation. Apart from that, I can have 2/8 and 8/22. Both of them also can happen. But 8th chromosome is very, very important for me because in chromosome 8, I have CMYC. Okay, CMYC is the most important marker. Ki67. Ki67 is 100% close to in Burkitt's. Ki67 is a proliferation index. Okay, it's a proliferation index, which means in Burkitt's lymphoma, at any point of time, all the 100% cells are dividing. That's why Burkitt's lymphoma is very, very important. All 100% cells divide in Burkitt's lymphoma. So treatment is difficult. Buckets will melt with chemotherapy. I give chemotherapy, all 100% cells will die. If I don't give and wait, it will spread. Early diagnosis is very, very important. But the problem with bucket is, let's assume you treat bucket. You give chemotherapy. All 100% cells die. Good or bad? What do you think? Let's say 100% are dividing. Chemotherapy kills only the dividing cells. All of them die. Good or bad? It is very bad. You always think it is good, right? It's very bad because when I kill 100% of the tumor cells, let's say million cells, what's the most common ion inside the cell? Most common ion inside the cell? It's bad because of the complication, toilet in blue. If I know the problem, I can easily find the solution. Potassium. Will there be hyperkalemia? All these cells die, so I end up in having hyperkalemia, right? Can I say phosphate is a very important buffer inside the cell? Yes, I'll have hyperphosphatemia. When the phosphate comes outside, what happens? It binds with calcium. I'll have hypocalcemia. Can I say your bicarbonate is also important as a buffer, right? You'll have acid-base disturbances. Not just that. When I destroy nucleic acid, I'll have more purine. I'll have hyperuricemia. So all these is the problem of Burkitt's treatment. We call them tumor lysis syndrome. Okay, it's good. If I can anticipate tumor lysis syndrome and treat it, it's very, very, very good. Fine, simple. Again, don't memorize tumor lysis syndrome. Don't use any mnemonic. I am killing a cell. This is the most common ion. You will never forget. Buffers. You'll never forget. Phosphate and your bicarbonate. When phosphate comes outside, binds to the extracellular calcium, reduces calcium because the only hypo. Rest everything is hyper. I destroy nucleic acid, uric acid comes outside, hyperuricemia. We can cause gout and renal disturbances, right? So here, what do you think is an important treatment? Hydration, RAS buricase, electrolyte maintenance. Very, very important for tumor lysis syndrome. If I can take care of that, I can take care of tumor lysis syndrome and obviously the patient comes back to normal. Fine? Okay, perfect. Hydration as a tumor lysis syndrome also was an PYQ, right? Because I have to maintain the hydration. I have to maintain the RAS buricase I have to give early on because uric acid problem will not be a problem. And also maintain the electrolyte disturbances. Fine? Perfect. Few classical findings. That's your smudge cell. The reason for smudge cell is loss of vimentin. Vimentin is a cytoskeletal protein in WBCs. When it's lost, it becomes very fragile. When I make a smear, it destroys. That's smudge cell, right? What is this guy? Here's a classical finding. What's that? That's your classical starry sky appearance, right? Here, the stars, supposedly stars are the macrophages. Okay? The sky, here is the tumor cells. The tumor cells are the blue sky and the star are the macrophages here as a classical starry sky appearance in Burkitt's, fine? Okay. Burkitt's blast will be, if there's in the bone marrow, the Burkitt's blast, like some of you said, will have vacuoles. Perfect. Manu said vacuoles are oil redopositive because vacuoles are nothing but fat. Fat is oil redopositive. That also will be SBB positive, Sudan black positive because it's fat. That's all, right? You'll have vacuoles there. Vacuoles will definitely be positive for this. Fine. Okay. What's this guy? That's your popcorn cell. Okay. That's a popcorn cell. That's there one side, right? So we'll compare Hodgkin's, classical, and your NLPHL. If you can identify popcorn cell without me drawing, you are really amazing in histopathology, right? Or you have seen the same image multiple times. It's very difficult to identify, fine? Okay. So we have classical Hodgkin's and we have nodular lymphocyte predominant Hodgkin's lymphoma, right? Okay, super. How many of you are from private medical college? Because there's one stereotype which I want to break. It's always said that I'm a student from a private medical college. I've met quite a few students say that, sir, I'm a student from private medical college. I don't have enough patients. I don't know whether I'll be a good doctor, right? These are, I'll be very honest and blunt. These are bullshit excuses which you're giving to yourself. Same with FMG also, tolerant blue. You know what? The term Reed-Sternberg cell, the person who discovered it, Dorothy Reed, she was not let into a medical school for the first 3 years or 2 years of her medical career because she was a girl. She was a girl, so she was not let into the school. No college. She had books. She read. She discovered, which every second year MBBS student will at least tell 100 times in their life. She came and told the boss Hodgkins, the cell which you discovered is wrong. They renamed Hodgkin's cell into mononuclear Reed-Sternberg cell. That's what grit and determination will give. Rest everything is excuses. You have knowledge, what your brain knows, your eye sees. And you are living in India. We are good in one thing, reproduction. If you don't have patience in India, you don't have anything. You will not see patients anywhere in the world. We are judgmental people, right? Go sit in a park after the exam. Look at every person. Antalgic gait walking. Atherosclerotic ear sign. Judge. Diagnose. Explore. A doctor does not need a OPD to diagnose. A doctor needs a knowledge and an application skill to diagnose. That's enough. So if you're starting giving excuses, move outside. Because excuses will push us down. We have good qualities of us and bad qualities of us. Let's use that to our advantage. That's all, right? Now, thanks to Reed, amazing person, right? That amount of determination, right? So classical RS cell, okay? Good cat. RS cells, classically they are CD15 positive, CD30 positive, and the most important thing, they are PAX8 weakly positive. If PAX8 is strong, it is not classical RS cell. NLPHL RS cell, that's your popcorn cell, or there's a variant of cell called as LNH type of an RS cell. Okay, this is CD20 positive. There are many more markers as well, but this word is concentrated for undergraduate. 45 positive, and PAX8 strongly positive. If it is weak, it is classical. If it is strong, it is this NLPHL. Fine. Okay, and also yeah, obviously CD15 and 30 are negative here. Fine. Okay. Classical as well as nodular sclerosis. Just few words regarding everything. Nodular sclerosis is a type of cell called as a lacunar variant. It's more common in abroad or in developed nations. I want to put India here, at least with respect to Hodgkin's lymphoma, it is there, right? And these are generally EBV negative. We have mixed cellularity, where I have mononuclear cell, classical binucleate outside RS cells, and this is more in developing nations, and this is EBV positive. Okay. Best prognosis will come to that, Manu, very soon. Just give me a second. Lymphocyte depleted, lymphocyte rich. The lymphocyte rich is only one thing. The background lymphocytes will be mostly, background cells will be mostly lymphocytes. Okay, and these are also EBV positive. Lymphocyte depleted is the rarest variant of Hodgkin's. It's lymphocyte depleted, which means someone is coming and destroying the lymphocyte, which is HIV. Obviously, when the HIV is there, EBV will always be there. So once HIV is there, they'll be having very less background lymphocytes. Since HIV is there, by default, prognosis is worst. Right? NLPHL is seen in younger individuals. Okay, NLPHL can be limited to a lymph node. They are generally limited to a single lymph node. They'll not spread mostly. Okay, and microscopy are the popcorn cells, and the CD markers are different, right? So when you come to the prognosis, once Ames has the prognosis in the order, they had the arrange based on the order, right? So the best is NLPHL. NLPHL is the best. Then comes your nodular sclerosis. Then comes your mixed cellularity. Then comes your lymphocyte rich. The last is lymphocyte depleted, in the order of reducing it, right? That's how the prognosis is. You have to compare everything, but if it's in classical Hodgkin's, the best prognosis is nodular sclerosis by default. Fine. Okay. Perfect. Depleted is the worst. I did say, yeah, lymphocyte debris is the worst. Okay, tell me what's the answer. Let's see if you can answer it. What's the diagnosis first? BABA. 19-year-old kid present with severe sore throat, cervical lymphadenopathy, fatigue, and mild leukocytosis. Atypical lymphocytes on that. Perfect. Can I call it infectious mononucleosis? Yes, perfect. This atypical lymphocytes was given a term, I am sure you must have heard this, called as an Downey cell. Okay. The cell is nothing but a lymphocyte, fine, with big amount of cytoplasm. They also have the cytoplasm, sometimes the cytoplasm looks like this. It's because the RBC go and intend them. Because of that, they are called as ballerina skirt appearance, right? Okay. It's the ballerina skirt appearance for the atypical lymphocyte. So now the question is about a virus. The virus will obviously be hit by T cells. It will not be by B lymphocyte. Any intracellular organism, be it a virus or an intracellular bacteria, T cells will be the predominant thing, like a mycoplasma. T cells will be more predominant than B cells, right? It's T lymphocyte and not a B lymphocyte. And these are actually also T cells. The CD8 T cells, which are trying to destroy the virus, happens to have the ballerina skirt appearance, and they are called as a Downey cell. Fine. Okay. Okay. I'll do one thing. I think I have to leave way for ma'am soon because ma'am will be taking ophthalmology. Can we stop it here? And I have a little bit of for systemic pathology. I'll take it sometimes down the road. Is that okay with you guys? I have a few more points left for systemic pathology because opthal will start by 3:30. Yeah, I'll stop with the general path and hemat. I'll definitely cover the same marathon sometimes at the end or sometimes after 9 p.m. We'll continue systemic pathology. A little bit pointers in systemic pathology which I want to convey, which is like your CVS, the vegetations, little bit of lung emphysema and occupational lung disease, about GIT, few polyps and others, nephrotic syndrome, and the glomerulonephritis. I'll cover this for sure. Take some time later cover. Go have your lunch and come back fresh for Ofthal. I'm sure Ofthal Sudha will make it wonderful for you guys. All the very best. Don't panic. I don't mind if you take a good rank or a bad rank, but I want you to be good doctors. That's the ultimate goal. Let's reach that. And when you focus that, no, you'll definitely get a good rank. That's a passing cloud in between. You'll definitely get a good rank. Don't worry about that, right? So, you guys, you've been an amazing round so far. Thank you for constant comments. Let's keep learning. Let's keep improving, right? Thank you, guys. Bye bye.
Hello everyone. Good afternoon and welcome to class. Please let me know if I am audible and visible and shall we start the session? Hello everyone. Good afternoon and welcome to class. Okay, thank you. So we'll start with Ophthal, and after this, after the very enriching section in ophthalmology from Dr. Ranjith, we will start with Ophthal. Ophthal is a short subject, so we will try to keep it short and high yield, so that you can have a breather before your next session. We'll try to finish it uh, in a short, concise way, and in such a way that we will cover all the important topics, but within a concise period of time. So I will start with a few simple topics, and as we go, I will go on to the more difficult topics. चलो, so शुरू करते हैं. The first topic that I want to discuss is vernal keratoconjunctivitis, a topic that is favorite with all examiners, whichever exam that you are appearing for, whether it is NEET PG or it is INI-CT, doesn't matter. You are very likely to get questions from here. So what is exactly VKC, vernal keratoconjunctivitis? What is it? It is a type of recurrent allergic conjunctivitis. So it's a type of recurrent allergic conjunctivitis, and it is also called by the name of spring catarrh. This is what we need to remember, because sometimes in the exam, instead of the name vernal keratoconjunctivitis, we get the name spring catarrh, and it is a type 1 hypersensitivity reaction. So by definition, it is a type 1 hypersensitivity reaction. And therefore, can you quickly recapitulate and tell me it is mediated by whom? It's a type 1 hypersensitivity reaction. So it is mediated by, it's mediated by IgE, and the cells which are involved are the mast cells. So it's mediated by IgE, and the cells which are involved are our mast cells. Correct. So now, next is that what are the symptoms of this condition? What are the symptoms? The symptoms are obviously itching, irritation, redness, watery discharge, and after recurrent episodes, you can have muddy discoloration of the eyes. Now, let us look at these two images. Very, very, very common images which are asked in the exam. So, see the first image. What is this image? This is an image of the everted upper lid, right? So, the upper lid has been everted, and what do we see here? We see some flat topped elevations or papillae. So these are the flat topped elevations or papillae, and this appearance, what is it called? The flat topped elevations or papillae, they give this appearance to the upper tarsal conjunctiva. And what is this called? This is typically what is called as our cobblestone appearance. A very common one-liner and also a very common image-based question. And the second image that we see close to the upper limbus, look at these whitish lesions. This came in the last NEET PG paper. This appearance, these whitish dots, they are called as our HT spots or the Horner-Trantas spots. So the two important signs that you need to remember in case of vernal keratoconjunctivitis is that when you evert the upper lid, you get to see these flat topped elevations, which is called as our cobblestone appearance, and on the upper limbus there are these whitish lesions. What are these whitish lesions? They are actually aggregation of epithelial debris and eosinophils. So what are they? They are aggregation of eosinophils and epithelial debris, and they form these Horner-Trantas spots. Now, apart from this, what other feature do we get? See, because of the rubbing of these papillae on the surface of the cornea, the corneal surface gets eroded and you get multiple small erosions. This is called as punctate epitheliopathy. This is called as punctate epitheliopathy. So multiple small erosions on the surface of the cornea due to the rubbing of the papillae on the cornea, and if these small epithelial erosions are not taken care of, they will join together and they will form one large erosion, and that is called as our shield ulcer. This is also another important one-liner. So two important images and one-liners: cobblestone appearance, Horner-Tranter spots, and shield ulcer. Right? Now, what is the treatment that we need to remember for VKC? So please remember, the treatment of VKC is divided into two broad categories. The treatment of the acute episode, that is, the child is brought to us with complaint of irritation, itching, watering, etc. And the second is the prevention of recurrence, because it's a recurrent allergic conjunctivitis and it happens just before the onset of the peak summer months, and children who get it, they usually get it every year. Oh, I forgot one thing. What this is seen more commonly in boys or girls? Tell me. This is seen in boys or girls? It's more commonly seen in boys or girls? Correct. It is more commonly seen in boys, and the age group is 5 to 15 years. It is commonly seen in boys between 5 to 15 years. So see that parents, they know that this episode will go away, but they are very much afraid that it is going to come back. So the prevention of recurrence is as important as the treatment of the acute episode. Now this also is a place where we tend to make mistake. So please remember that in acute episode, the first class of drugs that we use are lubricants. Now lubricants are only meant for symptomatic relief. They just provide relief from the irritation, but they are not actually going to address the pathology. So then, which is the class, or which are the three classes of drugs which are used for the treatment of the acute episode? The three classes of drugs are topical antihistaminics. The three classes of drugs are topical antihistaminics. If the child does not improve with topical antihistaminics, we are going to step it up to topical steroids. We are going to step it up to topical steroids. And if the patient does not improve with topical steroids also, then we step it up to topical immunomodulators. So this is like a step ladder therapy, where we start with the softest molecule and then step it up. Now, so lubricants, antihistaminics, steroids, and immunomodulators, they are used in the treatment of the acute episode. Now, which class of drugs is used in the prevention of recurrence? Now, please remember that for prevention of recurrence, the class of drugs that is used is the mast cell stabilizers. Now, the mast cell stabilizers have no role in the treatment of the acute episode. So this is a question which comes like this, that which of these classes of drugs is not used in the treatment of the acute episode? That's how it is going to come. So that's why you remember it this way, that for prevention of recurrence, because the cells involved are the mast cells, that's why recurrence is prevented by using mast cell stabilizers. All the other classes of drugs, that is antihistaminic, steroids, and immunomodulators, are used in treating the acute episode. And lubricants obviously will be used in the acute episode for improving the symptoms. Okay, so this is like a very commonly asked topic in all our exams, that is vernal keratoconjunctivitis or VKC. It's a type of recurrent allergic conjunctivitis. It's a type of recurrent allergic conjunctivitis. Now, another topic from the conjunctiva that is commonly asked in the exam is this. That is your xerophthalmia. Now, xerophthalmia, which is caused by deficiency of vitamin A. So, xerophthalmia, this is caused by deficiency of vitamin A. Now, there are lots of small questions that are likely to be asked from here, that have the potential to be asked from here. So, we will discuss that. So, first of all, let us quickly recapitulate how does the deficiency of vitamin A affect the eye. So, the deficiency of vitamin A, it affects the rod cells of the retina. How does it affect the rod cells of the retina? In the rod cells of the retina, there is a pigment by the name of rhodopsin pigment. There is a pigment by the name of rhodopsin, and these rod cells of the retina are responsible for vision in dim light. So that's why when the rod cells and the synthesis of the rhodopsin pigment is affected, the patient is going to end up with night blindness. The patient this is going to lead to night blindness or nyctalopia. But the deficiency of vitamin A also affects the ocular surface. Now quickly I want one of you to tell me what is the epithelium of the ocular surface. Again an important one-liner. Tell me what is the epithelium of the ocular surface? What is the epithelium of the ocular surface? Okay, I'll just give you a clue. Stratified. What is the epithelium of the ocular surface? The epithelium of the ocular surface is squamous, correct? If I have to put it little more specifically, it is stratified, squamous, non-keratinized. Very good. So see, the normal epithelium of the ocular surface is stratified, squamous, non-keratinized epithelium. Now in the deficiency of vitamin A, this undergoes metaplasia. That means it changes. This undergoes metaplasia and it becomes what is called as stratified, squamous, keratinized epithelium. So it becomes like the epithelium of your skin. So stratified, squamous, non-keratinized epithelium changes to stratified, squamous, keratinized. And the net result of this is two things. It gives rise to dryness or xerosis of the ocular surface, and eventually there is going to be surface ulceration or melting, which is also called as keratomalacia. So this is how deficiency of vitamin A is affecting our ocular surface. Now see, what we need to do is we need to learn the WHO classification of xerophthalmia. Now this is something you need to know like the back of your hand, because the probability of getting questions from here is always high in any exam. So see, let us look at what is the WHO classification. So the WHO classification starts with XN. So the WHO classification, it starts with XN. So what is XN? XN is xerophthalmia night blindness. XN is xerophthalmia night blindness. Okay, now see, night blindness, this is the earliest symptom. So if we get a question which is the earliest symptom of xerophthalmia, the answer is going to be night blindness. Now see, after stage XN comes stage X1. Now 1 is divided into 1A and 1B. Now 1 is the stage of conjunctival xerosis or dryness. It is conjunctival xerosis or dryness. Now if we are asked the question which is the earliest sign, then the answer is going to be conjunctival xerosis. So don't make a mistake here. Earliest symptom if we are asked, तो answer होगा night blindness. But अगर earliest sign है, sign is something which is seen by the physician. So that's why it is conjunctival xerosis. But see, any conjunctival dryness is actually not xerophthalmia. So stage X1B is Bitot spot, which you can see in this image. So this is an image of Bitot spot. You can see this whitish foamy lesion close to the limbus. This is Bitot spot. And Bitot spot, this is the most specific sign. So this is your most specific sign. So see, 3 possibilities of questions. Earliest symptom is night blindness. Earliest sign is conjunctival xerosis, but the most specific sign is Bitot spot. Now, after the stage of conjunctival xerosis comes the stage of corneal xerosis, which is X2. So in X2, the cornea starts becoming dry, and then is the stage of corneal ulceration, which is again divided into 3A and 3B. So 3A means less than 1/3 of the cornea is involved, and more than 1/3 of the cornea is involved means 3B. Now, after the cornea ulcerates, eventually it is likely to heal, and when it heals, there will be formation of scar. So see, this excess, this is the stage of conjunctival of corneal scarring, and when there is corneal scarring, there will be loss of corneal transparency. When there is scarring, there is loss of corneal transparency, and if there is loss of transparency, obviously this is going to become an important cause of blindness in children. So another question that is asked from here is, so see, once it has become an ulcer, it is going to scar. So the question that is asked from here is, up to which stage is xerophthalmia reversible? So it is reversible up to this stage, that is X2. So it is reversible up to this stage. Up to this stage. So up to this stage, that is X2, it is reversible. Once it becomes an ulcer, it is not reversible. So earliest symptom, night blindness, earliest sign, conjunctival cirrhosis, most specific sign, bite or spot, and reversible up to the stage X2. Right now, see, where do we get this xerophthalmia? Obviously we get it in malnourished children. So what is the treatment? The treatment is obviously supplementation of vitamin A. So what is the dose of vitamin A? So we remember that for children greater than or equal to 8 kgs or greater than equal to 1 year, our dose is 2 lakh international units to be given orally. 2 lakh international units to be given orally. And what is the regimen? The regimen is day 0, day 1 and day 14. So 2 lakh international units to be given orally on day 0, day 1 and day 14. And we say that for children less than 8 kgs or less than 1 year. For children less than 8 kgs or less than 1 year, what is the dose? Correct. It is 1 lakh international units to be given orally. 1 lakh international units given orally, day 0, day 1, day 14. Day 0, day 1 and day 14. Now please listen to me carefully. Now because these are malnourished children, there is a high possibility that sometimes the age and the weight, they will not match. So generally what they do is to confuse. They will give you a question where the age and the weight, they do not match. Meaning, suppose they say that there is a child who is like 1.5 years old, but the weight is less than 8 kg. They say that it is the weight of the child is 7 kgs and the age is 1.5 years. Now tell me what will be the dose. The age is 1.5 years and the weight of the child is 7 kgs. What is the dose of vitamin A to be given to this child? What is the dose? Meaning, if our age and weight are not matching, then we have to give according to the, yes, we have to give according to the weight. So please remember that this is the therapeutic dose. It is not the prophylactic dose. It's the therapeutic dose. Okay, so whenever there is a discrepancy between the age and the weight, we have to always consider the weight, because in children, as you have been learning in pediatrics, any dose is always based on per kg body weight, right? It is always based on per kg body weight. So whenever there is a discrepancy between the age and the weight, always give on the basis of the weight. So in this question, if it says that the age of the child is like 1.5 years, but the weight is 7 kgs, we have to give according to the basis of 7 kgs. So the dose is 1 lakh international units to be given orally. Right now, see, if the child is very sick and we are not able to give an oral dose, then what are we going to do? Then we can give an intramuscular dose. And please remember and be careful as to what is asked in the question, because your intramuscular dose is half of the oral dose. So where it is 2 lakhs, it is going to become 1 lakh, and where it is 1 lakh, it is going to become 50,000. So please be careful whether in the options, see, as a reflex, we always remember it as 2 lakh, 1 lakh, 2 lakh, 1 lakh. हम इसे ऐसे ही memorize करते हैं. But please remember 2 lakh, 1 lakh is the oral dose which you have memorized. But sometimes in the exam they ask the IM dose. तो उसको read करना. So these are the 2-3 places where this question goes wrong. It's a commonly asked question, but very commonly it goes wrong. One, it goes wrong if the age and the weight do not match. Always remember we give according to the weight. Second, read the question carefully to see whether they have asked us about the oral dose or the intramuscular dose. Right, so this is another very important topic that we have from conjunctiva. Next, chalo, we will go to this topic, which is our infective keratitis. We are going to go to infective keratitis. Now, infective keratitis is also something I always say you have to remember like the back of your hand. And if somebody asks you in your sleep also, you should be able to say. So, we will divide it into 4 parts. That is bacterial corneal ulcer, fungal corneal ulcer, viral keratitis, acanthamoeba keratitis. Now, for bacterial corneal ulcer, the symptoms. What are the symptoms of bacterial corneal ulcer? The symptoms are pain, redness, watching, photophobia, decrease in vision. Now, this is essentially the same symptoms that we have for fungal corneal ulcer also. Now, if we have to differentiate, the thing that we need to remember is that in case of bacterial corneal ulcer, the symptoms are more pronounced. The symptoms tend to be more pronounced in case of a bacterial corneal ulcer. Now, if you look at the ulcer, it is a single lesion and the margins are well defined or sharp. So have a look at this image. This can also come as an image based question. So if you look at this, if I were to just outline this, see, this is a single lesion. It's a single lesion and the margins are sharp or well defined. So single ulcer, well defined margins. Next is the hypopion. Next is about the hypopion. Now, please remember that hypopion is not a must with a corneal ulcer, because hypopion means pus in the anterior chamber. It is not pus in the cornea. So, hypopion means pus. Just 1 minute. So, hypopion means pus in the anterior chamber. Now, in case of bacterial corneal ulcer, so this we are talking about bacterial corneal ulcer. How do we identify it from the image? As I said, there is a single lesion and the margins are well defined. Now, if the hypopion is present, the hypopion is mobile. What do I mean by mobile? I mean that it is not very thick, which means that if I turn the head of the patient, then the pus is going to move with gravity. So it is a mobile hypopion. And also it is sterile. Sterile means if we were to aspirate that hypopion, we would find that it contains only pus cells. That is, neutrophils will be present, but there will be no bacteria. Why? Because bacteria do not grow into the anterior chamber. So single lesion, well-defined margins, mobile and sterile hypopion. Mobile and sterile hypopion. Now, next, what do we have to remember? We have to remember what is the drug of choice or what is the treatment. Now, obviously for bacterial corneal ulcer, the treatment will be antibiotic, but these antibiotics have to be given under high concentration. So what are they called? They are called as fortified antibiotic eye drops. They are called fortified antibiotic eye drops. Now, which is the antibiotic that is commonly used? What we use is ceftazidime. Ceftazidime 5% eye drops. Ceftazidime 5% eye drops. And what is the adjuvant that is used? The adjuvant is atropine eye drops. What is the role of atropine eye drops? Atropine eye drops, they act as cycloplegic and they are responsible for pain relief. So they are cycloplegic eye drops and they help in pain relief. Cycloplegic eye drops and they help in pain relief. So these are the points to be remembered about bacterial corneal ulcer. The symptoms are more pronounced: single lesion, well-defined margins, mobile and sterile hypopion. Treatment: fortified antibiotic eye drops, ceftazidime 5% and atropine eye drops, which is an adjuvant. Now, very commonly asked question, which is the drug that is absolutely contraindicated in bacterial corneal ulcers? Which is the drug that is absolutely contraindicated? Which is the drug that is absolutely contraindicated? It is obviously topical steroids, because though there is such a lot of inflammation, we are not supposed to give steroids because there is an actively growing organism. Absolutely contraindicated is our steroids. On the same lines, let us learn the next one now, or let us quickly revise the fungal corneal ulcer. So here also, see, the symptoms are essentially the same: pain, redness, photophobia, decrease in vision. But typically textbook teaching says that here the symptoms tend to be less pronounced. The signs are more, the symptoms tend to be less pronounced. So for a fungal corneal ulcer, the symptoms are less, the signs are more. And there is often a preceding history of trauma with vegetative matter. Now, trauma with vegetative matter, generally, if it is mentioned in the question, you can mark it as fungal corneal ulcer. So either they will say trauma with vegetative matter, or they say that it is a farmer in the harvest season. This because at the time when the farmers cut their crops, at that time they get some trauma and they can end up with corneal ulcers. Okay, so the symptoms, they tend to be less pronounced, but there is often a preceding history of trauma with vegetative matter. Now, what does this ulcer look like? Now here generally you will find that it is a lesion. It looks like this. There is one large lesion which are surrounded by smaller lesions. What are these smaller lesions called? These smaller lesions are called as satellite lesions, and typically the margins are described as feathery or fuzzy. They are typically described as feathery or fuzzy. And if there is a hypopion, as I said, hypopion is not a must, but if there is a hypopion, it is immobile or fixed, meaning it is so dense or so thick that even if you move your head, then the hypopion or the pus does not move. And if you aspirate that pus, it is generally non-sterile. Non-sterile means that it contains fungal hyphae. This means that fungi generally grow into the anterior chamber. It contains fungal hyphae, so fixed and non-sterile hypopion. So multiple lesions or satellite lesions, margins are feathery or fuzzy, fixed and non-sterile hypopion. What would we say is the drug of choice here? See, in India, the drug of choice is generally natamycin 5% eye drops. Now, out of so many, why did we choose natamycin? We chose natamycin because most fungal ulcers in India, they are caused by aspergillus. And aspergillus is very, very sensitive to natamycin. So, that's why natamycin eye drops. And here also, the adjuvant of choice is atropine eye drops, which is meant for pain relief. Atropine eye drops, which is meant for pain relief. And here also, what is absolutely contraindicated is your steroids. Absolutely contraindicated is your steroids. So the symptoms are essentially the same: pain, redness, photophobia, decrease in vision, but the question generally mentions a preceding history of trauma with vegetative matter, or the question will mention that the patient is a farmer. Both of which indicate this only, that there is a trauma with vegetative matter. The lesions generally, they may be single, but typical lesions are like this: one large lesion with satellites, margins are feathery or fuzzy, hypopion is non-sterile and immobile. Drug of choice, we will say natamycin, and adjuvant is atropine. So this is fungal corneal ulcers. So quickly revise ho gaya, fungal and bacterial corneal ulcers. Shall we move to the next one? Shall we move to the next one? Yes? Chalo. The next one is HSV keratitis. Salient points to remember: herpes simplex virus keratitis. HSV keratitis or herpes simplex virus keratitis. Now, most important first thing to remember in viral keratitis is that it affects each layer of the cornea separately. So we have epithelial, stromal, disciform, endothelial, 4 broad varieties of keratitis. So out of which we start with epithelial, because epithelial is different, the others can all be grouped together. ये हमें याद रखना है. So epithelial जो है, this is separate. Why it is separate? Because इसका pathophysiology is completely different from the others. So epithelial keratitis. Now, epithelial keratitis, this is caused by direct invasion of the epithelium by the virus. This is caused by direct invasion of epithelium by the virus, and also it is caused, there is active viral replication. there is active viral replication, direct invasion of the epithelium by the virus, and active viral replication. Right? And also what we need to remember is that it has two stages. The early stage of HSV keratitis, this one that you see here, this is called as dendritic ulcer. And what is the late stage called? The late stage is called as geographic ulcer. And in the early stages, actually, the ulcer is not very clearly visible. So to make it visible, what is the dye that you use? This was a question last year, I think, or maybe the year before that in NEET PG. A very recent question in your NEET PG paper. So here, to make the ulcer visible, you stain the ulcer with fluorescein dye. The ulcer is stained with fluorescein dye. And you examine under which filter of the slit lamp? It is examined under the cobalt blue filter of the slit lamp. It is examined under cobalt blue filter of the slit lamp. Now this is a PYQ. They had given this image and they had asked that what is the stain and what is the filter. So see, the stain is fluorescein and it is examined under cobalt blue filter of the slit lamp. In the first picture you will get a lesion like this with branches. This is called as the dendritic ulcer, and in the late stage it is kind of shapeless, that is called as geographic ulcer. So epithelial keratitis is caused by active destruction of the epithelium by a replicating virus. In the early stages, to make the ulcer visible, you stain it with fluorescein dye and examine it under cobalt blue filter. What is the treatment for epithelial keratitis? Because it's an actively replicating virus, the treatment is obviously antiviral. What we usually give is acyclovir 3% eye ointment. So the treatment is acyclovir 3% eye ointment. ये जो है, this is your epithelial keratitis. This is epithelial keratitis. But there are other three varieties also. The other three varieties actually हम इनको एक साथ पढ़ सकते हैं. Why? Because they are essentially very similar. That is, we have stromal keratitis, we have disciform keratitis, and we have endothelial keratitis. So stromal, disciform and endothelial keratitis. Now why are we learning all these together? Because stromal, disciform and endothelial keratitis, all these, they are caused by immune reaction to the viral antigen. They are caused by immune reaction to the viral antigen. And they with subtle differences, all of them, they look like a localized area of stromal edema. There is a localized area of corneal edema. Now, because this is caused by an immune reaction to the viral antigen, what is going to be the treatment here? What is going to be the treatment here? It is caused by an immune reaction to the viral antigen, presence with a localized area of corneal edema. Here the treatment is actually topical steroids, because it is correct, because it is an immune reaction. Topical steroids, which is given under the cover of oral acyclovir. Topical steroids under the cover of oral acyclovir, that is the treatment. ठीक है, तो इन तीनों को एक साथ याद रखेंगे. So epithelial is different. It is caused by a direct invasion of the epithelium by the virus. That's why treatment is acyclovir, antiviral. And also please remember, यहाँ पे ये भी पूछते हैं, what is absolutely contraindicated in epithelial? So absolutely contraindicated in epithelial is actually steroids. Absolutely contraindicated in epithelial is steroids, whereas the drug of choice in the other types is steroids. Okay, so for stromal, disciform and endothelial, the drug of choice is steroids. Now, another important thing जो यहाँ से याद रखना है, what is the special feature that we need to remember about, what is the special feature? The special feature of HSV keratitis that we need to remember, the special feature that we need to remember is that there is a decrease in corneal sensation. There is decrease in corneal sensation. Now, because of the decrease in corneal sensation, what happens is that in the acute stage, your ulcer is painless. It's a painless ulcer in the acute stage, but what is the long-term sequelae? The long-term sequelae is permanent damage to the cornea because of this. And what is that called? This is called as neurotrophic keratopathy. So because of nerve damage, there is a permanent damage to the cornea, and that's called as neurotrophic keratopathy. Now please listen to one thing carefully here where we may make mistake. Neurotrophic keratopathy is not an active disease. It's a long-term sequelae or it is a complication. So neurotrophic keratopathy, the old name of this used to be metaherpetic ulcer. Metaherpetic ulcer. We don't use the name now, but just in case it comes. So this is also an MCQ, that which of these is not an active manifestation of HSV. So neurotrophic keratopathy or metaherpetic ulcer is not an active manifestation. It's a long-term sequelae or a complication of HSV keratitis, which is caused by decrease in corneal sensations. So now if you get neurotrophic keratopathy, then what is the treatment for neurotrophic keratopathy? The treatment for neurotrophic keratopathy is copious lubricants, and there is a procedure that is done which is called as lateral tarsorrhaphy. Lateral tarsorrhaphy. Lateral tarsorrhaphy means what? We stitch the upper lid and the lower lid together at the side. So that's why what happens, the size of the palpebral aperture becomes smaller, and therefore it's a little protected. So lubricants and lateral tarsorrhaphy, that is our treatment for neurotrophic keratopathy or metaherpetic ulcer. Okay, so these are the salient points that you need to remember about viral keratitis or HSV. ये दोनों images जरूर याद रखना. Name of the stain याद रखना, name of the filter याद रखना. याद रखना कि epithelial keratitis में drug of choice is acyclovir, which is given in the form of an eye ointment. Contraindicated is steroids. For all the other varieties, steroids is the drug of choice. And the special feature is corneal hypoesthesia or decrease in corneal sensation, which makes the ulcer pain less in the acute stage, but leads to the long-term sequelae of neurotrophic keratopathy or metaherpetic ulcer, which is not an active stage of the disease. It's a complication. It is treated with lubricants and lateral tarsorrhaphy. Okay. Now the last type of keratitis that we need to remember is acanthamoeba keratitis. The last type of keratitis that we need to remember, that is acanthamoeba keratitis. अब acanthamoeba keratitis में सबसे पहला question that is asked is that what is this is typically the picture of acanthamoeba keratitis. This is acanthamoeba keratitis. Now, acanthamoeba keratitis mein the first question is, what is the most important risk factor? Now, this I think everybody should be able to say which is the most important risk factor for the development of acanthamoeba keratitis. Chalo, what is the most important risk factor? Quickly, salient points. What is the most important risk factor for the development of acanthamoeba? Correct. The most important risk factor is the misuse of contact lenses. And what kind of misuse do we actually mean? It means use of tap water to clean the contact lens. Use of tap water to clean the contact lens. Use of tap water to clean the contact lens. But here I want to caution you to another MCQ. So we have learned that the most important risk factor for the development of acanthamoeba keratitis is misuse of contact lens. But if we are asked which is the most common organism in causing ulcer in a contact lens misuser, causing ulcer in CL misuser, what is our answer? What is the most common organism causing ulcer in a CL misuser? It is not actually acanthamoeba. What is it? Correct. It is Pseudomonas. So don't get this wrong. All contact lens misusers don't get ulcers caused by acanthamoeba, which is good actually, because acanthamoeba is difficult to treat. So if a contact lens misuser gets a corneal ulcer, most likely it is a bacterial ulcer only. It is a bacterial ulcer only caused by Pseudomonas. But when are we going to suspect it is acanthamoeba? We suspect it is acanthamoeba when the ulcer looks like this. So this ulcer, what is it called? Look at its shape. The shape is very, very typical. This is called as a ring ulcer. This is called as a ring ulcer. And another important feature to be remembered about acanthamoeba is it causes keratoneuritis. Keratoneuritis means inflammation of the corneal nerves. So this is the most painful corneal ulcer. This is the most painful corneal ulcer. So your HSV is essentially painless and your acanthamoeba is excruciatingly painful. It's excruciatingly painful. The typical sentence that is used is that the pain is out of proportion to the clinical signs. This is a one-liner. Pain that is out of proportion to clinical signs, that is acanthamoeba keratitis. Okay, so because of keratoneuritis, it is the most painful and typically described as pain which is out of proportion to clinical signs. Now see, if you scrape this ulcer and you send it for stain or staining and culture, what is the stain and what is the medium for culture? See, it's for bacterial fungal, you will be able to say from microbiology. That is why I didn't discuss it, but this is like uncommon, so I'll just go through it once. So here, what do? You are obviously going to go for corneal scraping. And what are the names you need to remember for exam? The stain is calcofluor white stain. I'll come to the treatment. Let us first establish the diagnosis. Calcofluor white stain. And the medium for culture is non-nutrient agar enriched with E. coli. Non-nutrient agar enriched with E. coli. Please don't ask me anything about this. I don't know anything except the names, but the names come and that's why I'm telling you to memorize it. Calcofluor, this is microbiology, but ये नाम याद कर लो. यही पूछते हैं, इतना enough है. Calcofluor white stain and non-nutrient agar enriched with E. coli. Okay, so once we have established the diagnosis, now obviously we come to the treatment. Once again, see, uncommon organism, uncommon drug, but we need to know the names of the main drug only. The main drug is PHMB. PHMB stands for polyhexamethylene biguanide. PHMB eye drops, polyhexamethylene biguanide, PHMB. And also the next class of drugs is propamidine. PHMB, but if you have to choose an option, we will choose PHMB. That is the first class of drugs that is to be used. So treatment is PHMB or polyhexamethylene biguanide eye drops, and second line will be propamidine. So like इतना ही इसमें याद करना है. So use of tap water to clean contact lenses, but the most common organism in a contact lens misuser is actually Pseudomonas. So when do you suspect acanthamoeba? When you get a picture like this, when it is a ring ulcer and the pain is out of proportion to your clinical signs. Confirmation of diagnosis by scraping. The stain that is used is calcofluor white stain and the medium for culture non-nutrient agar enriched with E. coli. If we are asked drug of choice, we will mark PHMB, polyhexamethylene biguanide, and the other class of drugs which can be used is propamidine. ठीक है, चलो. This finishes our infective keratitis. Now the good part about infective keratitis is that there is rarely something very new or novel that is asked from here. They generally ask the same images, the same questions, and usually if you get a question from here, it's a sure short question. Next, another topic from cornea which is asked is this. See, this is keratoconus. Now keratoconus, by definition, it is a non-inflammatory corneal ectasia. Now the word ectasia with respect to the cornea, what does it mean? What does the word ectasia with respect to the cornea here mean? It means protrusion of the cornea associated with thinning. It is protrusion of the cornea associated with thinning. Now, the problem with this kind of a corneal protrusion is that it gives rise to irregular myopic astigmatism. So, the cornea is protruded, the shape is disturbed, and it doesn't have any pattern. So, a common question that is asked from here is, what is the expected refractive error in keratoconus? The expected refractive error in keratoconus is irregular myopic astigmatism, and because of this irregular myopic astigmatism, there is a frequent change of glasses, and the patient is not happy with the glasses because irregular astigmatism doesn't get corrected with glasses. And when you do a retinoscopy for this patient, you get a splitting of the reflex, which is called as the scissoring reflex. So scissoring reflex is an early sign of keratoconus and a commonly asked question. So the expected refractive error in keratoconus is irregular myopic astigmatism, and because of this there is a frequent change of glasses and it gives rise to scissoring reflex on retinoscopy. Now, what are the signs? Number one is Munson's sign. Look at this picture. This is your Munson's sign. So, what is the Munson sign? The Munson sign is that when the patient is asked to look down, the protruded cornea will press or indent on the lower lid. So, the protruded cornea indents or presses on the lower lid. This is Munson's sign. Next, there is disturbance of the tear film in keratoconus. So, there is deposition of iron at the base of the cone. So, at the base of the cone, there is a pigmented line. This pigmented line at the base of the cone, this is called as Fleischer's ring. Again, important MCQ. So, what is the Fleischer's ring? The Fleischer's ring is a pigmented line at the base of the cone. Pigmented line at the base of the cone due to iron deposition. Pigmented line at the base of the cone due to iron deposition. This is Fleischer's ring. Next, because of the stretching of the cornea, there is development of striae on the cornea, and these are called as Voigt's striae. Now, two important points to be remembered under Voigt's striae is, we are asked in which layer of the cornea do we get Voigt's striae. So, Voigt's striae, they are seen on the Descemet's membrane. They are seen on the Descemet's membrane of the cornea. They are seen on the Descemet's membrane and they are vertical in direction, which we remember it as V for V. They are seen on the Descemet's membrane and they are vertical in direction. Okay, so if I were to go over it once more, the expected refractive error is irregular myopic astigmatism. We get scissoring reflex on retinoscopy. On looking down, the patient's protruded cornea indents the lower lid, that is Munson sign. Because of the disturbance of the tear film, there is a pigmented line at the base of the cone due to deposition of iron, and that's called as your Fleischer's ring. Then because of the stretching of the cornea, there are striae on the cornea which are called as Voigt's striae, and Voigt's striae are vertical in direction. Now, keratoconus, how do you confirm the diagnosis? Or if I were to say what are the investigations for keratoconus? Now, the best investigation, or if you are asked what is the investigation of choice, the answer will be corneal tomography. Corneal tomography. What is tomography? Tomography helps you to analyze the surface of the cornea as well as the thickness. So both surface and thickness you get to know in tomography. However, if the tomography is not available, then the next investigation you can do is corneal topography. Now, what is the difference between tomography and topography? In tomography, you get to analyze the surface as well as the thickness, whereas in case of topography, we will get to know only the thickness. Only the surface and not the thickness. So, if tomography is not available, then the next possible investigation is corneal topography. So, I'll just go over it once more. Tomography helps us to analyze both the surface as well as the thickness, whereas topography will just give us a surface analysis. So, it's kind of inferior to tomography. So, tomography is the best. Then comes topography. And Yes, what do I mean? But you are saying pentacam, these are all types of tomographies. So OBSCAN, pentacam, these are actually, the actual name is corneal tomography. Now, depending on different companies, they have given different names to their machines. So pentacam is not the name of the investigation. It is the name of the machine that has been given by the company. So OBSCAN, pentacam, these are names. Like for example, paracetamol is known by different names like that. Okay, so corneal tomography, then corneal topography, and if this is also not available, then we do some basic investigations, that is keratometry and pachymetry. Keratometry and pachymetry. So keratometry and pachymetry. So keratometry and pachymetry are basic investigations. Keratometry will show that the curvature is increased, and pachymetry will show you that your thickness is decreased. So increased curvature and decreased thickness. Okay, chalo. Now let's go to what is the treatment. What will be the treatment? See here, the problem is the irregular myopic astigmatism and it is not getting corrected with glasses. So we will try to smoothen out the cornea by using contact lenses. So the contact lenses are rigid gas permeable contact lenses or RGP contact lenses. So rigid gas permeable contact lens. Rigid gas permeable or RGP contact lens. Now the problem with RGP lens is that if the cornea becomes too protruded, the lens will not stay, it is going to slip. So you have to do a procedure to flatten the cornea. That is called as C3R. What is the full form of C3R? Corneal collagen cross-linking with riboflavin. Corneal collagen cross-linking with riboflavin. Now by this procedure, you flatten the cornea, and after flattening the cornea, then you try to fit the lens again. Sometimes even after C3R, if the patient is not improving, then you do a procedure which is called as ICRS. ICRS is intracorneal ring segments. Intracorneal ring segments or ICRS. What are here? Certain rings are inserted into the cornea and it helps to correct the irregular astigmatism, ICRS. And the last option when nothing is working is keratoplasty. Keratoplasty obviously means cornea transplantation. Keratoplasty or cornea transplantation. Right, rigid gas. So first line of management is RGP contact lenses. Then is, if you're not able to fit the lens, you go for C3R to flatten the cornea, that is corneal collagen cross-linking with riboflavin. Then ICRS, intracorneal ring segments, and last option when nothing is working will be keratoplasty. So these are the salient points that you need to remember under keratoconus. याद आ रहा है ना सबको? I want to keep it short and high yield so that we touch on all the important points in all the important topics. Yes? Chalo. So these are like the must know things or the last minute revision things that we have under conjunctiva and cornea. अब चलते हैं another important topic, that is refraction and refractive errors. So quickly what we'll do is we will quickly first go through the images of the refractive errors and उसके बाद we will go to the questions on glass prescriptions जहाँ पे maximum गलती होती है. So let's come to these images. So tell me, first we will go through the images of the refractive errors, that is myopia, hypermetropia and the different types of astigmatism. Chalo, let's look at the first one. See, this is in this. These are the parallel rays of light. They are meeting at this point F, which is in front of the cornea. So this point F, which is in front of the cornea, what are we going to call this? The parallel rays of light. Parallel rays means distant rays after refraction meet at a point in front of the cornea. This is simple myopia. This is obviously simple myopia, or you can say myopia, whatever you choose to call it. Next, the exact opposite of myopia, these are the parallel rays of light. They are meeting at this point F, which is behind the cornea. So this is the opposite of simple myopia. So obviously this is simple hypermetropia. तो ये है सिंपल हाइपरमेट्रोपिया, सिंपल हाइपरमेट्रोपिया. बट जनरली ये एग्जाम में पूछते नहीं है. व्हाट दे आस्क इन द एग्जाम आर दीज, दैट इज द पिक्चर्स ऑफ एस्टिग्मेटिज्म. सो फर्स्ट ऑफ ऑल, हाउ डू वी आइडेंटिफाई दैट दिस इज अ पिक्चर ऑफ एस्टिग्मेटिज्म? In astigmatism, instead of one focal point, there will be two focal points, because there is a difference between the two principal axes. There's a difference between the two principal axes. So here, the rays of light which come in, they have come in as a single bundle, but inside they have actually split into two, and so you have two focal points. This is F1 and this is F2. So in the first picture, what do we see? In the first picture, you see that F1 is on the retina. So F1 is emmetropic. F1 is emmetropic. And what should we say about F2? F1 is emmetropic. And what should we say about F2? F2 is in front, so I am going to say that F2 is myopic. So F1 is emmetropic and F2 is myopic. So here one axis is emmetropic and the other axis is myopic. So this is called as SMA, simple myopic astigmatism. So this is called as SMA or simple myopic astigmatism. SMA, that is simple myopic astigmatism. ठीक है. अब इसका काउंटर पार्ट है ये. लुक एट दिस वन. हियर वी हैव द पैरेलल रेज ऑफ लाइट. आफ्टर रिफ्रैक्शन दे आर मीटिंग एट 2 points, F1 and F2, and this is what it looks like. Here your F1 is on the retina, so F1 is again normal, but what do we say about F2? F1 is emmetropic or normal, but what should we say about F2? F2 is behind, correct. So F2 is hypermetropic. So what should we call this? This is obviously called as simple hypermetropic astigmatism, correct, SHA. So this is simple hypermetropic astigmatism. So exam ke liye, what is the thing in all this stress, when you seem that when you start feeling that you have forgotten even the basic things, just remember the crux of simple astigmatism is that out of the two axes, one has to be normal. You can have only one defective axis in simple astigmatism. So if the defective axis is myopic, you call it as SMA, and if the defective axis is hypermetropic, you call it as SHA. ठीक है. इतना एग्जाम में याद रखो that simple astigmatism में one axis has to be normal. Next, now if you look at these images, now here both the axes are defective. None of the axes are normal. So let's look at this one. Here see, if I name this as F1 and this as F2, what can we say about F1 and F2? Here your F1 and F2 are both myopic. Right, here your F1 and F2 are both myopic, but they are not equally myopic. Your F1 is more myopic than F2. So this here, both axes are defective. This is called as CMA, compound myopic astigmatism. Here both axes are defective and both are myopic, but one axis is more myopic than the other. This is CMA, compound myopic astigmatism. Now the counterpart of it is the next picture. The next picture में देखो, this is F1 and F2. So here what can I say about F1 and F2? Here F1 and F2 are both hypermetropic. They are both hypermetropic because they are both behind the retina, but again they are not equally hypermetropic. F1 is more hypermetropic than F2. They are both hypermetropic, but they are not equally hypermetropic. F1 is more hypermetropic than F2. This is called as CHA, compound hypermetropic astigmatism. And the last one is this. Here see, this is F1 and this is F2. So F1 here is myopic because it is in front of the retina, and F2 is hypermetropic because it is behind the retina. So one axis is myopic and the other axis is hypermetropic. What do we call this? Where both are defective but one is myopic and the other is hypermetropic. This is called as mixed astigmatism or MA. So this is called as mixed astigmatism or MA. याद आ गए these pictures? So simple Only myopia, hypermetropia, and the 5 types of astigmatism: SMA, SHA, CMA, CHA, and MA. Right? Now, once we have done the pictures, now what we need to do under refraction, where we get questions wrong, is we have to do about the glass prescriptions. So let us just quickly run through the questions on glass prescriptions. Chalo, let me quickly run you through glass prescriptions. I will not go into the theory, because the theory all of you have read, you have forgotten, you have read it again and probably forgotten it again. Now let us concentrate on how to answer the question in the exam, and we are only going to think of that. So whenever you get a question on glass prescriptions, this will help you to solve most of them, barring maybe 1 or 2 if you get very difficult questions, but otherwise this will work for most questions. So whenever you get a question on glass prescriptions, first in your mind triage it into whether it is in minus or it is in plus. पहले अपने दिमाग में सोचो कि whether I have a prescription in minus or I have a prescription in plus. ठीक है? So if I have a prescription in minus, what are the possible options? And if I have a prescription in plus, what are my possible options? So if it is a minus prescription and if it is a plus prescription, what are the possible options? Now always remember M for M. Minus means myopia or myopic astigmatism. So minus means M for M, myopia or myopic astigmatism. So plus obviously means hypermetropia or hypermetropic astigmatism. Now see, in minus there are 3 possibilities of prescriptions. Either you will have a prescription where there is only a sphere, or you will have a prescription where there is only a cylinder, और there is a prescription जिसमें both sphere भी है and cylinder भी है. Please listen to this carefully. Once you get this, I think you will be able to answer the questions much faster without going into the theory. So minus M for M याद करो. Minus means M for M. Minus means myopia or myopic astigmatism. So minus prescriptions, the first option is, suppose you have a prescription where there is only a sphere. Like for example, let me give you an example. Minus 2 diopter sphere. S means sphere. So if it is only a sphere, this is a myopia or a simple myopia. Now the second option is, if there is a minus prescription which is only a cylinder. So suppose you have a prescription where there is only a minus cylinder, like for example say minus 1 diopter cylinder cross 90 or 180, doesn't matter. A minus cylinder will always have an axis. So either it will be 90 or 180. So minus 1 cylinder cross 90. This is a prescription of SMA, simple myopic astigmatism. And the third option is when you have a prescription which has both a sphere and a cylinder. So suppose we have this prescription where there is both sphere and cylinder. There is a prescription where there is both sphere and cylinder. So देखो, what is this prescription look like? Suppose the prescription looks like this. Minus 1 sphere and say minus 1 cylinder and any axis, say 90 or 180. What is this? There is both a sphere and a cylinder. So this is a prescription of CMA, compound myopic astigmatism. So in minus, first minus means myopia or myopic astigmatism. 3 options हैं, only sphere, only cylinder, both sphere and cylinder. So if it's only sphere, it is simple myopia. Only cylinder, simple myopic astigmatism. Both sphere and cylinder, compound myopic astigmatism. The same thing can be extrapolated to your plus prescription also. So now I will not say, now I want you to say. So chalo, in plus prescription, suppose you have only sphere. In a plus prescription, only sphere. Say for example, if I say plus 3 diopter sphere, what is the refractive error? If it is plus 3 diopter sphere, what is this? Plus and only sphere means? Plus and only sphere means this is simple hypermetropia, correct? So plus and only sphere means simple hypermetropia. Now next is plus and only cylinder. So if you have a prescription like this, that is plus and only cylinder, like for example, say for example, minus 2 diopters, sorry, plus 2 diopter cylinder cross 90. What is this? Plus and only cylinder. Plus and only cylinder means, plus and only cylinder means, correct, it is SHA, simple hypermetropic astigmatism. Plus and only cylinder means SHA. Now, if you have a prescription where there is both plus sphere and plus cylinder, if there is both plus sphere and plus cylinder, meaning suppose the prescription looks like this, say plus 2 diopter sphere and say plus 1 diopter cylinder cross 180. So there is plus sphere plus cylinder, both are there in the prescription. So if the prescription has both sphere and cylinder and they are in plus, then correct. So this is a compound hypermetropic astigmatism. So this is a compound hypermetropic astigmatism. राइट समझ आया. सो बेसिकली वेन एवर यू गेट अ प्रिस्क्रिप्शन, उसको डिवाइड करो इनटू, इन योर माइंड डिवाइड इट इनटू माइनस एंड प्लस. सो देखो प्रिस्क्रिप्शन को प्लस में है माइनस में है. माइनस है तो रिमेंबर एम फॉर एम. माइनस मीन्स मायोपिया और मायोपिक अस्टिग्मेटिज्म. 3 ऑप्शन है, ओनली स्फीयर, ओनली सिलेंडर, बोथ स्फीयर एंड सिलेंडर. ओनली स्फीयर इन माइनस मीन्स मायोपिया, ओनली सिलेंडर मीन्स एसएमए, बोथ स्फीयर सिलेंडर मीन्स सीएमए. For plus, only sphere means simple hypermetropia, only cylinder means SHA, both sphere and cylinder means CHA. ठीक है. अब लास्ट में एक और टाइप का प्रिस्क्रिप्शन बचता है जिसमें देयर इज अ कॉम्बिनेशन ऑफ प्लस एंड माइनस. सो जेनरली प्लस माइनस कॉम्बिनेशन में द प्रिस्क्रिप्शन दैट यू विल गेट विल लुक लाइक दिस. सो यू हैव अ प्रिस्क्रिप्शन लाइक दिस, से -1 sphere and say +3 cylinder cross 90. Or suppose you get +1 sphere, -3 cylinder cross 90. No, CHA does not mean 180. It can be 180 or 90. Please don't confuse this. This axis does not decide whether it is CHA or it is CMA or it is SHA. Nothing. You have to write an axis, so I wrote 180. I can write 90 also. That is not why it is CHA. It is CHA because there is a plus sphere and there is a plus cylinder. It doesn't matter where that cylinder is. राइट वो 90 180 से डिसाइड नहीं हो रहा है. वो CHA इसलिए है बिकॉज इसमें प्लस स्फीयर भी है और प्लस सिलेंडर भी है. दैट्स व्हाई इट इज CHA, नॉट बिकॉज ऑफ द एक्सिस. द एक्सिस डज नॉट डिसाइड वेदर इट इज CHA और SHA और CMA एनीथिंग. अब देखो, सो व्हेन यू गेट अ प्रिस्क्रिप्शन वेयर देयर इज अ कॉम्बिनेशन ऑफ प्लस एंड माइनस, इट विल लुक समथिंग लाइक दिस. दैट इज द स्फीयर एंड द सिलेंडर आर ऑफ ऑपोजिट साइंस. The sphere and the cylinder are of opposite signs, and you will see that the absolute value of the cylinder is greater than the sphere. Absolute value matlab if you remove the sign, the cylinder is greater than the sphere. So the absolute value of the cylinder is greater than the sphere. Matlab 3 jo hai, it is bigger than 1. So this kind of a prescription, this is a prescription of mixed astigmatism. So you will get a prescription where there will be the sphere and the cylinder will be of opposite signs, meaning it will either be a minus sphere and a plus cylinder or a plus sphere with minus cylinder, and the cylinder will be, the absolute value of the cylinder is greater than the sphere. So this is mixed astigmatism. Right. Now I will come to the last part of the prescription, which actually decides which is influenced, I should say, by 90 180, and that is with the rule and against the rule. So अभी तक मुझे बताओ कि यहाँ तक सबको क्लियर है ना? You will be able to answer the question now. You will be able to answer the question now. Yes, na? Now, yes, Pankaj, I am going to come to that with the rule and against the rule. Again, I am not going into the theory. वो theory तुम पढ़ भी चुके हो, भूल भी चुके हो. फिर से पढ़ोगे, फिर से भी वो भूल जाएगा. So, exam के पहले, if you have forgotten, just remember this much. This will help you to answer the questions, most of the questions. So, see, we have with the rule and against the rule, right? With the rule essentially means that the vertical axis is more curved or myopic. That is what is with the rule. But generally in the exam, what they do is they give us a glass prescription and they ask whether it is with the rule or against the rule. So now, the easy method of doing this question is just by heart this, that with the rule means that either you will have a minus cylinder cross 180 or you will have a plus cylinder cross 90. Okay, so minus cylinder cross 180 and plus cylinder cross 90. If this is there in the prescription, it is with the rule. Opposite jo hai, it is against the rule. Okay, so suppose if it is not matching with this, it is against the rule. So suppose you have this minus 1 sphere and say minus 1 cylinder cross 180. Now see, first of all, we have to say whether it is SMA, SHA, CMA, CHA or MA. तो मुझे पहले बताओ, what is it? SMA, SHA, CMA, CHA, MA. What is it? SMA, SHA, CMA, CHA, MA. इसमें से कौन सा है ये? It is CMA because see, there is a minus sphere and there is also a minus cylinder, right? So there is a minus sphere as well as a minus cylinder. So this is CMA, compound myopic astigmatism. Minus में है both sphere and cylinder, so it is CMA. So minus में है both sphere and cylinder. Now look at this part of the prescription, the cylinder part of the prescription. See, minus cylinder cross 180 मतलब ये है with the rule. Minus cylinder cross 180 meaning it is with the rule. It is with the rule. Minus cylinder cross 180 matlab ye hai with the rule. Now let me give you another example. Suppose we have this example in the exam. Say for example minus 1 sphere and say plus 3 cylinder cross 180. What is this? SMA, SHA, CMA, CHA, MA. What is this? It is obviously mixed astigmatism, MA hai, right? And now look at the cylinder part of the prescription, plus cylinder cross 180. Plus cylinder cross 180 matlab it is not matching with this rule that we have learnt, right? We have not, this is the rule that we by hearted, that with WTR means minus cross 180 or plus cylinder cross 90. Minus cylinder 180 or plus cylinder 90. So here see, it is not matching with this. That means this is against the rule. This is against the rule. समझ आया ना सबको? So this much about glass prescription. So see, in glass prescription, first thing is we divide it into minus and plus. Then if they ask, we may have to follow this also. That is what is with the rule. Just by heart this. Minus cylinder 180 or plus cylinder 90 is with the rule. Opposite is against the rule. Now please give me a thumbs up if this part is clear. Shall we move to the next part? Okay. Okay, now we'll go to another topic that is about the extraocular muscles. Extraocular muscles and the nerve palsies. Extraocular muscles and nerve palsies. So quickly we just have to go through the functions of the muscles. First of all, tell me which are the elevator muscles of the eye. Which are the elevators of the eye? Which elevation? This is a function of elevation is done by which are the elevators? The elevators are superior rectus and inferior oblique. SR and IO. Now depression. Depression, which are the depressors of the eye? Depressors are IR and SO. Depressors are IR and SO. Next, which are the intortors of the eye? Intorsion. Intorsion primarily is a function of the oblique muscles, and intortors are remembered as sin. Sin means superiors are intortors. So intorsion is a function of SO and SR. SO and SR, these are the intortors. SO and SR. We put SO first because torsion is primarily a function of the oblique muscles. So similarly, which are our extorters? Extorsion, this is a function of IO and IR. IO and IR. Next, the last, adduction and abduction. Adduction, this is the main adductor is obviously the medial rectus, and it is assisted by superior rectus and inferior rectus. So MR, SR, IR, these are our adductors. The adductors are, MR is the main adductor, it is assisted by SR and IR. And which are our abductors? Abduction, the main abductor is obviously lateral rectus, but it is assisted by superior oblique and inferior oblique. So LR, SO and IO, these are our abductors. LR, SO and IO, these are our abductors. So this is the function of our extraocular muscles. Right, now here what we need to read basically is are the three nerve palsies. So we will first start with third cranial nerve palsy. Let us start with third cranial nerve palsy. In third cranial nerve palsy, why is third cranial nerve palsy a little complicated as compared to the other nerve palsies? That is because it supplies multiple muscles. Okay, so because it supplies multiple muscles, that's why it becomes a little complicated. So let us look at this image first. Let's revise it, then we'll look at the image. So let us look at third cranial nerve. What is the lid muscle that it supplies? Which is the lid muscle that it supplies? It supplies the LPS. Now, because the LPS is affected, there is a severe ptosis, which you can see in the image. The more it presents with severe ptosis, you can see in the image that there is a finger which is pulling up the lid. It supplies two intraocular muscles. The two intraocular muscles are ciliary muscle and there is sphincter pupillae muscle. That is ciliary muscle and there is sphincter pupillae muscle. Now, because the ciliary muscle is affected, that is why there is loss of accommodation. Because the ciliary muscle is affected, there is loss of accommodation. And because the sphincter pupillae is affected, what do we get to see? Because the sphincter pupillae is affected, you get a dilated and fixed pupil. We get a dilated and fixed pupil. Now comes the extraocular muscles. So which are the extraocular muscles that are affected in third nerve palsy? Actually, all the extraocular muscles are affected except the SO and the LR. All the extraocular muscles are affected except the SO and the LR. Now, see, the SO is a depressor and the LR is an abductor, and these two are still working. So, the SO is a depressor, the LR is an abductor. So, the SO pulls the eye down and the LR pulls the eye out. That is why, what is the position of the eye here, which you can also see in the image? The eyeball is deviated in which direction? Eyeball deviated in which direction? What is the deviation of the eyeball? Eyeball is deviated downwards and outwards. Correct. That's what we see in the picture. So eyeball is deviated downward and outward. So the LPS is affected, that's why there is a severe ptosis, there is loss of accommodation, pupil is dilated and fixed, and all the extraocular muscles are affected except the SO and the LR. So the eyeball is deviated downwards and outwards. Next question that they ask is, what is the most common cause of third nerve palsy? What is the most common cause of third nerve palsy in adults, and what is the most common cause in children? In adults, the most common cause is microvascular infarct. In adults, the most common cause is microvascular infarct, and in children, the most common cause is trauma. Most common cause in adults is microvascular infarct, and most common cause in children is trauma. And what is the special feature of third nerve palsy caused by microvascular trauma? If it is caused by microvascular trauma, it may be pupil sparing. It may be pupil sparing, that is, it may not involve the sphincter pupillae muscle. Again, very important for MCQ. So, most common cause in adults is microvascular infarct, and if it is a microvascular infarct in the early stages, it may end up being pupil sparing. Okay, so these are the must know points about third cranial nerve palsy under paralytic squint. On the same lines, let me go to the next one, that is your fourth cranial nerve palsy. In fourth cranial nerve palsy, the affected muscle is SO, that is superior oblique. Superior oblique is the affected muscle, and the main functions of superior oblique are intorsion and depression. So the affected movements in fourth nerve palsy are intorsion and depression. So because the intorsion and depression are affected, so see, this is the eye. The intorsion and the depression are affected. So if the intorsion is affected, the eye will be extorted, and if the depression is affected, the eye will move up. That's called as hypertropia. So therefore, see, in SO palsy, there is extorsion and there is hypertropia. And because of this deviation or squint that you have, there is a diplopia. What kind of diplopia? The diplopia is a vertical diplopia. Diplopia is vertical because this muscle is mainly moving the eye like this. It's a vertical muscle. So that's why there is a vertical diplopia, meaning the two images are one on top of the other. So there is a vertical diplopia which is maximum in down gaze. Why it is maximum in down gaze? Because the SO is a depressor. So when you try to depress, you will not be able to depress and you will end up with diplopia. So diplopia is maximum in down gaze. Now please listen to me carefully. What are the activities that will be impacted in SO palsy? The activities impacted are those which we do in down gaze. Like for example, reading, writing and climbing down the stairs. So in the question, generally it will mention that patient suffers from jumbling of letters while reading and writing, or the question will mention that the patient experiences difficulty while climbing down the stairs. So there is a diplopia which is maximum in down gaze. So the activities impacted are reading, writing and climbing down the stairs. Now the main problem with SO palsy is actually the extorsion. Why? Because the primary function of SO is your intorsion. So because the intorsion is affected, the eye is extorted and this gives rise to tilting. Everything appears to be tilted and that is very disturbing. So to compensate this, what will the patient do? So see, this eye is already extorted. If he tilts the head like this, the extorsion will increase. So what he will do is he will tilt the head to the other side. So when he tilts the head to the other side, the extortion, it gets to a certain extent corrected. So the head posture is a head tilt to the opposite side to overcome the extortion. So these are the salient must know points about fourth nerve palsy. So let me just quickly go over it. In fourth nerve palsy, the muscle that is affected is SO, whose main functions are intorsion and depression. Now because intorsion and depression is affected, that's why the eyeball is extorted and it is elevated, or there is hypertropia. Because of this squint, there is a vertical diplopia that is maximum in down gaze, so that the activities affected are reading, writing and climbing down the stairs. To overcome or correct this extortion, the patient develops a compensatory head posture of tilting the head to the opposite side. Okay, so we learned third nerve palsy, we learned fourth nerve palsy. Now the last one is sixth nerve palsy. Now, sixth nerve palsy is actually much simpler than all this. Now, sixth nerve palsy, the muscle affected is lateral rectus, whose main function is abduction. So the muscle affected is LR, whose function is abduction. So if the abduction is weak, then obviously the eye is going to be pulled inwards. So there is going to be a convergent squint, that is esotropia. There is a convergent squint or esotropia. Now because of this esotropia, there is obviously going to be a diplopia, and this diplopia is a horizontal diplopia. Horizontal diplopia because this muscle is moving the eye horizontally. So the two images will also be side by side. So it's a horizontal diplopia. Now this diplopia is maximum on lateral gaze to the affected side. So which means that if there is an LR palsy on this side, the maximum diplopia is when the patient tries to look to this side. Why? Because when he tries to look to this side, he will have to abduct the eye, and he's not being able to abduct, so there is maximum diplopia on the affected side. So now what the patient will do, because he is having diplopia on this side, instead of looking to this side, he will turn the face to this side. So the compensatory head posture is a face turn. Face turn to which side? Again to the affected side only. So this is sixth nerve palsy. So in sixth nerve palsy, the affected muscle is LR, whose function is abduction. Because the abduction is weak, there is a convergent squint or esotropia. Because of the esotropia, there is a horizontal diplopia. This diplopia is maximum on lateral gaze to the affected side, so that the patient develops a face turn to the affected side. Okay, so this is sixth cranial nerve palsy. You can understand from this image, you will see that there is ESO here. There is esotropia in this image in primary position, and here see this is this gaze. Here this eye is not moving. Why? There is loss of abduction. Loss of abduction. So this is about the three types of cranial nerve palsies or paralytic squints that you have to know. Clear hai na? Shall we quickly move to the next one? Yes? Yes na everybody? Chale aage? Chalo, let's go to the next topic. Chalo, the next topic again is another important topic for the exam is Horner syndrome. Horner syndrome. Now, Horner syndrome is called as oculosympathetic palsy. The other name for Horner syndrome is oculosympathetic palsy. Oculosympathetic palsy. So it is a paralysis of the sympathetic nerve supply to the eye. And what are the structures that are affected here in Horner syndrome? In Horner syndrome, the structures which are affected, number one is the Muller's muscle or the tarsal muscle of the lid. The Muller's muscle or the tarsal muscle of the lid. The Muller's muscle or the tarsal muscle. So because this is affected, what will you have? The Muller's muscle is essentially an elevator, but it is not your main elevator. The main elevator is LPS, but this is like helping the LPS in the process of elevation. So here you will have a ptosis, but it is going to be a mild ptosis. Here we will have a ptosis, but it's going to be obviously a mild ptosis. And because of the mild ptosis, you will also get an impression that the eyeball is sunken. The eyeball is not actually sunken, it just looks like that. So this is called as mild ptosis and apparent enophthalmos. Mild ptosis and apparent enophthalmos. So Horner syndrome is the paralysis of the sympathetic nerve supply to the eye. Muller's muscle and or the tarsal muscle is affected, which is the helping muscle for elevation. So you have mild ptosis with apparent enophthalmos. Next, what is affected? The dilator pupillae muscle is affected. The dilator pupillae muscle is affected. So what will you have? You will have meiosis. That is, you will have a constricted pupil. You will have meiosis or you will have a constricted pupil. And the third what is affected is your sweat gland. And if the sweat gland is affected, we are going to have anhydrosis. If this is affected, we are going to have anhydrosis. So this is our Horner syndrome. This is our Horner syndrome. So anywhere that the sympathetic nerve supply is affected, you end up with this. It can also come as an IBQ or an image-based question. So the two features that are generally apparent here are, obviously you can see that there is a mild ptosis, and if you compare the size of the pupil, in the affected eye, the size of the pupil is smaller, which is suggestive of meiosis, that is constricted pupil. So mild ptosis and apparent in ophthalmos, meiosis and anhydrosis. This is Horner syndrome. So with this, we finish the different palsies. Challing quickly to the next one. The next very important topic that I want to discuss is the visual pathway. Now visual pathway ऐसा है, you all know it, but at the same time there are some common mistakes that we make here, and that is what I am going to discuss. So quickly, what are the structures in our visual pathway? We all know that the structures in the visual pathway are, we have the optic nerve. I will not write it. So this is the optic nerve. We have one on either side. Next we have the optic chiasma, then the optic tract. Then here the LGB, the lateral geniculate body. Then we have the optic radiation. And at last we have the visual cortex, which is called as your occipital cortex. The visual cortex or the occipital cortex. So the optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation and occipital cortex. Now quickly, we will just go over what do we have if there is a lesion in the optic nerve. That is lesion number 1. Lesion in the optic nerve. If we have a lesion in the optic nerve, what we end up with? We end up with monocular blindness. Lesion in the optic nerve, we have monocular blindness. Next, lesion in the optic chiasma. Tell me, for lesion in the optic chiasma, what do we have? Lesion in the optic chiasma. Lesion in the optic chiasma. What is the defect? The defect is bitemporal hemianopia. Bitemporal hemianopia. Now please remember, bitemporal hemianopia means what? The other name for bitemporal hemianopia is heteronymous hemianopia. Bitemporal hemianopia or heteronymous hemianopia. Bitemporal hemianopia, also called as heteronymous hemianopia. Right. Now if there is a lesion in the optic tract, what do we get? Lesion in the optic tract, it is homonymous hemianopia. Now quickly, I'll just draw a simple schematic picture. How do we draw bitemporal hemianopia? See, it will always be like this, right and left. Now, the place where you go wrong or you make mistakes is that when you draw a picture of this kind of a picture, that's a picture of the visual pathway, or you get a perimetry picture, the right and left is according to your own right hand and left hand. Please listen to this carefully. It's not like a clinical picture, mind you. In a clinical picture, like if I take this clinical picture, now this is right and this is left. Correct? So this is right and this is left. But here, this is right and this is left. The right and left in a visual pathway diagram is according to your own right hand and left hand. So where you have your right hand, that is right. Where you have your left hand, that is left. इसको याद रखो और इसको गड़बड़ मत करना. So we draw it like this. There are two circles. This is right, this is left. Then each circle is divided into two halves. Inner half is nasal, outer is temporal. So bitemporal hemianopia means that the temporal field of both eyes will be lost. So I am blacking out the temporal of both eyes. Now, what is homonymous hemianopia? Homonymous hemianopia means that the nasal field of one eye and the temporal field of the other eye will be affected. So, see, I am blacking out the nasal field of this eye and I am blacking out the temporal field of this eye. So, nasal of one eye and the temporal of the other eye are called this. When this is affected, you call it as homonymous hemianopia. Right, now comes the optic radiation, but this optic radiation is actually divided into two parts. See, you can see the two splits of the optic radiation. So what are the two parts of the optic radiation? We have a Mayer's loop and we have a Baum's loop. So this Mayer's loop, which passes through the temporal lobe, the Mayer's loop, it passes through the temporal lobe. If this is affected, we are going to get what is called as pie in the sky. It is called as pie in the sky. It is called as pie in the sky. Now, what is pie in the sky? Pie in the sky means that there is a homonymous hemianopia, but it is only superior. So, homonymous hemianopia, which is only superior, is called as pie in the sky. Now, the other loop of the optic radiation is your Baum's loop, and the Baum's loop passes through the parietal lobe. The Baum's loop passes through the parietal lobe. So, if there is a lesion in the Baum's loop or the parietal lobe, you get a defect which is called as pie on the floor. Now, what is pie on the floor? Pie on the floor is a homonymous hemianopia which is only inferior. So, it's like an inferior homonymous hemianopia. It's a homonymous hemianopia which is only inferior. So, quickly, for a lesion in the optic tract, it is homonymous hemianopia. For optic radiation, you can either have a lesion in the Mayer's loop or temporal lobe, which will give you pie in the sky, or Baum's loop, which is in the parietal lobe, giving rise to pie on the floor. And the last is if there is a lesion in the occipital cortex. If there is a lesion in the occipital cortex, you are going to get a homonymous hemianopia with central or macular sparing. We get a homonymous hemianopia with central or macular sparing. With central or macular sparing. Right? And this is because of infarct in the territory of which artery? Homonymous hemianopia with central or macular sparing is because of infarct in the territory of which artery? So it looks something like this. A homonymous hemianopia where the central part is clear. And this is because of lesion in the territory of which artery? This is because of infarct in the territory of which artery? PCA. So it is the result of PCA infarct. It is the result of PCA infarct. अब ये जो है, this I am sure that all of you know. It is just that you have to make sure that you don't get this question wrong. And the main, yes, the sparing of the middle cerebral artery leads to macular sparing. So this homonymous hemianopia with central or macular sparing is because of lesion in the territory of PCA, that is posterior cerebral artery, and the central sparing is because of the sparing of the middle cerebral artery. Now quickly I am going to look at these images. Now the main mistake that students make here is from right and left. Nothing else. और कुछ यहाँ पे गलत नहीं होता है. So if you look at this picture, this is right, this is left, and see the temporal fields of both eyes are affected. The temporal fields of both eyes are affected. So obviously the site of the lesion is the optic chiasma. Now there is no problem with the optic chiasma because there is no right or left to it. It's a midline structure. The problem arises when you have to, say whether it is right or left. So देखो, this is right and this is left, right? So the nasal field of this eye and the temporal field of this eye are affected. So you know it's a homonymous hemianopia. Now see, should we call this as right homonymous or left homonymous? That is the question. Now See here, the nasal field of the left eye and the temporal field of the right eye are affected, right? The nasal field of the left eye and the temporal field of the right eye are affected. So, the blackening is on your right hand side. See the nasal field of the left eye and the temporal field of the right eye. They are both on your right hand side. So, this will be called as right homonymous hemianopia. And right homonymous hemianopia means the site of the lesion is the left optic tract. So the site of the lesion is the left optic tract. Once more, see the blackening is on your right hand side, so it's a right homonymous hemianopia. Site of lesion is the left optic tract. Now what is this? Obviously it's a superior homonymous hemianopia, meaning it's pie in the sky. Once again, see the blackening is on the right side, so it's a right-sided pie in the sky, meaning the site of the lesion is the left-sided Meyers's loop or the left-sided temporal lobe. So the site of the lesion is the left temporal lobe. This picture again, see, it is an inferior homonymous hemianopia, so it is pie on the floor. Again, the blackening is on the right hand side, so it's a right-sided pie on the floor. Right-sided pie on the floor means the site of the lesion is the left parietal lobe. The site of the lesion is the left parietal lobe. Sorry. This is the problem if you're poor with gadgets. Just 1 minute, huh? So see, it's a pie on the floor which is of the right side. So once again, see the site of the lesion is going to be the left parietal lobe. The site of the lesion is the left parietal lobe. And the last one again, this is right-sided homonymous hemianopia with macular sparing. Again, the blackening is on your right hand side, so that's why the site of the lesion is the left occipital lobe. It is the left occipital lobe or the left-sided visual cortex, and it is an infarct in the territory of the posterior cerebral artery. I hope ये right or left अभी गलत नहीं होगा किसी का. This is the only thing that goes wrong. Baki sab people generally get it right only. The problem is with the right and left. I hope you will not get it wrong. Shall I move to the next topic? Chalo. The next topic that we need to quickly go through is the pupillary reflexes, the light reflex and the near reflex pathways and their defects. The light reflex and the near reflex pathways and their defects. So see, this is the pathway for the light reflex. So what is exactly light reflex? Light reflex obviously means that when you put light in one eye, the pupil constricts in both eyes, which means that if I put light here, this pupil will constrict. This is called as direct reflex. But when you put light in this eye, this pupil will also constrict, and this is called as your indirect reflex. Okay, so the light reflex has two components, the direct reflex and the indirect reflex. Now, what are the parts of the light reflex? Or what should I say, what is the afferent? The afferent is this, the optic nerve, the optic chiasma and the optic tract. So, the afferent for the light reflex is the optic nerve, the optic chiasma and the optic tract. What is the center? The center is this structure, this that you have here. This structure is called as the pretectal nucleus. Where is the pretectal nucleus located? The pretectal nucleus is located in the dorsal part of the midbrain. So the pretectal nucleus in the dorsal midbrain, that is your center. Now please, the third part, please listen to it carefully when we revise it. What is the efferent? The efferent actually starts from this structure, this blue one that you see here. This is your EW nucleus or the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the third nerve. Now from the EW nucleus, the nerve that is coming out is obviously the third nerve. Now the third nerve relays in this ganglion here. This ganglion, this is called as your ciliary ganglion. This ganglion is called as the ciliary ganglion. And beyond the ciliary ganglion, you can see these set of nerves here. These set of nerves that you have, they are called as your short ciliary nerves. They are called as the short ciliary nerves. So see, this is the pathway for your light reflex. These are the short ciliary nerves. And what kind of reflex is this? This is a parasympathetic reflex, because see, the EW nucleus is the parasympathetic nucleus of the third nerve. So this is a parasympathetic reflex. So the afferent is, as you can make out, optic nerve, chiasma and tract. The center is the pretectal nucleus in the dorsal midbrain. And the efferent starts from, yes, of course, the center is connected to the efferent by the internuncial neurons. That's correct. So the center is connected to the efferent by the internuncial neurons. The efferent is the EW nucleus. From there comes out the third nerve. The third nerve relays in the ciliary ganglion, and then we have the short ciliary nerves. So this is our light reflex. Now on the same lines, we will also learn the near reflex, and then we will go to the defects. Now the near reflex actually has three components. The three components of the near reflex are accommodation. When you look at a near object, you accommodate. So there is accommodation. Accommodations is always accompanied by convergence of the eyeballs and meiosis. Convergence and meiosis, and these changes are bilateral. So near reflex consists of accommodation, convergence and meiosis. Now, the afferent is not clear. Afferent of this is not very clear. Not clear. So, we do not have to know about the afferent. So, what we know is the center and the efferent. The center doesn't have a name, but it is located in the ventral midbrain, in contrast to the pretectal nucleus, which is located where? In the dorsal midbrain. The center is located in the ventral midbrain. And what is the efferent? The efferent is essentially the same only. So the efferent is essentially the same, that is the EW nucleus, the third nerve. Then we have the ciliary ganglion and the short ciliary nerves. The ciliary ganglion and the short ciliary nerves. So, the afferent is not known. The center, it is in the ventral midbrain, and the efferent is the same. Yaad aaya ye sabko? Has everybody been able to recapitulate this? So, let us, if it's a yes, I'll go on to the defects of the pupillary pathway quickly. Yes, so what are the defects of the pupillary pathway? The defects are, the first one is called as RAPD, relative afferent pupillary defect. The other name for which is Marcus gun pupil, and this is seen when you have a lesion in the optic nerve. When you have a lesion in the optic nerve. And it is tested clinically by the swinging flashlight test. So have a look at this image. It comes as IBQ. What is the swinging flashlight test? See, in the swinging flashlight test, this picture shows you the baseline. Now first, you swinging flashlight test means you first put light in the good eye and then swing it immediately to the bad eye. So when I put light in the good eye, see, both eye pupils constrict, because this is the normal response. Both eye pupils constrict, which is the normal response. But when I move the light quickly from the normal eye to the affected eye, then you see both eye pupils dilate. Both eye pupils dilate. So this is a paradoxical dilatation, because you don't expect the pupil to dilate in response to light. So it's a paradoxical dilatation. So once more, in case of RAPD, what do you see? It is tested clinically by the swinging flashlight test. When you put light in the good eye, both eye pupils constrict, and immediately when you move the light from the good eye to the bad eye, then both eye pupils will show a paradoxical dilatation. So this is right eye RAPD, which means that the site of the lesion is the right-sided optic nerve. So this is relative afferent pupillary defect or Marcus gun pupil. Next, if there is a lesion in the optic tract, we have a defect called as Wernicke's hemianopic pupil, but this is a theoretical concept. We are not able to elicit it practically. The third one is called as light near dissociation. Light near dissociation typically means that the light reflex is absent, but the near reflex is present. So light near dissociation, one is absent, but the other is present. Light reflex is absent, but the near reflex is present. Why is the light reflex absent? Because here the site of the lesion is in the pretectal nucleus, which is the center for the light reflex. But if you remember, the center for the near reflex is in the ventral midbrain, so it is unaffected. So the site of the lesion is the pretectal nucleus. And the typical example is Argyll-Robertson pupil, which is seen in neurosyphilis. So light near dissociation. The last one, Adie's tonic pupil. Now this is caused by a denervation of the postganglionic supply, meaning the short ciliary nerves. So the short ciliary nerves are the final common pathway for both the light reflex and the near reflex. So that's why both of them are affected, and so the pupil on the affected side is large. So you have a large dilated pupil on the affected side. As a result, there is a difference in pupillary size between the two eyes. So the two eyes, the size of the pupil is not the same. One side is large and the other side is small. So this difference in pupillary size, this is called as anisocoria. So anisocoria again is a one-liner. What is anisocoria? Anisocoria means difference in pupillary size. And where do we get to see Adie's tonic pupil? Adie's tonic pupil is typically seen after unrelated viral infections in female patients. They are unilateral. So in that particular side, the light and the near reflexes both are affected to a certain extent, and so the pupil is large and dilated, giving rise to anisocoria or a difference in pupillary size. Okay, so these are the defects of the pupillary pathway. So Marcus gun pupil, Wernicke's hemianopic pupil, Argyll-Robertson pupil, and Adie's tonic pupil. याद आया सबको? Everybody is able to recall it now? Chalo. Now I'll quickly go to a couple of really important topics from retina. So let's come to this one. Something which is like, something which you have to know like the back of your hand. Central retinal artery occlusion, or CRAO. Now quickly, the central retinal artery, it supplies the inner 6 layers of the retina. The central retinal artery, which is a branch of the internal carotid artery, it supplies the inner 6 layers of the retina. How does the patient present in case of a CRAO? The patient presents with a sudden, painless and extreme loss of vision. The patient presents with a sudden, painless and severe loss of vision. On examination, the visual acuity is very, very poor. The visual acuity is very, very poor. That is, it is like counting fingers at a few meters. The pupil shows RAPD, but the anterior segment is normal. And the sign that you see in the retina is this. This is typically what we call as the cherry red spot. Cherry red spot, right? Why? Because the whole retina appears edematous and pale. The posterior pole appears to be edematous and pale. Pale and edematous and hazy, I should say. Pale, edematous and hazy, whereas the fovea, it appears to be bright. So this is CRAO, central retinal artery occlusion. Okay, so sudden, painless, and severe loss of vision. Visual acuity is extremely poor. Pupil shows Marcus-Gunn pupil or RAPD. Anterior segment is normal. So the signs are there only in the posterior segment, and there we get to see a cherry red spot. Now, CRAO is one of the few ocular emergencies. Why? Because if it is not treated within the initial few hours of onset, that is why there will be the eye will be lost, the patient will become blind in that eye. So that's why it's an ocular emergency. It has to be treated within the initial few hours of onset, but unfortunately the treatment that is available is not very well directed. The treatment is based on the idea that if you suddenly lower the intraocular pressure, there will be a jerk, and the jerk may help to dislodge the thrombus. So the different methods are: number one is ocular massage. So vigorous ocular massage. When you do a vigorous ocular massage, the aqueous humor flows out and there is a sudden fall of IOP. Intravenous mannitol, again the same thing, rapid fall of IOP. Paracentesis means aspiration of aqueous. That also gives the same thing. So all this, they are based on the theory that sudden lowering of IOP creates a jerk effect. Sudden lowering of IOP creates a jerk effect that may dislodge the thrombus. The other method is carbogen inhalation. Why do we give inhalation of carbogen? Because carbogen is believed to be a vasodilator. Carbogen is a vasodilator, so that's why it is given. But despite all this, because one, it is an ocular emergency and patient may not come within the initial small period of time, and also because the treatment available is not very well directed, that is why the prognosis of CRAO is very poor. So please level mention here CRAO, the prognosis is very poor. CRAO, the prognosis is very poor. So please remember this. This is one of the options usually in the question. So that prognosis is good. Prognosis of CRVO is generally much better. But for central retinal artery occlusion, the prognosis is generally quite bad because one, as I said, the patient doesn't come immediately, and second, the treatment that's available is not very well directed. So sudden painless loss of vision, which is severe. Finger counting at a few meters is usually the visual acuity. RAPD, anterior segment normal, cherry red spot. It's an ocular emergency. Treatment, ocular massage, mannitol intravenous or paracentesis, and inhalation of carbogen. Prognosis is not very good. On the same lines, let's read the next one. The next one is CRVO, central retinal vein occlusion. CRVO or central retinal vein occlusion. Here also there is a sudden and painless decrease in vision, but it's not as bad as CRAO. The visual acuity is decreased, and once again the pupil may show RAPD and the anterior segment is normal. But what does the posterior segment look like? Here see, the posterior segment is white, it appears pale. Here it appears too red. So there are extensive retinal hemorrhages. So it appears too red, there are extensive retinal hemorrhages, and this is typically what is called as your splashed tomato appearance. So this is typically your splashed tomato appearance. So in CRVO also, there is a sudden and painless loss of vision, but the visual acuity will not be as bad as CRAO. And in the posterior segment, as soon as you see, it will hit you as being too red, too much of hemorrhage. Now let's come to the treatment of CRVO. Now, why did I say that the prognosis of CRVO is actually much better? Because most of the cases are mild. And these mild cases are going to resolve by themselves over 6 months. they are going to resolve spontaneously over 6 months. So for most of the cases of CRVO, the treatment is only a very careful observation, wait and watch. You just see how the patient is behaving and you will gradually see that the patient is getting better. So that's why the prognosis is good, because eventually, even by just careful observation and no active management, the patient is going to get better. The problem is only with the few cases, the few small percentage of cases which are severe cases. Now these severe cases which eventually will develop ischemia, and whenever there is ischemia, there is neovascularization and it has its own complications. So these severe cases are called as ischemic CRVO. The severe cases, they are called as ischemic CRVO. And what is the problem? They are going to give rise to neovascularization and its complications. It gives rise to neovascularization and its complications. So here the treatment for ischemia has to come in, depending on whether there is neovascularization, whether there is macular edema, you have to treat the patient. So the treatment options here will be laser photocoagulation. Depending on what the patient has, you will have to choose between laser photocoagulation and intravitreal injections. So intravitreal injections are anti-VEGFs or steroids. Intravitreal anti-VEGF or steroid injection. So this is the treatment for CRVO. So as I said, a large percentage of cases are non-ischemic or mild and they are going to resolve spontaneously over 6 months. So treatment is only observation. Treatment is actually required for the severe cases which will develop ischemia with neovascularization. So these cases, the treatment options are laser photocoagulation, anti-VEGF or steroid injections. And these severe cases, if left untreated, these severe cases, if untreated, then what will happen? If left untreated, they will progress. They may progress to end-stage neovascular glaucoma. They may progress to end-stage neovascular glaucoma. And this end-stage neovascular glaucoma, it happens after a period of 3 months. That is 100 days. So therefore, this end-stage neovascular glaucoma has a name. It's called as 100-day glaucoma. Again, another important MCQ. So see, these severe cases of your CRVO, if that is the ischemic CRVO, if it is left untreated, it may eventually progress to end stage NVG, that is neovascular glaucoma, and this whole process takes about 3 months of time. So this is called as 100-day glaucoma. So 100-day glaucoma is nothing but end stage neovascular glaucoma in untreated severe or ischemic cases of CRVO. Right? So again, two topics which you need to know very, very well, that is CRAO and CRVO. Chalo. One quick run through of another important topic, that is retinoblastoma. We have like a few more topics to complete. I wanted to keep it as short and high yield as possible, but in spite of that, we are racing against time. You have so much more to do in the next session also. So retinoblastoma, this is the most common intraocular malignancy in children. It is the most common intraocular malignancy in children. It is the most common intraocular malignancy in children. What is the gene responsible for this? The gene responsible for this is the RB gene, and the location of the gene is 13q14. 94%, please remember, they are sporadic. 94% are sporadic and only 6% are actually familial. 6% are familial, and the mode of inheritance is autosomal dominant. 94% is sporadic, 6% is familial, and the mode of inheritance is autosomal dominant. How do these children present? What is the commonest age of presentation? Age of presentation is around 18 months, that is 1.5 years. That is the age of presentation. And what is the presenting feature? The presenting feature is what you see in this image, that is leukocoria or white pupillary reflex. Leukocoria or white pupillary reflex. Next, what would they ask? They ask what is the most common route of spread? What is the most common route of spread? The most common route of spread is direct spread. Direct spread how? Via the optic nerve. Direct spread via the optic nerve. So most common route of spread is direct spread via the optic nerve. Okay, now next is how do you treat retinoblastoma? What is the treatment protocol, or how to answer the questions based on the treatment of retinoblastoma? So see here, you have 3 different types of questions. The first set of questions will be, they will say that it is an intraocular retinoblastoma. Intraocular retinoblastoma means it is confined to the eyeball. So early stage. Now intraocular, they say that they are small masses, meaning occupying less than 50% of the globe, or they will say that they are large masses occupying more than 50% of the globe. Now, if the question says that it occupies more than 50% of the globe, then the treatment is enucleation. Enucleation means removal of the eyeball with a portion of the optic nerve. Enucleation, that is removal of the eyeball with a portion of the optic nerve. But if it is occupying less than 50% of the globe, then you do not remove the globe. You just treat the tumor by focal therapy. Focal therapy can be laser therapy, cryotherapy, or brachytherapy. So remember, if the question says that it is an intraocular retinoblastoma, that it is confined to the eyeball, search in the question whether they are saying it's a large mass or a small mass. So if it says that it is a large mass occupying more than 50% of the globe, mark enucleation as your answer. And if it says it's a small mass, then focal therapy, which can be either laser therapy, cryotherapy, or brachytherapy. Now next is, they will say it's locally advanced. Locally advanced means when you have a retinoblastoma with orbital extension. That is, it has spread through the sclera into the orbit. Now, if it is a retinoblastoma with orbital extension, it is actually inoperable. So, we have to first make it operable by giving a few cycles of chemotherapy. So, first is a few cycles of chemotherapy to shrink the mass. After that, you go for enucleation. Once the mass becomes operable, then you go for enucleation. And then to remove the residual disease in the orbit, we go for orbital radiotherapy. Orbital radiotherapy. So chemotherapy, enucleation, and orbital radiotherapy. This is the treatment for retinoblastoma with orbital extension. Now the third is, they say when you have a retinoblastoma with metastases. When there is retinoblastoma with metastases. So if there is retinoblastoma with metastases, the treatment is only palliative. So it is palliative chemotherapy. So treatment for retinoblastoma with metastases is palliative chemotherapy. Now one more question that they ask from here is that which are the chemotherapy drugs? Which are your chemotherapy drugs used in retinoblastoma? It is remembered as VEC. V stands for vincristine. V stands for vincristine. E stands for etoposide. And C stands for carboplatin. And C stands for carboplatin. Now, when you do, so this is the treatment. So, for intraocular less than 50% focal therapy, intraocular more than 50% enucleation. Retinoblastoma with orbital extension, chemotherapy followed by enucleation, followed by orbital radiotherapy. And retinoblastoma with metastases, only palliative chemotherapy. And the chemotherapy drugs used are vincristine, etoposide, and carboplatin. Now, when you do an enucleation for retinoblastoma, you send it for histopath, and the common histopath picture is this, that you have a lumen with surrounding tumor cells. This is the rosette pattern, and the rosette pattern that is kind of specific for retinoblastoma is this. This is called as your FW rosette or the Flexner-Winter-Steiner rosette. The FW rosette or the Flexner-Winter-Steiner rosette. Okay, so this is about retinoblastoma. One more question that is asked is, what is the most common second malignancy? The most common second malignancy associated with retinoblastoma is osteosarcoma. Most common second malignancy associated here is osteosarcoma. ठीक है, याद आ गया सबको salient points? So these are like the must know things about retinoblastoma. Chalo, quickly let us go through some questions on cataract, because cataract is something which cannot be left ना, उसको तो हम छोड़ ही नहीं सकते. Let us quickly look at few very specific types of cataracts and the must know things about them. Chalo, look at this. Tell me, what is this cataract? What is this cataract? Whitish, yes, it is snowflake cataract. It is typically what is called as snowflake cataract. And snowflake cataract, where do we see it? We see it in diabetes mellitus. Snowflake cataract, which is seen in diabetes mellitus, and it is caused by accumulation of sorbitol. Yes, the excess glucose is converted to sorbitol with the help of the enzyme aldose reductase, and this gives rise to this typical whitish cataract, which is called as your snowflake cataract. Now, what is the next one? What is this cataract called as? What is this cataract called as? It is called as the oil droplet cataract. The oil droplet cataract. Its speciality is that it is a type of a reversible cataract. It is a reversible cataract and it is seen in galactosemia. It is seen in galactosemia. This is typically your oil droplet cataract. Oil droplet cataract is a reversible cataract and it is seen in galactosemia. Galactosemia. Next one. What is this? This is typically, see, it has this a slightly greenish hue. This is your sunflower cataract. This is sunflower cataract and this is seen in Wilson's disease due to the deposition of copper. This is the sunflower cataract. It is seen in Wilson's disease and it is caused by deposition of copper. This one. This is your rosette cataract. This is the rosette cataract which is seen due to blunt trauma. This is the rosette cataract and it is seen in blunt trauma. It is seen in blunt trauma. What is this cataract? This is a shiny opacity, and if I like kind of outline this shiny opacity, it looks something like this. So this is typically our Christmas tree cataract. This is typically Christmas tree cataract, and where do you get to see it? We get to see it in myotonic dystrophy. We get to see it in myotonic dystrophy. Christmas tree cataract, and this is seen in myotonic dystrophy. So these are a few typical varieties of cataract that you have to know: snowflake, oil droplet, sunflower, rosette, and Christmas tree cataract. Chal. Now let us look at a few ophthalmic instruments. Have a look at this instrument. Tell me, what is this instrument? What's the name of this instrument? The first one that you see here, what is this? This is the Goldman applanation tonometer. This is the Goldman applanation tonometer. This is the Goldman applanation tonometer, which is the gold standard tonometer. Which is the gold standard tonometer. right? And its main drawback is that it requires a regular corneal surface. It requires a regular corneal surface. It requires a regular corneal surface. So it is the gold standard tonometer, but it requires a regular corneal surface. So therefore, if you have a patient whose cornea is not smooth or regular, then you use a tonometer which is called as tonopen. This is called as tonopen. So what is tonopen? Tonopen is the tonometer of choice for irregular or scarred cornea. This is the tonometer of choice for irregular or scarred cornea. For irregular or scarred cornea. So Goldmann applanation tonometer is the gold standard tonometer, but its major drawback is that it requires a regular corneal surface. That is why if we have a patient whose cornea is not regular, meaning it is irregular or it is scarred, then we go for an instrument which is called as tonopen. Right, now there is one more tonometer that you need to know, that is called as your rebound tonometer. There is another tonometer which is called as rebound tonometer. Rebound tonometer is a tonometer with which a patient can evaluate his own intraocular pressure. So it's called as the self-use or the home use tonometer. It's called as the self-use or the home use tonometer. So see, the three main questions here are, which is the gold standard tonometer? It is Goldmann applanation tonometer, which is this image. Now, tonopen is the tonometer of choice in case you have an irregular or scarred cornea. And if you want to check, if the patient wants to check his or her own IOP, then we use the rebound tonometer. Okay? Now these two instruments that we have, the last two instruments and the last two images for discussion today. Now what is this instrument? Will you be able to identify this instrument for me? There is a handle. On top of the handle there is a head and there is a dial at the side for focusing the retina. This instrument is called as your direct ophthalmoscope. This instrument is the direct ophthalmoscope. This is the direct ophthalmoscope. And this instrument, what is this? This instrument you have to wear on the head and you have to use an additional lens called as the 20 diopter lens to focus the retina, and this is called as your indirect ophthalmoscope. This is called as the indirect ophthalmoscope. So we have the DO and the IDO, which are the two instruments for focusing the retina. Just 1 minute. Just give me 1 minute to plug in my charger. Okay, so see, direct and indirect ophthalmoscopes. So these two are like common questions in all exams, whether it is NEET or INI-CET. So the direct ophthalmoscope, you hold it in your hand and you focus the retina by rotating the dial. You go close to the patient. In case of indirect ophthalmoscope, you wear the instrument on your head, and in order to focus the retina, you need an additional lens, which is your 20 diopter lens. So now quickly let us go over the differences between DO and IDO. Differences between indirect and direct ophthalmoscope. Now this is like a must know question. Probability of getting something from here is very, very high in an exam. So direct ophthalmoscope and indirect ophthalmoscope. Now direct ophthalmoscope, the first is your magnification. The magnification for DO is around 15 times. Whereas for the IDO, the magnification is much less. It is only 3 to 5 times. Now, obviously, if the magnification is less, that is, if the zoom is less, the area that is covered is going to be much, much larger. So, the area or the field of view, in case of a direct ophthalmoscope, it is much lesser. It is limited to the central retina. it is limited to the central retina, meaning with the direct ophthalmoscope, we mainly focus on the optic disc and macula. We mainly focus on the optic disc and the macula. However, with an indirect ophthalmoscope, because the zoom is less, you have the field of view is up to the retinal periphery. You can see the peripheral retina only with the indirect ophthalmoscope. So the view is up to the retinal periphery. Third is the type of image. In case of direct ophthalmoscope, the image is a virtual image. So it is an erect image. It's a virtual and erect image for DO. Whereas for the IDO, it is a real image. And generally real images are inverted. So it's a real and inverted image. So these are the main differences. For a DO, the magnification is more. That's why the field of view is less and limited to the central retina. The image is virtual and erect. Whereas for the indirect ophthalmoscope, the mag is much lesser, and because the mag or the zoom is less, the view is up to the retinal periphery. The type of image is real and inverted. Now, two specific advantages that we need to remember about the IDO. Two specific advantages that we need to remember about the IDO are, number one is it has a very bright illumination. The illumination is very, very bright, and because the illumination is bright, that is why it is useful if you have hazy media like cataract. So it is useful if the media is hazy, like in case of cataract. And another very important advantage is, so if you look here, the indirect ophthalmoscope is a binocular instrument, meaning the examiner gets to use both eyes, whereas the direct ophthalmoscope is a uniocular instrument. As an examiner, you can use only one eye. So because the indirect ophthalmoscope is a binocular instrument, that is why it gives better perception of depth. It's a binocular instrument, that is why it gives better perception of depth. That is called as stereoscopic view. It gives stereoscopic view, which means better depth perception. Better depth perception. So these are the two advantages of IDO over DO. Okay, so this is what I wanted to discuss in ophthalmology with all of you. I have tried to keep it small, high yield, crisp and short, so that we will be able to cover maximum topics in this period of time. So these are like the must know topics. These are things that you must revise before you go to the exam, because the probability of getting something from these topics is like very high. So I hope this short session has been useful to all of you. Thank you very much. You have been very enthusiastic, and you have participated in the discussion, though I know you have such a lot of stress going on at the back of your minds as to whether the exam is going to be postponed or it is going to be held on the stipulated date. But then, as we keep on saying as teachers, we can only focus on the controllables, bacho. We cannot think about things which are beyond our control. Right? We do not know. We do not know whether it has been postponed. At least I do not know whether any notification has come on the official website. We will get back to you. With whatever notification has come, if it has come, but please do not get disheartened if it eventually does get postponed, because these are things which are beyond our control. इसका हम कुछ नहीं कर सकते हैं. We can only keep preparing and doing our best, and as and when the exam happens, we have to give it our best shot. Thank you very much. Now, very soon we will be starting the next session, which where you will have, we expect it to be another high yield session. And after that, at the end, maybe you will have a little bit of discussion on pathology again. Chalo, bye bye, and thank you very much.
much for joining in. And I think all of you know by now that the NEET PG has been postponed just few years, few minutes before the notification has come, and it's all over Instagram. There are videos also, right? So I don't know what to do, whether to congratulate or not, but personally, I welcome this decision. If you ask my opinion, it should have been postponed. I know it is a very late notification. Ideally, NB should have heed should have taken concerns of students much earlier, and should have postponed this and should have arranged for centers much earlier, because every student was saying that do it in one shift, do it in one shift, why do you want to why do you want two shift. And so we had to had a court judgment ruling, the judgment in student favor. So personally I welcome this decision, because it is better to have a one shift exam than a two shift exam, right? That is definitely better for students. And most likely the exam will be in mid-July or around 20th July. So usual 1 month delay they do. Last time also they did the same thing, that when they cancelled NEET PG one day before the exam, then the next exam was around 23rd July, 1 month after. So same thing will happen this time also. Exam will be around 1 month. Okay, stuck. Indrajit, is it okay now? Is it okay? Okay, I think we are live now. Everything is fine. Yeah. So I was saying that I said a lot of things. I don't know. I said personally that I welcome this decision, because it's better to have a one shift exam than a two shift exam, because that is fair to the students. We want a fair exam rather than an early exam. I think all of us want a fair exam, right? So one shift exam is definitely fair for the students. It gives all students equal chance to get a good marks and good rank, right? So let's see when the new date is announced. My personal opinion is that it will take around a month or so, 15th to 20th July. They'll the new exam will be there. They'll announce the dates around 15th June. So in 2 weeks they should announce the dates. And my guess is the exam will be around 20th July. Last year also, when they postponed NEET PG one day before the exam, the new date was 1 month later, right? So similar thing will happen this time also. Good evening, Subrat. Good evening, Sapna. Hi, thank you for joining in. So first of all, guys, tell me in the chat, because we are running the NEET PG marathon. We want input from you guys. What do you want us to do? So do you want us to continue with this NEET PG marathon till 8th June, or should we conduct some other sort of sessions, and this marathon series should be postpone it to when the new date arrives? So tell me in the comment section, what do you want? Please continue, please continue. It is so helpful. Please continue. ठीक है फिर तो I think the क्या बोलते हैं, the majority is saying to continue the series, so most likely we'll continue the series. Thank you Ishfaq, thank you Sapna, thank you Mr. Cryptic, thank you Cat. Sir, I told you yesterday it is impossible to arrange 1,000 centers in. हाँ हिमांशु, I mean ठीक है, you told, and it was, everybody was thinking on the same line, but as a teacher, how do you motivate students to keep studying, right? You have to say that the exam will be on 15 June, right? So ठीक है, it's good the exam got postponed. It will be a fair exam. Postponement again brings a little laziness, little slackiness in our preparation, but I think we'll get over it. So once the new dates are announced, again we'll get back on preparation. I've just made a video on NEET PG postponement, what should be the plan. I'll discuss that plan towards the end of the class, right? So एक नया schedule दे दो. एक नया schedule तो तभी देंगे ना क्रिप्टिक की, जब डेट आएगी. डेट ही नहीं पता तो schedule किस हिसाब से बनाए. Also give a new revision plan to keep momentum. हाँ, तो revision plan तभी आएगा जब डेट आएगी. What to do now? I've just made a video on my YouTube channel. You can check that out, or we can discuss the new plan after the class, because today is the last. आज की आखिरी क्लास है रेडियोलॉजी, कल नई क्लास स्टार्ट होगी, right? So we'll discuss the new plan towards the end of the class. So shall we start? Okay. So sir, the marathon series are amazing. It will be very helpful in future also. Please keep all the videos at least till the exam. ठीक है, exam तक तो videos रहेंगे ही. At present only we are fitting due to marathon only. Thank you. ठीक है सपना, think the majority is has spoken and they want the marathon series to continue. So we'll continue with the marathon series. Don't worry. Okay, so let's start with the radiology part of NEET PG. And first of all, let's cover some basics of radiology and then we'll move on to systemic radiology. Okay, now, so first, this is a question which came INI-CT very recently regarding CT attenuation. So we all know that the question was that which of the following is true regarding CT attenuation, right? So first question, the CT attenuation is measured using Hounsfield unit. So Godfrey Hounsfield is the father of CT scan. He invented CT scan. So on his name, we have kept the attenuation unit as Hounsfield. Now, what is attenuation? So if this is the object, these are the X-rays which are falling on the object. Now, it can happen two things. The rays can pass through or none of the rays pass through, right? So if all the rays pass through, all rays pass through, then we say that the object is not attenuating. Attenuating matlab obstructing, is not attenuating any rays. So this means it will appear as black. Whereas if no rays pass, then that will appear as very white, bright ekdam. And if few rays pass, then we'll get a grayish picture sort of thing, right? So depending on the density of the object and the atomic number of the object, you get various shades of gray, right? That is the basis of attenuation. The Hounsfield, the unit is Hounsfield. And which is the most black structure? The Hounsfield scale ranges from -1000 to +1000. This was again a question. And -1000 will appear jet black and +1000 appear jet white, right? And +1000 किसका देते हैं हम? Cortical bone का देते हैं. So correct कर लो आप. Metal नहीं है, cortical bone है. And jet black -1000 HU is for air. ठीक है? I've seen that the attendance has dropped drastically since the NEET PG postponement has been announced, and this was expected, right? I was expecting that the attendance would drop because now everything will be available online and nobody is in the mood to study. But nevertheless, let's continue with today's class, right? So -1000 is air, +1000 is cortical bone. Again, question was asked, zero किसका होता है? Zero is assigned to water. Zero is assigned to water, right? Now again, very important question, negative HU किसकी होती है? So any HU which is negative is fat. So -100 लेते हैं fat का, but sometimes in the question you can get -60, -20, -30 HU. All of them will denote that the lesion has fat. And the question was asked that there is a renal mass on CT scan. The CT attenuation is -60 HU. What is the diagnosis? So one of the options was renal cell carcinoma, another option was angiomyolipoma, and AML was the answer. Sir, increase the volume. Okay. Is it better now? There is some problem. I think audio में बहुत increase करनी पड़ रही है ना volume. So I think that this is better now. Is it better now? Tejas, Jeetu, cryptic commenter. Is it better now? ठीक है. So I said -1000 is air, +1000 is cortical bone, 0 is taken for water, minus is taken for fat. Now water में कौन कौन से structures हैं which constitute water? So urinary bladder, ascites, ventricles of the brain, all these constitute water. So they will have around 0 HU, 0 या उसके आसपास का HU होगा. Now all our soft tissues, brain, liver, spleen, kidneys, they have around 50 HU. And you write down one more thing, you annotate or you draw this line that around 80 HU we have acute hemorrhage. Around 80 HU we have acute hemorrhage, right? So any bleed will appear dense than the background soft tissue because soft tissue का 50 है और bleed का 80 है. So that is why acute EDH, acute FDH, all of the bleeds appear brighter than the brain, and hence NCCT is investigation of choice for head trauma. Correct? So a lot of questions from this table. First of all, HU unit is used to denote attenuation. range varies from -1000 to +1000. 0 is denoted to water and negative is denoted to fat. ठीक है, हाँ, dense मतलब white. Yes, yes, the cryptic commenter, dense मतलब white. ठीक है. Now, what is KVP versus MAS? Now, this is a term which we use on all X-ray based modalities, not just radiographs, right? So, KVP is the potential difference between the cathode and the anode. So, we know that this is the anode, this is the cathode. The electrons are coming from the cathode, incident on the anode, and you get X-rays. Now, the potential difference between these two is the KVP, and the current passing through the cathode, this is the MAS, right? So what does the KVP denotes? Potential difference. So जितना ज़्यादा potential difference, उतना तेज electrons move करेंगे, उतने quality of X-rays improve होगी, उतनी energy of X-rays improve होगी. So KVP decides, KVP, let's write it down here, KVP versus MAS. KVP decides energy of X-rays, right? And MAS decides quantity of X-rays, right? So energy of X-ray ज़्यादा होगी तो मतलब penetration power of X-rays is more, and MAS ज़्यादा होगा तो quantity of X-ray ज़्यादा होगी, मतलब dose to patient is more. So dose कौन decide करता है? MAS. Again a potential question. Quantity कौन decide करता है? MAS. Again a potential question. Now a very important thing is image contrast का क्या relation है? Image contrast is inversely proportional to KVP, whereas image contrast is directly proportional to KVP. यार पंकज, आई नो जनरल रेडियोलॉजी समझ नहीं आती है, बट अभी नहीं पढ़ा सकते यार, 2 घंटे में जनरल रेडियोलॉजी प्लस सिस्टमिक रेडियोलॉजी नहीं पढ़ा सकता. यू सी माई रैपिड रिविजन वीडियोस, ठीक है? रैपिड रिविजन इज अवेलेबल विद संकल्प नीट पीजी बैच. 3500 का प्लान है यार. 3500 में यू गेट ऑल रिविजन वीडियोस, क्वेश्चन बैंक, टेस्ट एंड डिस्कशन, recorded test and discussion videos, everything you get in 3500. I don't know why are you not buying it. 3500 में मेरा प्लान लो, रैपिड रिविजन प्लान, उसमें बेसिक रेडियोलॉजी पढ़ो. आई हैव कंप्लीटेड जनरल रेडियोलॉजी इन 3 आवर्स. 3 आवर्स, ठीक है? उससे पूरी जनरल रेडियोलॉजी कवर हो जाएगी आपकी. अभी नहीं पढ़ा सकते, सॉरी, ठीक है? मूविंग ऑन. इमेज कंट्रास्ट इज इनवर्सली प्रोपोर्शनल टू केवीपी एंड डायरेक्टली प्रोपोर्शनल टू एमएस. सॉरी, नॉट केवीपी, एमएस. ठीक है? अब इमेज कंट्रास्ट होता क्या है कि अगर ये बैकग्राउंड ब्लैक है, ठीक है, ये ब्लैक बैकग्राउंड है, ब्लैक बैकग्राउंड है, उसमें 2 चीजें हैं. मैं एक लाइन ये बना रहा हूं और एक लाइन ये बना रहा हूं. तो वाइट वाली चीज बेटर दिख रही है ना ग्रे से. ये ग्रे है, ये वाइट है, दिख दोनों रहे हैं, बट वाइट बेटर दिख रही है. So this is known as image contrast, that is ability to differentiate between 2 objects. ठीक है? That is resolution, and resolution depends on the image contrast. So image contrast is directly proportional to MAS and inversely proportional to KVP. If you are asked between which is the predominant determinant of image contrast, it is KVP. It is predominantly determined by KVP. And this is a previous year question. Image contrast is predominantly determined by KVP. ठीक है? Now in an obese patient, first factor to improve image contrast. Now obese patient के साथ दिक्कत क्या है कि their tissue is a lot, right? So you need good penetration of X-rays. So first factor that you increase in an obese patient is increase KVP, right? But you know that image contrast is inversely proportional to KVP. हम KVP बढ़ाएंगे तो image contrast कम हो जाएगा. So modify कौन सा करना पड़ता है factor? We increase the MAS. So in an obese patient, you increase both KVP and MAS. Very, very important point. ठीक है? Yes, Selva, I know, if even I get quite bash quite bashing regarding this, that sir why are you promoting PW, but मैं बोल रहा हूँ कि यार अगर आपकी need है कि अगर if you want a test and discussion revision video, so 3500 से सस्ता कुछ नहीं मिलने वाला, ठीक है, and quality content है. If you want you can try, obviously nobody is forcing you. If you want you can try, else what you have is fine. ठीक है. The cryptic commenter, I think KVP versus MS वाली concept is clear to all of you. KVP versus MS is clear. Okay, let's move on. Now, investigation of choice for various tissues. So let's say fluid containing pathologies. What are fluid containing pathologies? Ascites, pleural effusion, ठीक है, and acute, okay, ascites and pleural effusion. So what is the investigation of choice? It is ultrasound. Now for air containing pathologies like pneumothorax, peritoneum, cephalus, mediastinum, all pneumo containing structures, pneumothorax, investigation of choice is NCCT. Now for all calcifications, renal calculi, mainly renal calculi, ureteric calculi, bladder calculi, investigation of choice is NCCT again. ठीक है. एक एक्सेप्शन है, बताओ. वेरी कॉमनली गॉल ब्लैडर स्टोन्स. गॉल ब्लैडर स्टोन्स के लिए इन्वेस्टिगेशन ऑफ चॉइस इज अल्ट्रासाउंड, राइट. एनसीसीटी क्यों नहीं है? बिकॉज गॉल ब्लैडर स्टोन्स आर नॉट कैल्शियम कंटेनिंग, कैल्सिफिकेशन नहीं होते हैं वो, दे आर मेड ऑफ कोलेस्ट्रॉल एंड पिगमेंट्स, राइट. सो दैट्स व्हाई दे आर नॉट विजिबल ऑन सीटी स्कैन, दे हैव टू बी सीन ऑन अल्ट्रासाउंड. ठीक है. नाउ सॉफ्ट टिश्यू, if the soft tissue is tumor or in general soft tissue, you write MRI is the investigation of choice, because soft tissue resolution of MRI is much better than CT. Bone cortex, C for cortex, C for NCCT. And what is the bone cortex pathology that we talk about? So osteoid osteoma and fractures, NCCT. Now bone marrow, M for marrow and M for MRI. Right, so MRI is the investigation of choice for osteomyelitis, AVN, sacroiliitis, and stress fracture. Now acute hemorrhage meaning head trauma, investigation of choice is NCCT. Now chronic hemorrhage and microhemorrhages, investigation of choice is MRI. ठीक है. so microhemorrhages किस में होती हैं? Which disease do you get microhemorrhages? Diffuse axonal injury, CNS vasculitis. Investigation of choice is MRI. And which sequence, if you are asked sequence, SWI, T2 star or GRE, anything can be given in the question. All of these are correct answers. Now for vascular pathologies, ठीक है, vascular pathologies except लिख लो यहाँ पे, कौन सी नहीं है? except renal artery stenosis and carotid stenosis. ठीक है. So vascular pathology के लिए first investigation is a duplex ultrasound. Duplex Doppler ultrasound is the same thing. Investigation of choice is CT angiography. ठीक है. Except these, इनके लिए MR angiography है. And gold standard क्या बनता है? Gold standard is DSA or digital subtraction angiography. Okay, clear? So investigation of choice for microhemorrhages is MRI. For vascular pathologies, its first investigation is duplex, investigation of choice is CT angio, and gold standard is DSA. ठीक है. चलो next, types of contrast media. So what is this? Microbar HD. This is barium sulfate. This is barium sulfate, and first of all, this is water insoluble. Therefore, it cannot be given IV. It cannot be given intravenously. So where is it given? It is given orally. And orally किस में मिलते हैं? Barium swallow, barium meal follow through, and barium enema. ठीक है. नेक्स्ट क्वेश्चन कम्स कि कॉन्ट्राइंडिकेशंस क्या हैं. कॉन्ट्राइंडिकेशंस है परफोरेशन में यू कांट गिव, ट्रेक्योइसोफेजल फिस्टुला, ऑब्स्ट्रक्शन, बावल ऑब्स्ट्रक्शन में यू कांट गिव. सो इसमें देना क्या है फिर? इन दिस यू गिव iohexol, which is this compound, right? So these are the things that will be asked in barium. Second contrast is your iohexol. Now iohexol is a type of non-ionic monomer. Right? So this is water soluble, so it can be given IV. In fact, all your CT scans, contrast and CT scans are done using iohexol. Now what is this third contrast? This is iodixanol, and this also is water soluble, but this is non-ionic monomer, right? So this is also known as isoosmolar contrast media, and this is water soluble, so this is also given IV. But इसका advantage क्या है? Since it is isoosmolar, it is less nephrotoxic. Now what are the side effects of all iodinated contrast agents? It is contrast induced nephropathy, CIN. Therefore RFT is must before CECT. कितना होना चाहिए creatinine clearance? GFR should be more than 45 ml per minute for getting a CT scan done, contrast and CT scan done. ठीक है, both are same, compound different है, एक monomer है, sorry एक dimer है, dimer लिख, sorry, thank you, this is non-ionic dimer, this is isoosmolar, less nephrotoxic. ठीक है, sorry, this is non-ionic dimer. Thank you Dr. Tejas. ठीक है. Now fourth compound is gadolinium. Gadolinium is your MR contrast agent, and with MR contrast agent I mean that this is used whenever we are doing contrast enhanced MR, right? So what is the property of gadolinium? So this is bright on T1 because it shortens T1 relaxation time. Since it is bright on T1, therefore post contrast MRI is always T1 weighted. So you are asked this question, post contrast MRI कौन सा sequence करते हो आप? T1, T2, flare, T1 करते हैं post contrast. Now side effect क्या होता है? What is the side effect of gadolinium? Nephrogenic systemic fibrosis. So that is why again you do a RFT before getting a contrast enhanced MRI. Okay, so that is all that you need to remember with respect to contrast median radiology. Another fifth type of contrast, and this was asked in INI-CT, this is ultrasound contrast agent. Ultrasound contrast agent. Now what is the agent name? This is sulfur hexafluoride microbubbles. Sulfur hexafluoride microbubbles, SF6 microbubbles होते हैं ये. ठीक है. Now what do they do? Since they are microbubbles, they get reflected, they reflect the ultrasound, right? So that is why all the perfusion appears bright on ultrasound. So this is used for perfusion imaging of organs. And uses क्या है? कब नहीं कर सकते? When CECT and CEMRI are contraindicated. So when you can't do CCT and CEMRI, you can do ultrasound contrast agent. Why? Because excretion is via lungs, it's not via kidneys, therefore they are safe in CKD patients. Very, very important. And this was the question that was asked regarding ultrasound contrast agent. Its name is sulfur hexafluoride. CKD patient, which contrast will you use? CKD patient, which contrast can you use? You can't use iohexol, you can't use gadolinium, you can't use gastrographin. You have to use ultrasound contrast agent. Now, new question, potential question, what is the agent that we use in ultrasound contrast agent? This is SF6, sulfur hexafluoride. What is the brand name of SF6? It is SonoView. Brand name comes with the name of SonoView. Okay, good Jeetu, good. Now let's move on to the next. Let's come to systemic radiology now. So first pathology, everybody knows this is pleural effusion, right? You get this meniscus sign. What is the investigation of choice? It is ultrasound. So you get this meniscus sign, opaque radiopacity on one side of the chest, and contralateral tracheal shift. Contralateral tracheal shift on X-ray. Investigation of choice is ultrasound because fluid containing structures. Now, infected pleural effusion. What is it called? This is known as empyema. And what is the sign that you see in empyema? It is split pleura sign. And since it is infected, what is the treatment? Treatment, you have to drain it. You have to drain it. So either you put in a ICD, or if it is small, you do ultrasound guided aspiration. Ultrasound guided aspiration. Okay, so there is one doubt that, sir, I have only watched BTR videos, study BTR notes and getting 100 to 110 correct in GTs. Okay, in PW NEET mock, I got 149 correct. As now exam got postponed, should I watch any main videos or study main notes? So stick to your plan. ठीक है, अगर आपने BTR videos, BTR notes से पढ़ा है तो बार बार उनको ही पढ़ते रहो. Do multiple revisions of that. Now you will ask that, sir, what about my weak subjects then? So whatever lacuna you have now, complete it with the help of questions. So daily solve 50 questions, random all tags, or 100. Now do 100 because you have more time. Do 100 daily questions, all subjects, right? So your cyclical revision will keep on happening. You will be able to mark new questions. Don't read main notes now. Don't watch main videos because main videos are very lengthy. You still don't have time to watch main videos. Continue with your plan. Just add more questions to your practice apart from grand test. Questions मतलब grand test नहीं होता है. ठीक है, आगे बढ़े. चलो, blood vessels. That is how you diagnose it is a pneumothorax. Now question comes, what is the best view? Best view is chest X-ray expiratory view, wherein you see a visceral pleural line and no blood vessels. जो एरिया ब्लैक है वहां पे ब्लड वेसल्स नहीं दिखती हैं. हेलो, हाँ मामा जी क्लास में होगी. Now, second question is, what is the investigation or the best investigation to diagnose pneumothorax? The answer is NCCT. NCCT is the best investigation or the investigation of choice. Third question, what is the management? So we know that if it is an unstable patient, we do a needle thoracostomy, and this is done where adults में हम करते हैं fifth intercostal space, mid-axillary line. Children, we do it in the second intercostal space, mid-clavicular line. ठीक है, and followed by an ICD. ICD तो डालनी है जब भी pneumothorax है. Stable patient है, so you just put in an ICD. What are the ultrasound findings? So B mode में you get absence of sliding pleura sign, and more specific sign on B mode ultrasound is presence of a lung point, right? Now what is the sign on M mode? What is the sign on M mode? You get barcode sign, also known as stratosphere sign. ठीक है, एंड एब्सेंट सीशोर साइन बोल सकते हैं. नॉर्मल प्लूरा शोज सीशोर. ठीक है, सी में हम जब हेल्दी होते हैं तब जाते हैं, तो सीशोर भी तभी देखेंगे जब हम हेल्दी होंगे. नॉर्मल प्लूरा में सीशोर साइन मिलेगा. हाउ डज इट अपीयर? सो दिस इज योर barcode sign and seashore sign like this. All of you have seen this image. We are doing a quick revision for you guys, right? Okay, let's move on to the next. What are these? So if you see unilateral radiolucency, that is black lung with an air fluid level. Unilateral radiolucency plus air fluid levels. What are you dealing with? This is hydropneumothorax. And what is this? If you see a cavity with an air fluid level, this represent a lung abscess. Lung abscess. Now what is this sign which is shown here? You see that the right heart border is obscured. Right heart border obscured. What is the name of the sign? Sign is silhouette sign. And what is the location of this pathology? This is in the right middle lobe. Right middle lobe. So this can be a mass, this can be a consolidation, this can be a collapse. How do we differentiate? We look at the morphology. A consolidation will have air bronchograms. A collapse will have features of volume loss. So diaphragm will be pulled up or hilum will be pulled down. And mass will have very well defined rounded borders. Location is RML. This was asked previously in AIMS. Right middle lobe, right? Correct. Now let's see other pathologies. Just name of the sign and diagnosis. What is the sign? Name of the sign is CT halo sign. And where is the scene? Invasive pulmonary aspergillosis. This is IPA. Invasive pulmonary aspergillosis, CT halo sign. So center mein there is consolidation and surrounding mein there is ground glass opacity. This is CT halo sign. Basically it tells us invasive fungal infection. Okay. Now second is an air crescent sign. Now air crescent sign, a lot of you think that it is seen in aspergilloma, but remember it is also seen in invasive pulmonary aspergillosis, IPA. And invasive pulmonary aspergillosis में कब मिलती है? Whenever this patient is getting healing. It is the blood immunity is strong. It is attacking the fungus. So what happens? That necrotic core sort of retracts. And there is a cavity, and in between the cavity, air creeps in. And that is what is known as an air crescent sign. It was originally described for invasive pulmonary aspergillosis only. Now, what is this next sign? Periphery में consolidation, center में GGO. This is reverse halo sign, also known as bird nest appearance. And this is seen in diagnosis, invasive mucormycosis. Invasive mucormycosis. ठीक है. Now what is this sign? So aspergilloma में जिसको हम बोलते हैं air crescent sign, this is actually called as a monod sign. So there is a cavity, and in that cavity a fungus sort of colonizes. So this is a fungal colonization. It is not invasion. Fungal colonization, and it happens in immunocompetent patients. Immunocompetent patients with pre-existing cavities. So for example, old TB patients, old bronchiectasis patients who already have a cavity in the lungs, right? So let's say you have a patient who comes with sudden onset massive hemoptysis, right? And there's a past history of TB. Currently CT shows no trine bud nodules, but a cavity in the left upper lobe with an air crescent or a monod sign. What is the diagnosis? Don't mark TB as the answer. Think of aspergilloma. Aspergilloma is the most common cause of massive hemoptysis in a post-TB patient. Correct? Now, what is the second image? What is the name of the sign? Second is showing ABPA. Tell me, fatafat, what sign do you see in ABPA? Yes, finger in glove appearance. Finger in glove appearance. So क्या होता है finger in glove? So upper lobe में bronchiectasis होता है. There is bronchiectasis, and in that bronchiectasis mucus starts plugging. ठीक है, तो ऐसा लगता है कि फिंगर्स पे किसी ने ग्लव्स पहना दिया है. So what is finger in glove appearance? There is central bronchiectasis, and this is a potential question that ABPA में कौन सा टाइप ऑफ ब्रोंकिएक्टेसिस मिलता है, सेंट्रल की पेरिफेरल, सेंट्रल ब्रोंकिएक्टेसिस, एंड दिस इज अपर लोब प्रिडोमिनेंट. ठीक है, एंड अलॉन्ग विद दैट यू गेट म्यूकस प्लगिंग, एंड दिस म्यूकस प्लगिंग रिजल्ट्स इन अ finger in glove appearance. That is the only thing that will be asked you. Now, what is the most specific sign? Most specific sign of ABPA is actually known as HAM. Now, what does HAM stand for? It stands for high attenuation mucus. Attenuation mucus. So I told you कि bronchiectasis में क्या होता है, bronchiectasis में mucus plug होने लगता है, but sometimes this mucus is bright even on a non-contrast CT. ठीक है, mucus तो water होता है, water should appear isodense, but why is it appearing bright? Because there are fungal elements which are present in this mucus, and so if you are able to see fungal elements in this mucus, it is very specific of ABPA. So potential question, most specific sign for ABPA is high attenuation mucus. High attenuation mucus. Now clinical features क्या होते हैं, क्लिनिक्स में कैसे चलेगा पता, क्योंकि क्वेश्चन में तो ऐसा नहीं आएगा, क्वेश्चन में तो क्लिनिकल फीचर्स आएंगे. तो क्वेश्चन में देयर इज हिस्ट्री ऑफ एस्थमा, वेरी वेरी इंपॉर्टेंट. एस्थमा इज अ रिस्क फैक्टर. फैटीग, ठीक है, फैटीग, क्रॉनिक कफ, these are the symptoms which suggest ABPA. And on X-ray you get a finger in glove appearance, on CT scan you get high attenuation mucus. Potential questions, I've told you all the important keywords, all the important buzzwords. Okay, let's move on to the next series. So cardiovascular radiology, all important X-rays. This is your favorite, everybody knows this. So sign and diagnosis. So sign क्या है, पहला है boot shaped heart. Boot shaped heart, diagnosis is tetralogy of Fallot. दूसरा क्या है हमारा, box shaped heart. Box shaped heart, what is the diagnosis? Diagnosis is Epstein anomaly. थर्ड क्या है, Egon string appearance. What is the diagnosis? TGA. And the fourth क्या है, figure of 8 appearance. Figure of 8 appearance, and the diagnosis is supracardiac TAPVC. Now I'll tell you few other important buzzwords or hinters in this, because you know nobody's gonna ask you boot shaped heart now, because that is not the level of the exam nowadays. What you will be asked is that in which of these do you get cyanosis? So all of them you get cyanosis. So cyanosis is seen in all of them. Then how do you differentiate between these four? So in the first two you have pulmonary oligemia, मतलब reduced pulmonary blood flow. And कैसे दिखता है reduced pulmonary blood flow? Black दिखेंगी lungs appear black. So देखो यहाँ पे थोड़े black दिख रहे हैं, यहाँ पर भी देखो black दिख रहे हैं, lungs कम ही दिख रहा है क्योंकि heart इतना बड़ा है, but still lungs are appearing black. So black lung means cyanotic patient में it is pulmonary oligemia, and you have to think about these two differentials, Epstein and TOF. Now how to differentiate between Epstein and TOF? In TOF, heart size is normal. This is very important. Although in TOF you have right ventricular hypertrophy, but heart size on chest X-ray, that is CT ratio, is normal. Whereas in Epstein anomaly, you have enlarged heart. You have cardiomegaly. Okay? And another thing, why cardiomegaly? Because of right atrial enlargement. Which chamber is enlarged in Epstein anomaly? Right atrium is enlarged. Chalo, next question. Let's see the various heart borders. What forms which heart border? So right heart border from top to bottom is formed by SVC, RA and IVC. So SVC, RA and IVC. And left heart border from top to down is formed by aortic ascending arch of aorta, main pulmonary artery, left atrial appendage and left ventricle. So arch of aorta, main pulmonary artery, left atrial appendage and left ventricle. What is left atrial appendage? The auricle of the left atrium. Okay, I'm writing it completely. Left atrial appendage. An important thing to note is that left atrium does not form any heart border. So what it does it form? It forms the base of heart. So क्या इसको बोलते हैं base? नहीं, इसको नहीं बोलते. This is known as the inferior surface. Base पीछे वाला part होता है, posterior part of the heart होता है base. That is formed by left atrium. Inferior surface is formed by, tell me in the chat box, कौन बनाता है inferior surface? What forms the inferior surface of heart? It is the right ventricle. Right ventricle forms the inferior surface and this is the anterior most chamber of heart. Okay, good Tejas, RV forms the right inferior surface. Now how do we assess the heart size? So what is cardiomegaly? Cardiomegaly is defined by CT ratio or cardiothoracic ratio. So adults में क्या कट ऑफ है? Adults में CT ratio more than 0.5 is taken as cardiomegaly. Infants more than 0.55 and neonates more than 0.6. ठीक है, चलो next set of questions. Again this is a previous year question asked in NEET PG. ठीक है, so on this barium swallow, what do you see? You see a posterior indentation on the upper esophagus. This is known as dysphagia lusoria. Dysphagia lusoria. And what is the cause of this? The cause is URSA or aberrant right subclavian artery. Right subclavian artery. What is URSA? वो कौन सी आर्टरी है इसमें से? ये वाली आर्टरी है, देखो. ठीक है, नॉर्मली हाउ डू यू सी? यू सी द थ्री आर्चेस लाइक दिस. 1 2 3 यहाँ पर होता है तीसरी आर्टरी, बट यहाँ पर ये वाली आर्टरी क्रॉस कर रही है ऑन द कॉन्ट्रोलैटरल साइड. राइट सबक्लेवियन आर्टरी इज क्रॉसिंग ऑन द कॉन्ट्रोलैटरल साइड and forming the right subclavian. It is going behind the esophagus, and while going behind the esophagus, it compresses the esophagus, causing dysphagia lusoria. So normally anterior to the vertebra, you don't see any artery. If you see an artery anterior to the vertebra, it is an URSA. It is URSA. Now let's see the signs of left atrial enlargement. So what are the signs? So number 1 is widening of carina. ठीक है, this is the carinal angle. This gets widened in left atrial appendage. Second sign is double density sign. Double density sign. What is double density? That the right heart border, this is the right heart border. उसके अंदर you see another margin. This margin. This is the margin of the left atrium, and Why does it happen? Because as the left atrium enlarges, it crosses the midline, and so this is the total size of the left atrium. This is the size of the left atrium. This is known as double density sign. The third sign is straightening of left heart border. That is, the left heart border is straightened. The straightening also signifies your left atrial enlargement. And fourth is walking man sign. A walking man sign is seen on lateral chest x-ray. This is seen on lateral chest x-ray. So you won't be able to see this sign on this image, but just remember the name of the sign, walking man sign. Okay. Now let's move on to bone tumors. So we are done with chest radiology, respi and cardiovascular. Let's revise bone tumors quickly. So first important thing, whenever you are diagnosing bone tumors, you first have to see the age, because age tells a lot of things. Then you have to see the location, and finally the last thing you have to see is the internal characteristics. ठीक है, लोकेशन में क्या देखना है, क्या वो एपीफाइसिस है, मेटाफाइसिस है, डायाफाइसिस है, क्या वो सेंट्रल है या एक्सेंट्रिक है, और whether it is cortical based or involves the medulla. Right, so let's see what are the differential diagnosis of each one of them. So based on location, epiphyseal locations are two tumors only. One is chondroblastoma and another one is giant cell tumor. So how will you differentiate between these two? Based on age. So chondroblastoma occurs in children and giant cell tumor occurs in adults. So children, how do you identify on X-ray? You see that the growth plate is not fused. Whereas in adults, you see the growth plate is fused. ठीक है, क्लियर है अभी तक? चलो डायाफाइसिस के लीजन्स देख लेते हैं. Diaphysis tumors we remember by the mnemonic O female. O stands for osteoid osteoma, F for fibrous dysplasia, E for Ewing's sarcoma, M for metastasis, A for adamantinoma. Adamantinoma is a very specific tumor. It only occurs in the diaphysis of tibia. तो टिबिया के डायफाइसिस में अगर कोई ट्यूमर दिख रहा है, मार्क एडामेंटिनोमा. L is for lymphoma and E again is for eosinophilic granuloma. ठीक है, so let's see all of the tumors one by one. What is the first tumor? Tell me. What is the first tumor? Chondro what? Chondrosarcoma or chondroblastoma? What is the first tumor? So age क्या है? 15-year-old boy. So बच्चा है. And what is the tumor? Where is the tumor located? It is located in the epiphysis. Well-defined tumor, not causing cortical breach. Right? So what is the diagnosis? Benign tumor, epiphysis, children. I just told you. Children, epiphysis. Chondroblastoma. So diagnosis is chondroblastoma. Age is before skeletal maturity and location is epiphysis of long bones or apophysis. Apophysis क्या होते हैं? Trochanters and tuberosities. तो जैसे आप देखो ये ग्रेटर ट्रोकैंटर है, दिस इज द ग्रेटर ट्रोकैंटर, वहां पर ट्यूमर है, इट इज कॉन्ड्रोब्लास्टोमा. ट्रोकैंटर्स एंड tuberosity. Next, what is the tumor? 35-year-old adult. What is the location? Next step is to see the location. It is epiphysis. Adult epiphysis. एक ही diagnosis है हमारे पास, giant cell tumor. What is the age? After skeletal maturity. Location is epiphysis. Now sometimes in the question you can be given epimetaphysis location. That is also correct, and that is in fact the actual location, but we, for our understanding and for solving questions, let understand this as an epiphyseal tumor. Now what is an appearance? This is a multiseptated tumor, and treatment is surgical excision. You do a curettage. ठीक है. Now next, what is the diagnosis? So age is again adolescent or young adults. Location is diaphysis. ठीक है. Long bones में femur is the most common. The name of the sign is Shepherd Crook deformity, and the syndromes associated are: number 1, McCune-Albright syndrome. What do you get here? You get precocious puberty, plus polyostotic FD, plus 𝐒𝐄𝐈𝐀 spots. And what is the second syndrome that you see? Maza-Brod syndrome, right? And here you get what? Fibrous dysplasia plus soft tissue myxomas. Soft tissue myxoma. Now moving on, what is the age? क्या दिख रहा है हमें इसमें कि growth plate is not fused. Growth plate is not fused. यहाँ पे भी देखो अल्ना में भी growth plate is not fused. So age is before skeletal maturity. Location is metaphysis. And what do I see? I see a benign looking lesion. The cortex is not breached. Cortex is intact. Therefore it is benign. Young patient, benign metaphysis, lytic, only 1 dd. Answer is aneurysmal bone cyst. ठीक है, ABC. So this is eccentric and has septations, therefore known as soap bubble appearance. Soap bubble appearance. ये देखो, ये कौन आ गया? ये कौन आ गया? पढ़ना है आपको भी? पढ़ना है आपको भी? चलो बैठो यहाँ पे. चलो नेक्स्ट क्वेश्चन. Next question. What is the diagnosis? So again you can see that the growth plate is not fused. So this is a young patient, and the location of the tumor is metaphysis. Now unlike aneurysmal bone cyst, this is central in location. ठीक है, and this is unilocular, no septa. So this is unilocular. What is the diagnosis? Simple bone cyst. ठीक है, and sign क्या है? Good. Fallen fragment sign. कोई और बताएगा? एक और साइन का नाम बताएगा कोई? Hinged door साइन. दो होते हैं साइन. सो अगर पूरा फ्रैक्चर फ्रैगमेंट बीच में ही आ गया तो उसको फॉलन फ्रैगमेंट बोल देते हैं, बट अगर फ्रैक्चर फ्रैगमेंट यहाँ पे चिपका पड़ा है, दैट इज नोन एज अ हिंज डोर साइन. डोर ट्रैप साइन और अ हिंज डोर साइन, ठीक है, डोर ट्रैप भी एक नाम है, गुड, ट्रैप डोर साइन तेजस सुब्रत, गुड, ठीक है। चलो नेक्स्ट क्वेश्चन, ट्यूमर ऑफ स्मॉल बोन्स ऑफ हैंड्स एंड फीट, ठीक है, हैंड्स, लोकेशन में लिख लेते हैं, हैंड्स एंड फीट, अगेन अ सेंट्रल tumor, what is the diagnosis, एनकॉन्ड्रोमा, ठीक है, तो सेंटर का ट्यूमर होता है and अंदर से खाली करता है, एंड ऑस्टियल स्कैलोपिंग, अगेन इट इज नॉट कॉजिंग any cortical destruction, so this is a benign tumor. What are the two syndromes associated? So Olier's disease and Maffucci syndrome. Olier's disease has only enchondromas and Maffucci's has enchondromas plus soft tissue hemangioma. All of them are pre-malignant. And what is the malignancy that develops in these? It is low-grade chondrosarcoma. Low-grade chondrosarcoma बनता है, सब pre-malignant lesions होते हैं, Olier's and Maffucci's. Next, ठीक है, young adult or adolescent with night pain relieved on NSAIDs. Diagnosis osteoid osteoma, direct, ठीक है, diaphyseal location diaphyseal location, it has a nidus plus surrounding sclerosis, ठीक है, क्लिनिकल फीचर्स हमने लिख ही लिए हैं। एंड ट्रीटमेंट क्या होता है, बताओ ट्रीटमेंट क्या होता है, व्हाट इज द ट्रीटमेंट, टेल मी। ट्रीटमेंट इज रेडियो फ्रीक्वेंसी एब्लेशन ऑफ नाइडस, ठीक है, सो आप एक प्रोब डालते हो यहाँ पे एंड उसको अंदर से जला देते हो, क्योंकि नाइडस से ही प्रोस्टाग्लैंडिन्स निकलते हैं, आपने नाइडस पे जला दिया, सो देयर इज नो नाइट पेन्स, देयर आर नो नाइट पेन्स व्हिच हैपन, सो ट्रीटमेंट ऑफ चॉइस इज रेडियो फ्रीक्वेंसी एब्लेशन ऑफ नाइडस, ठीक है। एस्पिरिन तो पेन, एस्पिरिन इज फॉर पेन, परमानेंट सॉल्यूशन, तो वी हैव टू ऑफर अ परमानेंट सॉल्यूशन आल्सो, राइट, so for that we ablate the nidus with the help of radio frequency, and this is done by us, yours truly, intervention radiologist, ठीक है, हमारे पास पेशेंट्स आते हैं, डे केयर एडमिशन, डे केयर प्रोसीजर होता है, दिस इज डन अंडर सीटी गाइडेंस, वी पुट इन अ प्रोब थ्रू द बोन कॉर्टेक्स इनटू द नाइडस एंड ablate that nidus, okay। now next diagnosis, age is again adolescents, what do you see, you see a bony lesion which has cortical and medullary continuity, location is metaphysis, has cortical and medullary continuity, so basically it's a abnormal growth of your normal growth plate, so normal growth plate grows like this, it grows like this, okay, so there is eccentric growth of your normal growth plate, so at the edge of this osteochondroma you have a cartilaginous cap, so there is a cartilaginous cap present, and when do you suspect malignancy, if the thickness of cartilaginous cap is more than 2 centimeters. And where do you measure the thickness, you measure this on MRI, and this is what this image is showing, that this is the cartilage cap which is above the osteochondroma, and if this thickness is more than 2 centimeters, that means that there is a malignant transformation which has happened. Again, what malignancy is more common, low grade chondrosarcomas are more common. Now, what are multiple osteochondromas? अच्छा diagnosis तो लिख दें. Diagnosis is osteochondromas, also known as exostosis. Exostosis. So they are actually not tumorous. ठीक है, they are actually hematomas. Multiple osteochondromas are known as diaphyseal aclasis. Diaphyseal aclasis. Right. So you have multiple osteochondromas in multiple bones. So radius, ulna, femur, tibia, fibula, all of these have osteochondromas. So one thing you remember is that these osteochondromas grow away from joint. ठीक है, so यहाँ पे इसका knee joint होगा, so it is growing away from the knee joint. Similarly, if it was to happen on tibia, it will grow like this. So osteochondromas grow away from the joint. Okay, next question. Next spotter, what is the diagnosis? So this occurs in the second decade of life. Location is metaphyseal. The matrix is osteoid matrix. Bones affected are long bones, and the diagnosis is osteosarcoma. ठीक है, टेल मी फटाफट पेरियोस्टल रिएक्शन का नाम क्या है? सनबर्स्ट. सनबर्स्ट पेरियोस्टल रिएक्शन. दूसरा है कॉडमैन्स ट्रायंगल. यस तेजस, ऑस्टियोकॉन्ड्रोमा के एक तो है कि थिकनेस मोर देन 2 सेंटीमीटर, एक और ये भी है कि इट कीप्स ऑन ग्रोइंग आफ्टर प्यूबर्टी. सो नॉर्मल बिनाइन ऑस्टियोकॉन्ड्रोमास stop growing after puberty because growth plate fuses at puberty, right? So since their extension of growth plate stops growing after puberty, so osteochondromas stop growing after puberty. If they are growing even after puberty, that means there is a malignant transformation which has occurred and you need to do an MRI. ठीक है, चलो नेक्स्ट. एडल्ट पेशेंट. Location either metaphysis of long bones or flat bones. Matrix is chondroid matrix. What is the hallmark of chondroid matrix? You get C or O shaped ring or arced calcification. Ring or arc calcification. So rings are O and arcs are C. So O and C type of calcification also sometimes mentioned. What is this tumor? This is chondrosarcoma. Happens in adults more than 40 years of age. Right, now question comes, most common flat bones. Most common flat bone involved, it's pelvis. And most common primary malignant bone tumor of flat bones, it is chondrosarcoma. In adults it is, यहाँ पे लिख लेते हैं, wait. In adults it is chondrosarcoma, and in children it is Ewing's sarcoma. Clear everybody? Should we move ahead? So with that we finish our important bone tumors. Few other bone tumors might be left, they are not so important. Ewing's sarcoma, again onion skin periostal reaction, Ewing's you get in the first decade of life. You already know all this. Now next is this spotter. What is the name of the sign that you see here? You see a dagger sign. and the diagnosis is ankylosing spondylitis. Right? This is a type of spondyloarthropathy, and this is HLA-B27 positive. What is the age? Usually it affects the young males. Young males meaning 20 to 20s and 30s. Males in their 20s and 30s. Young males affected. Joints. First joint to be involved is your SI joint. And what finding do we get in SI joint? We get bilateral asymmetric sacroiliitis. Sacroiliitis. And what is the investigation of choice for sacroiliitis? It is MRI. It is MRI. Travel man is asking, sir, is exam postponed? Yes, exam is postponed. There's official notification. Exam is postponed. Now you can travel. ठीक है गुड. स्टर भी लिख दिया किसी ने. सीक्वेंस ऑफ चॉइस क्या देखते हैं हम? एमआरआई पे कौन सा सीक्वेंस यूज करते हैं? स्टर. चलो अब आप बताओ, अगर आप स्टर बोल ही दिया है डॉक्टर जीतू, व्हाट डू वी सी ऑन स्टर? व्हाट डू वी सी ऑन स्टर? Yes, we see bone marrow edema. Bone marrow edema. So bone marrow edema के लिए सीक्वेंस ऑफ चॉइसेस स्टर. स्टर की फुल फॉर्म बताओ क्या है? स्टर की फुल फॉर्म पता है क्या है? ठीक है, गुड गुड सोनम, गुड. बोन मैरो एडिमा, इट इज शॉर्ट टाउ inversion recovery, and this is a fat suppressed sequence. फैट सप्रेस्ड सीक्वेंस है. ठीक है. सो बोन मैरो में फैट होता है, दैट इज वाई वी डू स्टर, ताकि बोन मैरो का फैट इज वाइट ऑन T2. So you suppress the fat with the help of this stir sequence, only water is seen. So bone marrow edema is very well seen on stir because it is a fat suppressed sequence. It suppresses the normal fat signal of the bone marrow and only the water is seen. That is why to pick up any subtle bone marrow edema like stress fractures, AVN, sacroiliitis, the investigation of choice is MRI and stir. Okay, good. This is very good. Again, 2-year-old child with weakness and short stature. This is the hand X-ray given. What is the diagnosis? We are dealing with rickets, right? And so what are the findings? Widening of growth plate, splaying, fraying, and cupping of metaphysis. Okay. Next question now comes. Healed rickets. What do you see? In healed rickets, you see metaphyseal bands. ठीक है. तो जहां पर ये फ्रेइंग वगैरह दिख रही है ना, यहाँ पे ऐसे ऐसे लीनियर बैंड्स दिखने लगते हैं व्हाइट कलर के. You see these metaphyseal bands here whenever there is healing occur. Healed rickets, white line of Frankel नहीं है. white line of Frankel scurvy में है. मेटाफिजियल बैंड्स अलग चीज है. मेटाफिजियल बैंड्स इज हील्ड रिकेट्स. एक और जगह मिलते हैं मेटाफिजियल बैंड्स. ऑल्सो सीन इन lead poisoning and arsenic poisoning. ठीक है. मेटाफिजियल बैंड्स हील्ड रिकेट्स में दिखते हैं. व्हाइट लाइन ऑफ ट्रायंगल अलग चीज है. यहाँ पर बोलो अब. ठीक है. इस कर्व में बोल दो अपने सारे जो भी अरमान है. ठीक है. विंगबर्गर्स रिंग साइन, व्हाइट लाइन ऑफ फ्रैंकल, ट्रमलफील्ड जोन, रेडियो ल्यूसेंट, Trummerfield zone, and a Pelkin spur. All these signs are seen in scurvy. इसके अलावा important है जो pencil thin cortex. Pencil thin cortex and subperiosteal hematoma. Subperiosteal hematoma. Chalo, next, what is the sign? Codfish vertebra, also known as fish mouth vertebra. So what is the diagnosis? Osteoporosis. Right? Now tell me, is osteoporosis painful or painless? This is usually painless. Painless disease is osteoporosis. If there are pains, if pain present, that means there are osteoporotic acute fractures. ठीक है, एंड एक्यूट फ्रैक्चर्स कैसे होते हैं? दे आर स्ट्रेस फ्रैक्चर्स ओनली, स्ट्रेस फ्रैक्चर्स. ठीक है, एंड सो एक्यूट ऑस्टियोपोरोटिक फ्रैक्चर्स के लिए क्या आप इन्वेस्टिगेशन करोगे? इसमें आप एमआरआई करते हो. अगर आपको एक्यूट फ्रैक्चर्स देखने, विच आर द सोर्स ऑफ पेन, बहुत इंपॉर्टेंट बता रहा हूँ, बिकॉज ऑस्टियोपोरोसिस की अगर आपसे पूछेंगे इन्वेस्टिगेशन ऑफ चॉइस क्या है, देन यू विल मार्क एज डेक्सा स्कैन. एंड डेक्सा में you see bone mineral density. So overall bone mineral density low है या नहीं, वो कैसे चलेगा पता? Overall bone mineral density is less, you will see with the help of DEXA. But if there is an acute low backache, you want to see where are the stress fractures. For that you do a MRI, and again MRI, what do we see? We see bone marrow edema. Bone marrow edema tells us that this fracture is an acute fracture. Okay, what is the score used? It is defined as T score less than minus 2.5. And what is FRAX? FRAX score is fracture risk assessment tool. Used in osteoporosis. Used in osteoporosis. Okay, so with that we finish our MSK radiology also. Now let's move on to neuroradiology. So first things first, head trauma. One question is sure shot on head trauma. So what are the different types of extradural, extraparenchymal or extraaxial hemorrhages? So number one is FTH. Ulta marker rakha hai. So this is EDH. This is FTH. Okay, so EDH does not cross the sutures. FTH can cross the suture. कौन सा सूचर मिलता है यहाँ पे? फ्रंटो टेम्पोरल सूचर होता है. ये फ्रंटल बोन है, फ्रंटो या स्फिनॉइड बोन है, स्फिनॉइड टेम्पोरल सूचर, एंड पीछे टेम्पोरो ऑक्सिपिटल सूचर. यू सी दैट द ब्लीड इज क्रॉसिंग दी सूचर. सो दिस इज FTH. इट इज नॉट क्रॉसिंग. दिस इज EDH. सो EDH not crosses sutures, FTH crosses sutures. सेकेंड, मिडलाइन कौन क्रॉस करता है? मिडलाइन क्रॉसिंग EDH shows, FTH does not. टाइप ऑफ ब्लीड क्या है? EDH is an arterial bleed, therefore emergency, whereas FTH is a venous bleed. So middle meningeal artery is the most common artery, and venous में कौन सी वेन फटती है? emissary vein. Emissary vein. When do you intervene? Decompression surgery कब करते हैं? When midline shift is more than 5 mm. Next is SAH. SAH is diagnosed by thunderclap headache, or the worst headache of your life. Worst headache. Also, this can present with headache plus neck rigidity. So this is a type of extracorporeal hemorrhage which mimics meningitis, but how do you differentiate? There is no fever, right? Second, NCCTP, what do you get? You get a star shaped bleed. That is bleed in the basal cistern. Basal cistern bleed, right? Most common cause क्या होता है? Trauma. Most common non-traumatic cause, berry aneurysm. Is berry aneurysm. ठीक है. Investigation of choice to localize site of bleed, it is CT angio. CT angio. And gold standard is DSA. Grading system, modified Fisher scale. This is CT based. And clinical grading, Hunt and Hess scale. And there is another one known as WFNS, World Federation of Neurosurgery. World Federation of Neurosurgeons का एक scale होता है. These are all the important scales. So this is your whole nutshell, your whole play card or flash card if you want to say with respect to SAH. FDH ट्रीटमेंट ऑफ चॉइस है, डिपेंड करेगा कि क्या है, क्रॉनिक FDH है कि एक्यूट FDH है. एक्यूट FDH है तो डिपेंड करेगा मिडलाइन शिफ्ट है कि नहीं. मिडलाइन शिफ्ट है तो डिकम्प्रेसिव सर्जरी करनी है, अगर मिडलाइन शिफ्ट नहीं है तो वेट एंड वॉच करना है आपको, एंड ICP मैनेजमेंट, ICP मॉनिटरिंग. ओके, नाउ लेट्स कम टू CNS इन्फेक्शंस. ओके, what is this? First tell me diagnosis फटाफट. 1 2 3 4. ठीक है, so this is neurocystic sarcosis. Neurocystic sarcosis. What do you see here? You see a cyst with scolex. Cyst plus scolex. ठीक है. Now NCC versus tuberculosis में स्टूडेंट्स को बहुत कंफ्यूजन होता है. So remember neurocystic sarcosis presents as seizure. इसकी प्रेजेंटिंग कंप्लेन होती है सीजर. ठीक है. सिस्ट प्लस कोलेक्स मिलेगा. रिंग एनहांसिंग लीजन मिलते हैं इन एक्टिव स्टेजेस. मल्टीपल होते हैं, मल्टीपल स्मॉल साइज्ड. ठीक है. वेरा सेकंड में क्या दिख रखा है? सेकंड इज ट्यूबरकुलर मेनिंजाइटिस. इसमें भी यू कैन समटाइम्स गेट रिंग एनहांसिंग लीजन्स like this. But apart from the ring enhancing lesions, you will see basal meningitis. ठीक है. ये जो white दिख रहा है आपको सब, this all is meningitis, basal meningitis. And क्योंकि meningitis है तो clinical features मिलेंगे आपको headache and cranial nerve palsies. ठीक है. थर्ड क्या है? थर्ड इज अ ब्रेन एब्सेस. अगेन ब्रेन एब्सेस कैसे डिफरेंशिएट करेंगे बाकी दोनों से? इट विल बी सॉलिटरी यूजुअली एंड इट विल बी लार्ज. फोर्थ इज पेरीवेंट्रिकुलर कैल्सिफिकेशन. This is seen in CMV encephalitis. And कौन सा CMV? Congenital CMV. Periventricular calcifications. ठीक है. Now tell me two other important encephalitis. Encephalitis with thalamic involvement. Bilateral thalamus कौन सी encephalitis में involve होता है? Yes, number one is Japanese encephalitis. Can someone tell me another chocolate question? Thalamic involvement encephalitis. Virus ही है. Hint भी दे रहा हूँ, virus है. Can anybody tell me which other virus involves thalamus? No, not thalamus. ठीक है, चलो टेम्पोरल लोब के बारे आते हैं. टेम्पोरल लोब इन्वॉल्वमेंट इज HSV, हर्पीस सिम्प्लेक्स. यस, हर्पीस सिम्प्लेक्स टेम्पोरल है. जापानीज के अलावा एक और वायरस इन्वॉल्व करता है थैलेमस को. कैन समवन टेल मी? थोड़ा सा टफ है. द आंसर इज डेंगी. डेंगी इनकेफ्लाइटिस ऑल्सो इन्वॉल्व्स थैलेमस. ठीक है, चलो. रिंग एनहांसिंग लीजन्स इन HIV पेशेंट्स. HIV पेशेंट्स में अगर सॉलिटरी रिंग एनहांसिंग लीजन है तो HIV दे रखा होगा, HIV पॉजिटिव पेशेंट. अगर सॉलिटरी रिंग एनहांसिंग लीजन है देन यू हैव टू मार्क आंसर एज CNS लिम्फोमा. एंड मल्टीपल है तो CNS टॉक्सोप्लाज्मोसिस. CNS टॉक्सोप्लाज्मोसिस. ठीक है, टॉक्सोप्लाज्मोसिस में क्या मिलता है हमें? एक्सेंट्रिक रिंग साइन मिलता है. एक्सेंट्रिक रिंग साइन, एक बड़ा सा रिंग होगा और उसके एक्सेंट्रिक में एक और स्पोलेक्स जैसी चीज होती है. बट ये वो नहीं है, न्यूरोसिस्टिक सर्कोसिस नहीं है, बिकॉज इट इज अ बिगर रिंग एंड इट इज इन HIV पॉजिटिव. HIV पॉजिटिव विल ऑलवेज बी गिवन टू यू इन द ऑप्शंस इन द क्वेश्चन. चलो, now let's see other important brain calcifications and other brain tumors. We are talking about phakomatosis, basically syndromic brain tumors having skin lesions. तो पहला phakomatosis है जिसमें ash leaf nodule है. We are talking about phakomatosis. तो पहला है जिसमें ash leaf nodule है. एंड CT स्कैन में क्यों दिखा रखा है मैंने आपको? I see subependymal tumors or subependymal calcifications. What is this tumor? This syndrome is, और हम यहाँ लिखेंगे syndrome. Syndrome is tuberous sclerosis. ठीक है, TSC. गुड. सेकेंड phacomatosis है, स्किन लीजन आते हैं कैफे ऑलिव स्पॉट्स. एंड ट्यूमर में क्या मिलता है हमें? बायलैटरल अकूस्टिक श्वानोमा. कौन सा साइन मिलता है? आइसक्रीम कोन साइन. व्हाट इज द सिंड्रोम? न्यूरोफाइब्रोमोटोसिस टाइप 2. ठीक है, टाइप 2, सबने टाइप 2 बोल दिया. ठीक है. थर्ड इज कोस्ट ऑफ मेन स्टेन. ठीक है, पोर्ट वाइन स्टेन भी बोलते हैं इसको. पोर्ट वाइन स्टेन क्या है? दिस साइन स्टर्ज वेबर है. साइन का नाम क्या है? ट्राम ट्रैक अपीयरेंस. स्टर्ज वेबर सिंड्रोम. ठीक है, तो सारे फेकोमोटोसिस भी हमने रिवाइज कर लिए. ठीक है, गुड. नाउ लेट्स मूव ऑन टू सिस्टिक लीजन्स इन द नेक. तो सिमिलर टाइप ऑफ लीजन्स हैव क्लब टुगेदर ताकि आपको कंफ्यूजन ना हो एंड यू रिवाइज दीज इमेजेस. तो पहला है सिस्ट इन फ्लोर ऑफ माउथ. व्हाट इज द डायग्नोसिस? This is ranula. Port wine stain is the same side as that of your tram track appearance, उसी साइड में होता है ये. ठीक है. सेकंड क्या है? cyst beneath sternocleidomastoid. ये क्या है फिर? This is second brachial cleft cyst. And third क्या है? multiseptated lesion, child, non-enhancing. This is lymphangioma. Lymphangioma or lymphatic malformation. ठीक है. इसका earlier name was cystic hygroma. Cystic hygroma is no longer used. That is not the correct terminology to use. You labeled it as lymphangioma or a lymphatic malformation. ठीक है. hemangioma क्यों नहीं है ये? hemangioma enhancing होता है. hemangioma enhancing होता है. So I have specifically written non-enhancing. New name of cystic hygroma is lymphoma or lymphatic malformation. चलो. Other neck x-rays फटाफट. What is this arrow pointing towards? Child with acute throat pain, fever, stridor. Sign and diagnosis. Sign is thumbprint sign. Diagnosis is acute epiglottitis. Second sign, barking cough, young patient, young child, barking cough. Sign is steeple sign. Diagnosis is laryngotracheobronchitis or croup. कौन करता है? पैरा इन्फ्लुएंजा वायरस. ठीक है. क्रूप सबको पता है. क्रूप एवरीबडी नोज क्रूप. ठीक है. थर्ड एंड फोर्थ इमेजेस क्या हैं? सो आप देखो यहाँ पे. दिस इज ये वाला हाइपरट्रोफी. यहाँ पे एक मास हो रखा है विच इज कंप्रेसिंग ऑन द नेजोफैरिंग्स. देखो नेजोफैरिंग्स की नैरोइंग हो रखी है. सो दिस इज एडिनॉइड हाइपरट्रोफी. एंड इसमें क्या दिख रखा है? इसमें हमारा प्रीवर्टिब्रल स्पेस वाइडनिंग हो रखी है. सो दिस इज पैराफैरेंजियल और प्रीवर्टिब्रल एब्सिस. ठीक है. both of them are different but you can't differentiate just on the basis of x-ray, so we give both the DDs here. What is the thickness? That is important. At C2 the thickness should be more than 7 mm and at C7 more than 22 mm. ठीक है. तो C2 ये वाली वर्टिब्रा होती है. यहाँ पे डिस्टेंस नॉर्मली कम होता है, तो यहाँ का कट ऑफ भी इसलिए कम है. C7 थोड़ी लोअर वाली वर्टिब्रा है, यहाँ का डिस्टेंस नॉर्मली भी ज़्यादा है, तो यहाँ का कट ऑफ भी थोड़ा ज़्यादा है. ठीक है. चलो लेट्स मूव ऑन टू द नेक्स्ट क्वेश्चन. नाउ वी मूव ऑन टू GI tract radiology. So we are done with a lot of systems. Now GIT, genitourinary women's imaging are left, and then small topics like radiotherapy and nuclear medicine. So 10 more pages, guys. Okay, just bear with me. 10 more pages. Quickly we'll finish all the important topics, and your radiology for NEET PG, which is scheduled to happen at an unknown date, will get revised. ठीक है. चलो. ऑल गोइंग गुड? मजा आ रहा है? बताओ. न्यू पेरिटोनियम, क्लिनिकल फीचर ऑफ डायग्नोसिस. नेक्स्ट स्टेप बताओ क्या है? ठीक है. हॉलो विस्कस परफोरेशन सबने बोल ही दिया है. क्लिनिकल फीचर्स, एक्यूट एब्डोमेन, guarding rigidity, rebound tenderness. Diagnosis is pneumoperitoneum. Next step is exploratory laparotomy. Most sensitive investigation is NCCT abdomen. ठीक है, चलो नेक्स्ट क्वेश्चन. Identify the barium studies. So what is this? Easy. Barium meal follow through. I can see the stomach, the duodenum, the jejunum, and the ileum. What is the next study? Barium swallow. What is the next study? Barium enema. So barium studies में compound used is barium sulfate. It is given oral or through enema. It is never given IV. IV is contraindicated. ठीक है, IV बेरियम कभी नहीं देना भाई लाइफ में, प्लीज. लेट मी प्लग इन द चार्जर यार. Okay, contraindications we've already covered. Perforation, tracheoesophageal fistula, and obstruction. ठीक है, सो क्वेश्चन आता है आपका, इसमें क्वेश्चन आता है बोरहैव सिंड्रोम में. बोरहैव सिंड्रोम के लिए आप इन्वेस्टिगेशन ऑफ चॉइस क्या करोगे? आपको लीक देखनी है, परफोरेशन देखना है, इसोफेजियल परफोरेशन देखना है, साइट देखनी है, तो क्या करोगे? सो इफ द पेशेंट इज अनस्टेबल, you do a CT scan with iodinated oral contrast. Yes, Kavisha, patho is done. Patho was done in the morning today. So morning session was patho followed by ophtha, and this is radiology. If we see pneumoperitoneum, do we need to do fast and CT scan? No. If you are seeing pneumoperitoneum on chest X-ray, directly take the patient in the OT. Chalo, next important barium swallows. So first is dysphagia plus halitosis. ठीक है, diagnosis is Zenker's diverticulum. Second is dysphagia to liquids more than solids, bird beak appearance, eclasia cardia, investigation gold standard, esophageal manometry. Third, dysphagia to solids more than liquids, rat tail appearance, CA esophagus. Investigation of choice, endoscopy, gold standard, biopsy. How to differentiate bird beak from rat tail? So you look at the irregularity. So if there is irregularity, that means it is a rat tail. If it is smooth, that means it is bird beak. Simple as that. ठीक है, स्मूथ है मतलब बिनाइन है, बिनाइन है मतलब एक्लेसिया है. अगर इर्रेगुलर है मतलब मेलिग्नेंट है, मेलिग्नेंट है मतलब कैंसर है, सीए इसोफेगस. फोर्थ इमेज, dysphagia plus chest pain. Sign, corkscrew esophagus. Diagnosis, diffuse esophageal spasm. ठीक है, पोएम भी कर लेंगे, ठीक है, एक्लेजिया में पोएम भी कर लेंगे। चलो, सिंगल बबल साइन किस में मिलता है? इन्फेंटाइल हाइपरट्रोफिक पाइलोरिक स्टेनोसिस। डबल बबल साइन किस में मिलता है? ड्यूडेनल एट्रीजिया। ट्रिपल बबल साइन मिलता है जेजुनल एट्रीजिया। एंड कॉफी बीन साइन किस में मिलता है? sigmoid volvulus. You get this in sigmoid volvulus. Okay, sorry for speaking in Hindi. I'm really sorry. I think a lot of students would not understand. I'm really sorry. I'll continue in English. Now tell me, what do you see here? So this is a neonate with respiratory distress syndrome who has this chest X-ray, right? So what do you see? You see that there is a scaphoid abdomen. You don't see any bowel loops inside the abdomen because all the bowel loops have herniated into the left chest. So what is the diagnosis? The diagnosis is congenital diaphragmatic hernia. Clinical features are neonate with respiratory distress syndrome, complication, pulmonary hypoplasia. Initial management में you do endotracheal intubation. So this is a disease which has to be diagnosed prenatally on antenatal ultrasound, and you have because you can't give bag and mask ventilation. Bag and mask ventilation is contraindicated here. ठीक है, positive pressure ventilation is contraindicated. You have to give an invasive pulmonary ventilation. चलो, next, bowel obstruction. Bowel obstruction में X-ray findings. You see air fluid levels. How many air fluid levels are significant? More than 3 are significant. So these are multiple air fluid levels that you see. Investigation of choice, CECT, contrast enhanced CT, because this tells us the transition zone. On another abdominal X-ray, what do you see? You see that the small bowel loops have complete septae because they are valvulae conniventis, whereas large bowel obstruction have incomplete septae because large bowel has Hofstra. Okay, two important signs. Tell me, this is the claw sign and coiled spring sign. Where is it seen? Diagnosis. ठीक है, string of pearl sign is also a sign on chest X-ray. Good. String of pearl sign is also seen on bowel obstruction. String of pearls. ठीक है, डायग्नोसिस है इसका इंटुसिसेप्शन. The diagnosis is intussusception. Investigation of choice in children is ultrasound. In adults, it is CECT, because adult intussusception is usually due to a leading point like a tumor, colon tumor, right? So you have to do a CT scan. A gold standard is barium enema. All right, now let's come to hydatid cyst. Honeycomb sign is seen in which stage? CE2 stage. So multiple daughter cyst is honeycomb sign. Water lily sign is CE3A. Hydatid sand is CE1 stage. So CE1 and CE2 are active stages. Okay. So treatment क्या है? Treatment, if it is CE1 stage, you can do pair. But if it is CE2 stage, you have to do surgery. you have to do surgery. ठीक है, CE3 water lily sign, this is the most common question which was asked, but I don't think anymore it will be asked. You'll be asked honeycomb sign or a unilocular cyst, and treatment is pair. If CE1 and CE2 stage, you do surgery. Okay, so why pair in CE1 stage? So what is pair? So in CE1 stage, let's understand hydrated cyst. Let me give some more time to hydrated cyst because it is an important topic, right? So hydrated cyst is caused by Echinococcus granularis, and it undergoes various stages. So whenever Echinococcus infection of the liver happens, the first stage it forms is a unilocular cyst, that is a single cyst. This is how a unilocular cyst appears, and we know that the endocyst of the hydrated is active layer. So this endocyst keeps on dividing like this, and with time it forms a CE2 stage. So multiple daughter cyst, this is known as a honeycomb sign. So multiple daughter cyst. Okay. Now what happens sometimes that this endocyst sort of separates from the main cyst. So this detached endocyst is known as a water lily sign. Water lily sign is nothing but a detached endocyst. Okay. And this CE2 stage, when it transforms into the CE3B stage, in which some of the cyst solidifies, whereas some of the cyst remains cystic. Okay, so these are the transition stages, CE3A and CE3B. And then CE4 and CE5 are inactive stages. CE4 mein the whole cyst solidifies. In CE5 the cyst undergoes calcification. Okay, so pair stands for puncture, aspiration, injection, and re-aspiration. So it is done in a CE1 stage. So in a CE1 stage, what do? We puncture this cyst with the help of a needle or a catheter, take out all the contents, aspirate, that is aspirate. Then we inject a scolicidal agent. What do we inject? We inject absolute alcohol. Absolute alcohol burns the endocyst, and then we re-aspirate this sclerosant, re-aspirate this scolicidal agent. This whole is known as puncture, aspiration, injection, and re-aspiration pair. It is only done in C1 stage when the whole cyst is a unilocular cyst. When multiple cyst forms, you can't put in a catheter in each and every one, right? So the only option you have now is a cystectomy, right? So you take out the cyst along with the endocyst, and that is a surgical excision. That is a surgical excision. Now let's come to gallbladder pathologies. So the first pathology that we will read is a gallbladder polyp. Now gallbladder polyp appears as an echogenic structure, but there is no posterior acoustic shadowing. No posterior acoustic shadowing. Okay, and most of them are followed up. When do you do a surgery? If it is more than 10 mm, only those polyps you do a cholecystectomy. Second disease that we will read is polylithiasis or a CBD stone. Again, you will see echogenic lesions, but now they will show this posterior acoustic shadowing. Okay, so here posterior acoustic shadowing is present. See the chat, my phone is dead. Now, when do you say that this polylithiasis is cholecystitis? That is, the gallbladder is inflamed. When the wall thickness is more than 3 mm, there are stones present, and there is this pericholecystic halo. Sometimes you see fluid in between the wall and the liver. This pericholecystic halo, this suggests that there is inflammation going on, and this suggests it is cholecystitis. And what type of cholecystitis? Acute cholecystitis. Another sign that you get in acute cholecystitis is a sonographic Murphy's sign. Now, chronic cholecystitis, you get an important sign known as West sign. West stands for wall echo shadow complex, right? So this is seen in chronic cholecystitis. Now, what is the third spotter? Third image is that of gallbladder adenomyomatosis. Gallbladder adenomyomatosis. And what is the name of the sign? It is comet tail sign. Comet tail sign. What is sonographic Murphy sign? So sonographic Murphy sign क्या था पहले बात? Murphy sign was if you palpate the right upper quadrant, there is tenderness when the patient takes a deep breath. You ask the patient to take a deep breath, and on palpation there is tenderness. Why? Because the surface, the serosa of the gallbladder is touching the parietal peritoneum. Similar is sonographic Murphy sign. So you press the right upper quadrant with your ultrasound probe, and if there is tenderness on ultrasound probe pressure, that is your sonographic Murphy sign. ठीक है, चलो let's move on to the other bile duct pathologies. So what is this investigation? This is ERCP, and what is it showing? This is showing filling defects. This is a CBD stone. What is this second modality? This is MRCP. You can see that the CBD is dilated. There is IHBRD or intrahepatic biliary radical dilatation, and in the dilated CBD you see a filling defect or a hypointense defect. This is again a CBD stone. A third modality is again an ERCP. It is showing beaded appearance of biliary tree. Seen in diagnosis is primary sclerosing cholangitis. No, it is not EHBA. The diagnosis is primary sclerosing cholangitis. Beaded appearance क्या होता है कि stricture and dilatation. Again, stricture and dilatation. This alternating stricture and dilatation, this is known as beaded appearance of biliary tree. Can you tell me beaded appearance और कहाँ मिलती है? Beaded appearance of artery is seen in beaded appearance of artery किसमें मिलती है? रीनल आर्टरी स्टेनोसिस तो मिलती है, बट कौन सा कॉज ऑफ रीनल आर्टरी स्टेनोसिस? नॉट फाइब्रोमाइल्जिया, नो, it is fibromuscular dysplasia, not fibromyalgia. Yes, near, I think you wanted to say fibromuscular dysplasia, but this is not fibromyalgia. कोलिडोकल सिफ्ट कैसे दिखता है? ओके, कोलिडोकल सिफ्ट में the cyst shows fusiform dilatation. देखो कोलिडोकल सिफ्ट में फ्यूजिफॉर्म डायलिटेशन मिलती है हमें सिस्ट की, और कोई फिलिंग डिफेक्ट नहीं मिलेगा. फिलिंग डिफेक्ट इसमें सीबीडी स्टोन शायद पड़ा हो ड्यू टू लॉन्ग स्टैंडिंग स्टैसिस, बट यू डोंट सी अ सीबीडी स्टोन in a cholecystitis. So this is how a cholecystitis appears, right? A fusiform dilatation of the whole CBD. See again another image. This is a fusiform dilatation of the bile duct. This is choledochal cyst. Chalo, let's come back. Now let's move on to genitourinary system. So similar looking images. What is the modality? First tell me what is the modality. Modality number 1, number 2 and number 3. So this is a plain KUB X-ray. What is the diagnosis? Diagnosis is bilateral staghorn calculus. Second क्या है? Yes, second is an IVP. Second is an IVP, and what do you see? You see that the lower pole of both the kidneys are fused together. Diagnosis: horseshoe kidney. Right? What is the name of the sign? Flower vase sign. Flower vase appearance, also known as shaking hand appearance. Shaking hand appearance. What is the third modality? Is it an MCU or an IVP? Shravanti, what is the third modality? Is it an IVP or is it an MCU? MCU, MCU, MCU. Tushar Priya Gautam is asking if we see a worm in the CBD, which is seen in flukes, liver flukes, right? So how do you see a worm? So I told you that stone is appear as a round filling defect. A worm is appears on an MRCP like a linear filling defect. So bile duct worm, let's see. Bile duct worm appear as a linear filling defect. ये देखो यहाँ पे MRCP में ERCP. This is an ERCP. You see a linear filling defect here, right? This whole linear filling defect. This is your worm inside the bile duct. ठीक है, चलो let's come back to our modality. So पहला modality is KUB X-ray. Why is it a KUB X-ray? Because I am not seeing any ureter. I am not seeing any bladder. That means it is a plain X-ray. Now in the second, I see that the renal calyces are opacified. These are the renal calyces, and if you look carefully, the renal outline is also seen. This is the nephrogram. So this is an IVP. That means that the contrast is getting excreted in the kidneys. Now what is the third modality? A lot of you are saying that this is an MCU. This is an MCU. No, this is not an MCU. MCU is what? Micturating cystourethrogram. So the patient has to micturate. And whenever the patient micturates, what happens? You see a urethra. You see a urethra. You're not seeing any urethra here. So this again is an IVP. This is not an MCU. This is a IVP. Good, Shravanti. Okay, this is an IVP. So the first modality, what is this diagnosis? You see that the right pelvic calyceal system is dilated, but the ureter is not dilated. So this is right PUJ obstruction. Whereas in second, this modality, this is also an IVP. What do you see here? You see that on the right hand side, only the lower calyces are opacified. and this is a special sign which is known, this is known as a drooping lily sign. Good. Shravanti, this is drooping lily sign, and where is it seen? This is seen in complete PCS duplication with obstructed upper moiety. Yes, duplex system with obstructed upper moiety. Why? Because the upper moiety inserts in the lower part of the bladder. Ectopic insertion होता है ना upper moiety का. Upper moiety is ectopic insertion, and that turns into a ureterocele, and that does not allow the urine to pass. So gradually over time, the upper moiety keeps on developing hydronephrosis, and becomes non-functioning. So when you do an IVP, the upper moiety does not excrete kidney because it is non-functioning. Only the lower moiety, which has a lower ureter, separate ureter opening, that gets opacified and appears like a drooping lily. This is known as Wiedgert-Mayer law. Good. Okay, Wiedgert-Mayer law. All right, let's move on to the next. Again, similar looking structure, similar looking pathologies. First, tell me the modality. So what is this first modality? I can see the kidney outline. I can see the pelvic calyceal system ureter. What is this modality? So first is IVP. Name of the sign is cobra head or adder head appearance, and diagnosis is bilateral ureterocele. Correct. What is the second modality? The second modality, also you can see the pelvic calyceal systems, you can see the bladder, but do not see any urethra. So what is this modality? Again, this is an IVP. Okay, good. This is an IVP. What is the sign? The sign is maiden wave deformity. That is, both the ureters are medially displaced and are hydronephrotic. Why? Because there is a retroperitoneal fibrosis. So this is seen in diagnosis, retroperitoneal fibrosis. This is also known as Ormond's disease. And it now comes under the umbrella of IgG4 disease. Now tell me the third modality. What is this third modality? So you see that bilateral pelvic calyceal systems are visualized. You can see the ureter, you can see the bladder, but you can also see the urethra. So there is only one modality in which you will be able to see the urethra, which is micturating cystourethrogram. So patient has to micturate on the table. Literally the patient micturates on the X-ray table, right? And you can see the urethra. So this modality is MCU. MCU is micturating cystourethrogram, also known as VCUG, voiding cystourethrogram. So what is this first diagnosis? You can see that the ureters are dilated, the renal pelvis is also dilated. So first diagnosis is vesico-ureteric reflux. And the second modality, in which you see that the bladder and the posterior urethra is dilated. This is posterior urethral valve. Right? And name of the sign is, as you have rightly mentioned, keyhole sign. All right. Okay. Now tell me these three diagnoses. Let's cut this out, not important. Blood attenuators, kuch nahi. Again, similar looking pathologies. What is the modality? So all of them, in all of these, you don't see any ureter. You don't see any bladder. You don't see ureter. You don't see bladder. You don't see ureter. You don't see bladder. This cannot be IBP. This cannot be MCU because there is no bladder. So this is a plain KUB X-ray. All of these are plain KUB radiographs. ठीक है, पहले में क्या दिख रहा है आपको? You see the calcification. In the first one, you see calcification in the shape of renal calyces. So these are bilateral staghorn calculi. Modality of keyhole. Modality to is same, right? Modality is MCU only. Patient is micturating, right? MCU. Screw-wide stone, staghorn calculi, whatever. What is this diagnosis in the second? In the second, you see calcifications in the shape of the renal cortex. So this is putty kidney. Seen in renal TB. And here you get sterile pyuria. Third is multiple calcifications in the shapes of renal medulla. So this is medullary nephrocalcinosis. And where do you see? You see this in hyperparathyroidism. Medullary nephrocalcinosis, hyperparathyroidism. ठीक है, similar looking X-ray is very different diagnosis. First, identify where the calcifications are located. So staghorn calculi will be in the shape of calyces. Calyx appear like this. Cortex calcification will outline the kidney, and medullary calcification will be the stippled calcifications. Okay, let's move on to the next. So we come to genitourinary trauma. Genitourinary trauma. Right, so first we are discussing bladder injuries. For bladder injury, investigation of choice is a CT cystogram. CT cystogram, right? So what do we see here? In the first image, I can see that the contrast is extravasating in the anterior abdominal wall. So this is extraperitoneal bladder injury. Whereas in the second image, the extravasated contrast is outlining the small bowel loops. So this is intraperitoneal bladder injury. Right, now what is a cystogram? What is a cystogram? So cystogram, as the name suggests, images the urinary bladder. So we put in a Foley's catheter, and through the Foley's catheter we inject diluted dye. So diluted urographin we inject, and we inject till the point when the patient feels pain, or overall a 300 ml of diluted dye we inject, and then we take a plain CT scan. So if there is a rupture of bladder, that dye will start leaking out, and depending on where this dye is leaking out, we can identify whether it's an extraperitoneal bladder injury or an intraperitoneal bladder injury. So extraperitoneal bladder injury is the base of the bladder and the anterior and lateral walls. So in that case, the contrast extravasates into the scrotum, anterior abdominal wall, and root of penis. So collection will be formed there, and extraperitoneal bladder injury is treated with prolonged Foley's catheterization. Prolonged Foley's catheterization, it heals on its own. Whereas intraperitoneal bladder injury is injury to the dome of the bladder, right? So whenever a full bladder has a blunt trauma, the dome ruptures, and that dome is intraperitoneal, so the contrast surrounds the small bowel loops. So that is why intraperitoneal bladder injury, you see contrast around the small bowel loops, and this is repaired surgically. So treatment here is surgery. That's why it is important to differentiate between an intra and an extraperitoneal bladder injury. Now, second is we'll read about urethral injuries. And for urethral injuries, investigation of choice is RGU. Okay? Investigation of choice is RGU. So in the first image, let's see the part of urethra. So just below the neck of the bladder, this is the prostatic urethra. Then a very small segment, this is the membranous urethra. This enlarged part is the bulbous, and then the penile shaft is your penile urethra. So first of all, most common site of urethral trauma is membranous urethra, right? And how does injury looks? So this is how the injury looks. You see there is contrast extravasation on the RGU. Now, what is the clinical feature? A clinical marker which will always be present in cases of a urethral injury is blood at meatus. Blood at meatus. So, protocol kya hai? What is the protocol? If there is blood at meatus, you do not insert a Foley's catheter, first of all. Okay, Foley's catheter is inserted as part of secondary survey. So you don't insert a Foley's catheter. You first do an RGU. Okay, if RGU is normal, you go ahead and insert a Foley's catheter, right, and do a cystogram. But if your RGU is abnormal, that is there is a contrast extravasation, then you go ahead and do a suprapubic cystostomy or a suprapubic catheterization, SPC. Okay, so this is the protocol of blood at meatus. Again, we look at the polycystic kidney disease. So in the first case, where you have large bilateral renal cysts plus liver cysts. So what is the diagnosis? This is ADPKD. If there are multiple small cysts, then this is ARPKD, and this also is known as a striated nephrogram. Now, if there are large cysts in a neonate plus a non-functioning kidney, and what is the diagnosis? And this is what is known as multicystic dysplastic kidney. RRR, reset, restart, refocus is asking how to differentiate between membranous and bulbar urethral injury. Yeah, depending upon the location. So bulbar part कौन सा होता है इसमें? This is the bulbar urethra. तो जो भी expanded सा part होता है ना थोड़ा सा, that is the bulbar urethra. So depending on the location, you have to identify. That's it. Okay, what is this diagnosis? Bilateral angiomyolipomas. Diagnosis is tuberous sclerosis. Second, beer paw sign Diagnosis is xanthogranulomatous pyelonephritis. Okay. Third, air in renal fossa, emphysematous pyelonephritis. Now MRI light bulb sign, where you get an MRI light bulb sign, your diagnosis is pheochromocytoma. Pheochromocytoma. So what is a light bulb sign? So pheochromocytoma is very bright on T2 weighted images. So this is a T2 weighted image. You can see that the suprarenal there is a mass, and this mass is very bright on T2 weighted image. Now why am I saying this is a T2 weighted image? Because CSF is white. So this is a T2 weighted scan. And on this scan, you can see that the suprarenal lesion is very bright. Again, similar lesion you can see on the corneal image. This suprarenal mass is very bright. This is a pheochromocytoma. So next question is asked. Investigation of choice to localize pheochromocytoma is MRI. But if it is specially asked, investigation of choice to localize extraadrenal pheo, then the answer is DOPA PET. And if this is not given, then MIBG. DOPA PET बहुत सारी जगह नहीं होता. So most of the books would mention MIBG, but DOPA PET is more sensitive than MIBG. DOTA-NOC नहीं है, DOTA-NOC नहीं है, remember. DOPA PET है. DOTA-NOC is for neuroendocrine. Chalo, let's come to nuclear medicine, and we'll finish this in the next few minutes. We'll finish it by 9. Okay. So concept क्या है modality में? We have 3 types of modality. One is a 2D scan, that is known as a scintigraphy, or a nuclear scan, or a radioisotope scan. So that is a normal 2D scan. We inject technetium-99m. It is taken up by the relevant organ, and we have a gamma camera which stays like this. It's a stationary camera. The rays come here and forms an image. This is a 2D image. So most common radioisotope used in scintigraphy is technetium-99m. Right? What is the half-life? Half-life is 6 hours, and it emits gamma rays. What is a detector? The detector is a gamma camera, also known as an Anger's camera. Whereas a 3D scan, 3D nuclear medicine scan is known as SPECT. This is a 3D scan, so it rotates around the patient like this. That's why known as a computed tomography. What is the full form? Single photon emission computed tomography. Now PET is a very different modality. PET does not use technetium-99m. What is the radioisotope that PET uses? First of all, full form is positron emission tomography. Radioisotope used is 18 fluorine. ठीक है, अभी आएंगे यूजेस पे आएंगे. ठीक है, 18 fluorine. This is the radioisotope, and it is incorporated into FDG, or 18 fluorodeoxyglucose. So one of the oxygen of the glucose molecule is removed, and it is replaced by 18 fluorine. So that's why the name 18 fluorodeoxyglucose. So the concept of nuclear medicine is that with this radioisotope, you attach a ligand. So let's say we are doing a PET scan. The 18 fluorine is the radioisotope, and the ligand is deoxyglucose. Right? So this travels to all the metabolically active places, and it lights up. Right? Now what is the principle? The principle is Warburg effect. Warburg effect. That is, preferentially there is glucose uptake by cancer cells. That is the Warburg effect. Now half-life of F18 is 110 minutes. And what test do you do? Since we are competing with the normal blood glucose, this 18 FDG is also a glucose. So we want that the normal glucose should not be very high. So test before PET scan is a random blood sugar. Right? And if RBS is more than 200, PET is abandoned. PET is not done. All right. Now let's see the various nuclear medicine scans. So DMSA scan is used to see renal scars. And which disease do we see renal scars? Vesico-ureteric reflux. Now DTPA is used for GFR estimation. Sometimes you are asked about captopril DTPA. Captopril DTPA is used to diagnose renal artery stenosis. Now MAG3 is for overall renal function. Okay, and hence it's also known as a renal dynamic scan. Renal dynamic scan. Now where is MAG3 used? This is used in cases of PUJ obstruction, in which we want to see what is the level of functioning of the particular kidney, because if that is a poor kidney, poorly functioning kidney, then we'll do a nephrectomy. Whereas if that POJ obstructed kidney has some function, then pyeloplasty is a good option. You can save that kidney by doing a pyeloplasty. So this decision is based on this MAG3 scan, also known as a renal dynamic scan. Now for cardiac nuclear medicine scans, what do we have? For perfusion and ischemia, thallium scan, SESTA may be SPECT, and tetrophosmin scan. For myocardial viability, we have FDG PET. For ejection fraction and left ventricle function, we use Muga scan, but Muga scan is no more used. The best modality for ejection fraction is cardiac MR. Now on MI, hotspot is seen on. So what is the concept of this? So I told you that for myocardial viability, we use FDG PET. So let's see a normal FDG PET. A normal FDG PET looks like this. Right, so in a normal FDG PET, you will see that there is good uptake in the brain, some gland, sometimes heart, brain, heart, kidneys, bladder, and intestines. These show normal uptake on PET scan. So I told you heart shows normal uptake. So this property is used to see myocardial viability. So wherever the heart is infarcted or scarred, the FDG uptake will not be there. So areas of myocardial infarction appears as cold spots. Cold spots meaning they don't show uptake. Areas of myocardial infarction appears as cold spots on FDG PET. And let me show you a FDG PET. See this? This arrow is pointing towards a part of the heart which is not showing PET. That means this part is infarcted, right? And so the best modality for myocardial viability is FDG PET. Now there is one nuclear medicine scan in which FDG PET में तो क्या हो रहा था, cold spot की तरह हो रहा था, but एक nuclear medicine scan है जिसमें MI appears bright. That is MI myocardial infarction appears as hot spot. And what is that scan? That is a pyrophosphate pyrophosphate scan. Pyrophosphate scan. Okay, now let's come to bone scan. So bone scan mein what is the compound use? It is technetium 99M. MDP scan, methylene diphosphonate. What are the uses? So first of all, let's see stress fracture, bilateral stress fracture. Bilateral stress fracture. Can you name a sign? There is a sign known as Honda sign, asked in this year's INICT. Honda sign tells us sacral insufficiency fracture. Second are osteoblastic mets. Which cancer shows osteoblastic mets? Prostate. Now, any bony lesion, any lytic bony lesion, we assume them to be metastasis usually. And second differential is multiple myeloma. Now, bone scan may metastasis appears as bright, that is hot spot. But multiple myeloma appears as cold spot. Why? Because multiple myeloma have plasmacytic infiltrate. They are not osteoblastic activity. That's why cold spot on bone scan is seen on multiple myeloma. Multiple myeloma. Now biliary tree, what is the name of the scan? It is known as HIDA scan, and it is first used is in acute cholecystitis, but it is no longer used. No one uses HIDA scan nowadays. Acute cholecystitis ke liye we have ultrasound. Second is bile leaks. Now bile leaks we use MRCP and ERCP, so again HIDA scan is not used. And third is extrahepatic biliary atresia. Okay, extrahepatic biliary atresia ke liye also we don't use this. What do we use? We use intraoperative cholangiogram. Okay, next, parathyroid adenoma. Now for this we use technetium 99M scan, or we can use for technetium 99M CEFTA maybe scan. CEFTA maybe is the ligand which if taken up by the parathyroid adenoma, or if we want a 3D which is better than 2D, then we have CEFTA maybe SPECT. For Meckel's diverticulum, what is the scan that we use? We use a technetium pertechnate scan. Now for neuroendocrine tumor, we use somatostatin, receptor scintigraphy, also known as an SRS scan. This is also known as an octreotide scan. But a PET scan is much more commonly used now. And what is the name of this PET? This is DOTA-NOC PET. Okay, for neuroendocrine tumor, carcinoid, you use DOTA-NOC PET. Now for pheochromocytoma, we use MIBG or DOPA PET. For thyroid scan, we use iodine 123. For Parkinson's disease, again we use DOPA PET. This is a previous year question. Prostate cancer, which is the scan that we use for prostate cancer? Tell me. This is PSMA PET. PSMA stands for prostate specific membrane antigen. Okay, PSMA PET. Now, how do various scans appear on iodine 123? Iodine 123 scans हैं सारे. So normal is this uptake. If you have diffuse enlarged glands with diffuse increased uptake, that is a grave disease. Again, if you have diffuse enlarged glands, but some of the nodules are showing uptake, others are not showing, this is a toxic multinodular goiter. And if only one of the nodule is showing uptake, rest of the gland is not showing uptake, that means that's a solitary functioning nodule or a toxic adenoma. Right? So these are the important scans with respect to nuclear medicine. Now let's finish radiotherapy quickly and then we'll wind up today's session. Now radiotherapy we know deals with radiations. So first of all, what is the most common type? What is the most common radiation used in radiotherapy? These are X-rays. These are X-rays. All right. Now types of radiotherapy are what? You can do give radiotherapy from a distance. This is known as teletherapy. In Hindi we call it sikai. Right? Or you can put in some implants within the tumor. Let's say there is a breast tissue, you put in breast implants. There is a cervical cancer, you put in implants near the cervix. That is known as a brachytherapy. So brachytherapy uses implants. And third is a systemic therapy. Systemic therapy is injected intravenously and it is taken up by the cancer cells which die. The first type of therapy which is a teletherapy. The first type of therapy is a teletherapy. I've told you it uses either X-rays or it uses gamma rays. Now, X-rays are produced by linear accelerators. And gamma rays are produced by cobalt-60 machines. Now, second is a type of brachytherapy. Second type is brachytherapy. Now, brachytherapy may we use temporary implants and permanent implants both. So, what are the permanent implants? This is a question which is asked. So, you remember gold 198, cesium 131, and yttrium 90. Again, question is asked, which are the pure beta emitters? So, strontium, phosphorus, and yttrium. Right now, stereotactic radiosurgery is what? So, to target any tumor, let's say there is a brain tumor. You can either give radiations continuously, you can put in an implant, but in brain you can't put in an implant, especially if these are vital organs, you can't put in an implant. For these vital structures, what do? We target these structures using radiations from various directions. So at a particular point, the radiation will be so high that that part will be burned like a knife. This is known as a gamma knife. Now, gamma knife, as the name suggests, uses gamma rays and it is used in intracranial neoplasms. Okay, like CP angle tumors or brain AVMs, intracranial or cerebral AVMs. Second is a cyber knife. Now, cyber knife uses an X-rays and it is used to treat lung cancer, liver cancer. Right? So, gamma knife uses a frame. You write down here only, gamma knife uses a frame known as a Lexell frame. And this is how a Lexell frame looks like. This frame is the Lexell frame and this is the gamma machine. This is the gamma knife. Right? Now, what does a cyber knife use? Cyber knife uses a robotic arm. So this is the cyber knife. and this is the robotic arm which is pointing towards a particular location. So this, in this case, it's treating a lung cancer. Now, what is the third type of stereotactic radiosurgery? It is proton beam radiosurgery. And in proton beam, you just remember, it shows Bragg peak effect. It shows Bragg peak effect. Now, this is a Bragg peak effect. Normally, the intensity of radiation is maximum near the surface and it gradually decays down. But in proton beams, what happens? The proton beam's intensity is maximum at a distance from the skin surface. Why? Because when the rays, proton beams, travel the skin surface, their velocity slows down, and as the velocity slows down, their energy rises. This is a peculiar phenomena, Bragg peak effect, which is shown by proton beam radiotherapy. Okay. Now, what is a fractionated radiotherapy? This is again a term which is asked, fractionated radiotherapy. Now, this whole dose of teletherapy cannot be given in a single setting, right? Because then the normal cells and the abnormal cells both will die. So you give the total dose in divided doses. Each dose, each division is known as a fraction. Now, what is a regular fractionation? Regular fractionation is you give per fraction 1.8 to 2.4 gray. You give one fraction per day, and you give radiotherapy 5 days in a week. Right? So Saturday and Sundays are off. So you give from Monday to Friday, and Saturday, Sundays are off. You don't give any radiotherapy. So what happens in Saturday and Sundays? The normal cells which have normal DNA repair mechanism, they heal themselves, and the cancerous cells which have an abnormal DNA repair mechanism, they die off. So fractionation allows normal cells to repopulate, to regrow, to repair. Okay. Now, what is a hypofractionation? What is a hypofractionation? Hypo meaning less. So we are giving less fractions. So what will happen in hypofractionation? If your total fractions are less, then the per fraction dose will be high. So in hypofractionation, per fraction dose is more than 2.4 gray. But again, we are giving one fraction per day and 5 days a week. So since total fractions are less, per fraction dose is high. And what do we do in hyperfractionation? Hyperfractionation is the number of fractions are more. So per fraction dose is less than 1.8 gray. Again, we are giving one dose per day and giving 5 days a week. So that is all regarding radiotherapy. Rapid quick revision of radiotherapy. Right, there are few other important spotters. There are few other important spotters which are important from radiotherapy. So a question comes regarding pure beta emitters, which we've already covered. They're yttrium, phosphorus, strontium. Again, something that you have to memorize. So I'm not spending a lot of time. Again, beta plus gamma emitters are gold, iodine 131, and radium. And important half-life of important isotopes. So remember, technetium 99M, half-life is 6 hours. 18F 110 minutes, and for all the iodine radioisotopes, half-life is important. So how do I remember? 12 into 5, 60 days. 3 को I turn into 8, so 8 days. 13.2 is 2.3 hours, and 123 is 13 hours. Right? Now, what are the recommended dose? These are again standard questions. So just I made you a table for this. This is a table for recommended dose limits according to AERB. Right? So we have many workers present in the radiology department. A patient comes for getting a scan done. There is a radiographer which acquires a CT. There is a radiologist which reports a CT. Right? So what is the dose limit for all these workers? So if a patient comes to the radiology department to get, let's say, X-ray or a CT scan, basically any X-ray based modality, what are the dose limits? So per se, there is no dose limit defined, because you can't refuse an X-ray or a CT scan based on his past history. So let's say he has a pulmonary embolism, you can't refuse a chest CT, right, or a CT pulmonary angiogram. So as such, there is no dose limit which is defined. But if you have to mark an answer, it is 50 millisieverts per year for a patient. Now, if it's an occupational worker like a radiologist, like a radiographer who works in the radiology department, his per year cutoffs or dose limits are a little less than patients. Per year, less than 20 millisieverts, or in a 5-year period, it should not exceed 100 millisieverts. Now, if the patient is pregnant, his dose limit is high, 5 millisieverts, but less than the normal patient, because pregnancy we avoid giving X-rays, right? What is the dose limit which is defined? 5 millisieverts. But if the healthcare worker working in the radiology department is pregnant, then her dose limit is even less than 2 millisieverts. And for general workers, that is workers who are, for example, patient attendants or patients who are traversing the radiology department, their dose limits are 1 millisieverts per year. 1 millisieverts per year. Okay, this is a very, very important table now. Radio sensitive versus radio resistant, which is the most radio sensitive, which is most radio resistant. Every time one question comes from this. So most radio sensitive cell cycle phase is G to M, more than M phase. Radio resistant phase is the S phase. If you're asked regarding organ, most radio sensitive organs are gonads. So your testes and ovaries, more radio sensitive. Vagina is resistant. Tissue, radio sensitive tissue is bone marrow, and radio resistant tissue is nervous tissue. Blood cell, leukocytes are radio sensitive, and platelets are radio resistant. And if you were asked basically overall cell types, so rapidly dividing cells are more radio sensitive. So for example, gut mucosa, blood endothelium, hair, they are much more radio sensitive, and radio resistant are non-dividing cells, right? That's why nervous tissue is very radio resistant, because it does not divide. Now finally, this is your lead apron. What is the minimum thickness? Minimum thickness recommended is 0.25 mm of lead, and most common thickness in lead aprons is 0.5 mm lead. Yes, Tanya, per term means per pregnancy. These limits are for per pregnancy. Okay, what is this? This is a TLD batch. This is a type of personal dosimeter, right? What is this made of? It is made of calcium sulfate, sorry, not barium sulfate. It is made of calcium sulfate doped in dysprosium, right? Personal dosimeter meaning it is attached below the lead apron. It is worn below lead apron, and it calculates or it records how much the radiation exposure that a person has gotten. That's why the name personal dosimeter. Now every 3 months it is sent to AERB, or Atomic Energy Regulatory Board, and they take out the film from that TLD batch and do something known as thermoluminescence. So they expose it to a laser, and what does the laser do? It jumps the electrons from the higher to a lower energy shell, and it emits radiations. So depending upon how much radiations this TLD batch is emitting, they can get to know how much the radiation exposure was there. So this is based on the phenomena of thermoluminescence. Now radiation units, again, let's just quickly revise. So radioactivity is measured in SI units as becquerel, so disintegrations per seconds, right? And conventional unit is curie. So 1 curie is a very big radioactivity. So usually in nuclear medicine, you will see them as millicurie, right? Millicurie. And becquerel is a very small entity. So most commonly, you will see gigabecquerels being used as a term. Now, exposure is coulombs per kg SI unit, and the conventional unit is Röntgen. Now, radiation absorbed dose, the conventional unit is rad, and the SI unit is gray. This is the most commonly used. So most X-rays, most CT scans will give you a radiation dose as a gray. इतने gray exposure है. Now humans को, radiologist को, patients को, what is the dose which they get? That is an equivalent dose. That is, what does the exposure does harm to us? And uski SI unit is sievert. The SI unit for equivalent dose and effective dose is sievert, and the conventional unit is rem. So what are the effective doses from routine diagnostic procedures? So from a chest X-ray, one chest X-ray gives 0.02 millisieverts. Mammography has a higher radiation dose than chest X-ray, 0.2 to 0.8. IVP around 3, you remember. Barium enema around 6. CT head is 2.3 and CT chest is 8. So one CT chest is equal to 400 chest X-rays. Correct? A bone scan is 4 and PET scan has a very high radiation dose of 22 millisieverts. Now what are the radiation effects? So two types of radiation effects are seen. So one are deterministic effects and another are stochastic effects. Now let's understand each of these. Now stochastic effects are what? Let's say you are exposed, you got a CT scan done. So CT scan has a very low dose, around, let's say if you're getting a CT head, its radiation dose is 2.3. So some tumors, some side effects happen irrespective of the dose amount, right? So they are dose independent. Even at a less dose, you can get these effects. Even at a high dose, you can get these effects. These are known as stochastic effects. That is, they are chance events. हो भी सकता है, नहीं भी हो सकता. And what are these? These are somatic mutation and cancers. Second type of effects are deterministic effects. They occur when a very high radiation is exposed. For example, a nuclear power plant blast, or a nuclear bomb attack. Very high radiation dose is exposed. And so what do you get? After a particular threshold, they start showing up. So below a threshold, no effects are seen. And above a threshold, effects start coming up. And above that threshold, the relation is linear. As the radiation exposure increases, the effects increases. Below a threshold, no effects are seen. So what are these effects? So these like skin erythema, cataracts, alopecia, infertility. They occur at a very high dose, and as the radiation exposure increases, their intensity or severity keeps on increasing. These are known as deterministic effects. So question directly can come that alopecia or skin epilation is a deterministic effect. Skin erythema is a deterministic effect. Okay, and last thing, acute radiation syndromes. So I told you that rapidly dividing cells are very radio sensitive. So the first syndrome that you get whenever a large radiation is exposed, it is a hematological syndrome. That is, your WBCs starts falling, right? And they occur at a radiation dose of 2 to 8 gray. And death due to a hematological syndrome occurs within 2 months. Now GI syndromes occur due to injury to gastrointestinal mucosa, which is again a rapidly dividing cell, and they occur at a threshold of 5 to 12 gray. And death due to these occur less than 2 weeks. And the last to get affected is the nervous tissue, cerebrovascular syndrome, occurring at a very high radiation dose, and the death occurs within 2 days. Very severe, very high dose. So this is all from my side. With this, we finish our NEET PG Radiology Marathon. We have covered everything in short, in crisp, so that you revise very fresh before your NEET PG, right? So this was intended for the 15th June exam, but now we will have a new date, hopefully. So you can keep this handy. I'll share this on the Telegram group of Sankalp NEET PG batch. You can download it from there, right? So thank you so much for attending. Thank you so much for being so patient. And tomorrow again we'll have another set of classes. Tomorrow there is Obs and Gynae, and one more, I forgot what other subject is there. So again we'll have 2 more sessions tomorrow, and all the very best for the upcoming NEET PG, which likely will happen in July. All the very best. Bye bye and good night.